Well, good morning, everyone. Sorry for that brief delay. And welcome to the third annual Homewood Mental Health Symposium. It's really great to see you all here this morning. For whether you're joining here in person or connecting in virtually online from across the country, thank you so much for taking the time to join us here this morning. Thank you for your dedication to continuing education and for your dedication, of course, to optimizing patient care and improving lives every day through the work that you do. For those that don't know me, my name is Carlos Lalonde. I'm a psychiatrist here in Guelph. I'm also an associate professor at McMaster University and a proud McMaster graduate myself. My current role at Homewood is that I'm the president and chief of staff at Homewood Health Center in Guelph and executive vice president medical services for Homewood Health across the country. The idea of this mental health symposium was really born a number of years ago, kind of in the midst of the pandemic, as we were really starting to see the severe impact that the pandemic was having on mental health and addiction disorders across the country. We started to hear more and more from our community partners about the challenges that they were facing in primary care and the increase in severity, frequency, and complexity of the mental health and addictions issues they're dealing with in their practices. At the same time, we also know we were struggling across the country with accessing mental health resources, as well as having limited opportunities for continuing education and training. We saw this as an opportunity to pull on the expertise that we have internally at the health center to meet those identified community needs and offer a free, full-day, fully accredited CME event tailored to meet the needs of primary care and other healthcare providers in the community, delivered by our internal panel and team of experts in mental health and addictions treatment at Homewood. The topic for today's event, the topics and the content for today's event, as has always been the case, has been tailored based on the identified needs of our community partners in primary care, with input from our esteemed steering committee, including Dr. Fryers in the corner, as well as input from previous year's events. So please make sure to fill out the feedback forms because it makes a difference. It allows us to tailor and customize and adapt based on your feedback for future events. It's been really great to see this event grow over the last few years since we launched 3 years ago. And I'm proud to share that this year we've set an attendance record that between the people that are joining here in person and the folks that have registered to attend online, we have well over 200 people from across the country attending today's event. And for the first time, I could say that we actually have registrants from every province across Ontario, plus a couple from the Yukon. So I'm really proud to see this event grow, and I'm hoping that it's a reflection of the quality of the presentations and that we are, in fact, hopefully meeting the needs that have been identified. I wanted to briefly share a heartfelt thank you to our planning and steering committees, again, to Dr. Doug and Lisa Fryers for joining the steering committee and providing the input from primary care. And to the many people who made today's event possible, Katrina, Amrita, Vikram, so many other people that were involved in making today's event a success. Thank you also, of course, to our presenters for sharing their expertise and experiences, and for all of you again for being here today. I just wanted to take a moment to acknowledge the land that we're on. Homewood Health Center and the Delta Hotel here in Guelph reside on the treaty lands in the territory of the Mississaugas of the Credit of the Anishinaabe First Nation. We recognize that we are settlers on this land where we live, work, and learn, and we acknowledge this is a gathering place. This gathering place is home to many past, present, and future First Nations, Inuit, and Métis people. Homewood Health respects the spiritual, cultural, and historical significance of this land, and we support the Truth and Reconciliation Commission of Canada's calls to action. As an organization, we commit to a path of continued learning, reflection, and ongoing efforts to strengthen our relationship with Indigenous people. So given this is an accredited event, we have to have all of our disclosure slides, so we could get used to this now, but this will be very brief. I'm employed by Homewood. I'm not receiving any other type of honoraria for my involvement today, and I'm not on anyone's else's payroll at this point. Now that we know of, that I'll admit to in public. And once again, this is fun. This is This event is funded by Homewood Health, and there's no other sponsors, including pharma, for this event. By the end of the day, in terms of objectives, I'm hoping that attendees for today's event will be able to understand and evaluate prevalent mental health issues that they're facing and they're dealing with in their practices, be able to formulate an inclusive treatment strategy based on current evidence and clinical practice guidelines, as well as identify incidences where it might be more appropriate for referral to specialized psychiatry or other mental health providers. This is a brief overview of the schedule for today. I think we made the adjustment to the schedule. There might be a bit different than the one you have in your folders. We shortened the break this morning from 30 minutes to 15 minutes, so from 10:30 to 10:45, as well as shortening the lunch a little bit from 11:45 to 12:30, so that we could actually slot in a break in the afternoon, which I'm guessing that everybody's going to want and need at that point. Please participate as much as possible. We value your contributions and your feedback and your questions. Each one of the sessions today is going to be an hour long. There'll be 15 minutes reserved at the end of each presentation for questions. And please, again, take the time to complete your feedback forms. For the folks that are attending in person, there's a number of feedback forms for every session in the folder. And if you could kind of do them at the end of each session, it'll probably be most accurate to do them in closer proximity to the end of each session, and then hand them in at the end of the day. That would be great. For those attending online, you'll be sent a link, I believe, to be able to complete those evaluation forms. And at this point, I'm very happy and honored to be introducing the CEO of Homewood Health, Jaclyn Pike. I actually have a very long and impressive bio in my hand that I was clearly instructed not to read to you all this morning. So if you're interested, you could easily Google search Jaclyn Pike. Very impressive list of awards, accolades, and accomplishments. But more than this, more than her list of accomplishments are able to reflect, Jaclyn has been with Homewood for more than a decade. Prior to that, she spent about 20 or so years in media and in law. But again, more than her professional accomplishments, I could say that Jaclyn is incredibly passionate about the important and impactful work that we do in providing high quality patient care and being involved in important medical education events like today and in supporting the needs of the community. So please join me in welcoming Jaclyn.
Thank you, Carlos, and good morning. And thank you, Carlos, for not reading the CV. Holy cow, you had a whole page. And I said, who wants to hear that at literally 9 o'clock in the morning? Plus, I'm one of those people that likes everything except talking about herself. So that was a very selfish request, Carlos, and I'm really appreciative that you complied. So welcome, and I'll try not to double up on some of the things that Carlos said. This is the third symposium. I think the prior two have had tremendous feedback and response, and by the growing, I think, attendance list, I think everyone is telling us that this is a good thing to do. So Homewood's been at this for over 140 years. Proud history here in Guelph, doing obviously a lot of work in Ontario, and then increasingly nationally. We like to think, and I don't know we are, a leader in mental health care. Our mission has been to transform lives by providing compassionate, accessible, and innovative care to those in need. At the heart of this mission is a significant and enduring commitment to the well-being of Canadians. And given what's happening right now in the world, the well-being of Canadians, and I think everyone across the world needs ever more support, especially when it comes to mental health. We are honored that millions have trusted us to guide their paths to recovery. In shaping the future of mental health, we made a very conscious decision about a year plus ago to put an increased focus on women's mental health through research and treatment. Homewood is collaborating with Dr. Benicio Fry, who's the inaugural Homewood Chair in Women's Mental Health and Depression, to rapidly translate research into clinical practice. This alliance, together with our recently launched Women's Trauma and Concurrent program, will bridge major gaps in treatment for a population that seriously needs significant support and support that's relevant to women. We are also forging new, meaningful partnerships locally and nationally. I'm really, really pleased to announce that Homewood Health has been selected to be the official mental health services provider to Team Canada. So all of our Olympic athletes, as well as the Canadian Olympic Committee and their families with a comprehensive range of mental health supports and services. It's a, I think, special partnership, and we're already obviously working with the COC on preparations for the Winter Olympics in Milano Cortina, and then also, of course, the upcoming Summer Olympics in LA. In addition to that, we've also recently been selected as a core services partner for Warrior Health. It's a new initiative funded by the province of Ontario in supporting mental health services for first responders, so for all police, firefighters, paramedics, and correctional officers and their families in Ontario. Very proud of that. It is a really unique technology platform available to that population. It was actually built by Homewood's technology team working closely with our clinicians. We are very proud of it. It actually just went live yesterday. Even closer to home, we have forged a multi-year partnership with the University of Guelph, somewhere right across the street here, to elevate student mental well-being and women's athletics. So back to the symposium. As Carlos said, we really believe this is a partnership with you, the primary care community. We are committed to supporting your educational needs by increasing access to education and resources on mental health and addiction treatment. With the increased prevalence of mental health disorders nationally, enhancing mental health education in primary care practice is even more critical. Your role in supporting mental health is essential. As frontline care providers, you are uniquely positioned to identify early signs of illness and facilitate intervention. By managing the complexities of mental health care can be a daunting task, as we know. It's chronic underfunding and continued lack of access to specialists. Through knowledge transfer, through opportunities for conversation and peer networking, we want to help you make informed decisions while challenging and changing perceptions about accessing care. We believe that by bringing together experts and those with lived experience, we can foster meaningful conversations and drive progress. So today's program, which I think is a great one, we are excited to present an all-female panel of distinguished experts delivering presentations on a variety of topics. The selection of this panel underscores our commitment to amplifying women's voices in mental health care and research. Women have been historically underrepresented, and we aim to create more avenues to highlight their invaluable contributions and perspectives. Our panelists bring a wealth of knowledge and experience, and I know their insights will inspire change. To our presenters, Dr. Margaret McKinnon, Dr. Jaclyn Kukat, Dr. Rhonda Taylor, Dr. Naomi Mudachi, Dr. Lisa Gagnon, Dr. Tara Riddell, Dr. Zainab Mohamed, that's a lot of doctors, and Brianna Martey, athlete and mental health advocate. I thank you for volunteering your time and expertise for today's event. I also, like Carlos, wish to acknowledge the leadership of the Symposium Steering Committee. A sincere thanks to Carlos, as well as Ben McCutcheon, Dr. Sharif Agali, for your commitment to supporting our primary care providers. Would also again like to express my gratitude to Dr. Doug Friars, Board Director of the Guelph Family Health Team, and Dr. Lisa Friars, a family physician in the Guelph community, for ensuring that educational needs and realities of primary care providers are reflected in today's learning objectives. Finally, I thank the Homewood Planning Committee for successfully executing today's event. I say that with the expectation that it will be successful. I have no doubt, because the prior two have been great. Your hard work is really very much appreciated, so congratulations. So last, thank you to all attendees for your dedication, your curiosity, your drive to advance patient care. We look forward to an inspiring and enlightening day of discussions. The increasing interest in our program highlights our collective dedication to improving health outcomes and addressing treatment gaps. Together, we can make a difference in the lives of those we serve and contribute to a healthier, more resilient Canada. And given the world today, resilience and building it is a really good thing. Thank you all very much.
I might need some technical assistance here. I can't seem to advance the slides. Okay. Great. Okay, so I'm very pleased to move on to our first presenter for today, Dr. Margaret McKinnon. And she'll be speaking to us about underexplored aspects of PTSD. Dr. McKinnon serves as the Homewood Research Chair in Mental Health and Trauma, and she's a full professor and associate chair of research in the Department of Psychiatry and Behavioral Neurosciences at McMaster University. As a clinician scientist, Dr. McKinnon is also appointed as a research lead for mental health and addictions at St. Joseph's Healthcare Hamilton, and is a senior scientist at Homewood Research Institute. Dr. McKinnon is known for her work characterizing trauma-related illness and PTSD among military members, veterans, public safety personnel, as well as survivors of childhood abuse and trauma. She's also involved in the development and testing of novel treatment interventions aimed at often under or unexplored aspects of PTSD and trauma, including guilt and shame, moral injury, dissociation, and cognitive dysfunction. Dr. McKinnon served as the chair of the federally funded PTSD Center of Excellence as a research reference group, and works closely with government sectors, including Veterans Affairs Canada and the Canadian Armed Forces. Dr. McKinnon has published more than 180 peer-reviewed papers and chapters, and holds funding from numerous federal and provincial bodies, including the Public Health Agency of Canada, the Canadian Institutes of Health Research, and the Canadian Institute of Military and Veterans Health Research, National Defence, VAC, and Workers' Safety Insurance Board of Ontario, or WSIB. So please join me in welcoming Dr. McKinnon to the stage.
We're just getting the timer up, so
okay, sure.
And then it should merge. Okay.
Having a small technical difficulty.
Figure out what's going on here, but we can also just
You can just advance slides. Sure,
yeah.
that's fine.
So we can follow along.
So good morning. I'm very honored to be here today as the Homewood Research Chair in Mental Health and Trauma, which is really, it's been sponsored by Homewood Health, Homewood Research Institute, McMaster University, and St. Joseph's Healthcare Hamilton. I also want to begin by disclosing, I'm actually a person with lived experience of PTSD as well. About close to 25 years ago, I was traveling on board a plane, my honeymoon towards Lisbon, Portugal, and it ran out of fuel midway over the Atlantic. And I will tell you that after that event, I did develop PTSD. I received very effective mental health treatment for that. And I'm very grateful to be here. And I will also say that my family doc, Melissa Schurter, who is amazing in Cambridge, she's been a big part of maintaining my mental health and my recovery. So I just want to acknowledge all the contributions that all of you also make every day to mental health and well-being. So thank you. So I'm going to turn to the first slide. What I'd like to do today is review underexplored aspects of PTSD. I'm also going to focus on giving you some tools that may be helpful to you and your family, but also to your patients as well. But before we get started, I will recognize that McMaster University is located on the traditional territories of the Mississauga and Haudenosaunee nations. It lies within the lands protected with the Dish with One Spoon Wampum Belt Agreement. And in doing so, I really want to acknowledge that special relationship of the Indigenous peoples to the lands and to pledge to work together with Indigenous peoples to ensure that the gifts of all peoples are recognized and honored. I have no conflicts of interest and no other disclosures to make. I thought I'd just shorten that. So we know from Canadian research that nearly 65 to even 70% of Canadians are exposed to potentially psychologically traumatic events over the course of their lifetime. Statistics Canada just did a really good update on this to tell us what are what's the current picture surrounding PTSD in Canada. We know that the majority of these exposures stem from transportation accidents, physical assaults, which 1 in 5 Canadians will face during their lifetime, along with life-threatening illnesses. And we also know that the types of trauma exposure, as you'll know from your own clinical work, varies significantly between men and women, with women being more subject to sexual assault and sexual molestation, along with physical attack, being threatened with a weapon, and childhood physical abuse. We see among men higher exposure to sexual assault, similar to women, but also combat exposure. And I think that's something that we're going to be increasingly seeing in our practices in the years to come, as we look at global security threats and really prepare our healthcare system for the possibility of receiving casualties from abroad, from the Canadian Armed Forces. Also, childhood neglect and childhood physical abuse. I think it's also startling to read that nearly 1 in 5 Canadian women have experienced sexual assault in their lifetime. That's compared to about 5% of men. And again, 1 in 5 Canadian women have had other unwanted sexual experiences. One way of asking about this with our patients is to say, you know, I'm aware that many women have experienced sexual assault, unwanted sexual experiences. I'm just wondering if you may be one of those people. That's a way of normalizing it by saying that we know many women have experienced this, and we can ask in a gentle and compassionate manner, recognizing that 1 in 4 of our patients will have experienced this, female patients will have experienced this. And again, really pointing towards the need for trauma-informed care as well. So I really like to talk about the spectrum of response to trauma. And so we know that in the face of the exposure to a major traumatic event, the intensity of our response can vary. Many people in the aftermath of the trauma will experience symptoms such as recurrent thoughts, dreams or images, feelings of fear, anger, helplessness, and despair, increased vigilance. But this is a normal response to trauma. And I think it's really important for us to remind folks of that when they're exposed to a highly traumatic event. That could be wildfires, that could be exposures that are happening abroad, it could be any number of things. But these are normal characteristics responses that tend to resolve over the course of several weeks. So if we look at the longitudinal course of trauma response, it's one of primarily recovery. We see here that in the week following exposure to a highly traumatic event, about 94% of folks will be expressing these symptoms. By 3 months, it will be about half. By 9 months, decreasing. And then we do see those folks who, out many years later, about 1 in 4 will show continued traumatic response. I'd also like to say that the course of response to trauma is not linear, as this graph suggests. So we certainly know that PTSD, post-traumatic stress disorder, and other symptoms related to trauma exposure may be expressed with delayed response, so many years later, and may also recover, then decline and recover. It's really unfair to say to people that PTSD is treated and it's over and that's it. That's very seldom the case in trauma. I can speak to that from my own personal experience as well. So I want to tell you a little bit about some of the resources that we have available. This has been work that we've done with Homewood Health and Homewood Research Institutes through a financial contribution from the Public Health Agency of Canada. We were asked by the Public Health Agency of Canada to stand up a website to really support the mental health and well-being needs of all Canadians. It was intended initially for use during natural disasters and highly traumatic events like the wildfires. They're just beginning to rage across our country now. We saw the attacks in Vancouver, but I would argue that many of these resources are applicable for your patients now. So the first resource available on this website, and I have the URL here. It's really just being able to reach out across Canada for help. You can click on here based on your age, your geographic location, your professional groups, with healthcare workers and public safety personnel, as well as members of equity denied groups, including the LGBTQ2SIA+ community, members of the Métis, First Nations, and Inuit peoples, and so on. And so just we really like to talk about mental health literacy and knowing where to go for help. We also have a resource, which I think is really important in the context of talking about normal responses to trauma. So this is a model that was stood up by the Canadian Armed Forces. And the idea here is to be able to assess yourself, to look at whether you're having a normal reaction to trauma, whether you're reacting and need to start thinking about perhaps seeking help, whether you're injured and needing help, and whether you're critically ill. And we do have this model available on the website, which again, we've done in partnership with HRI and Homewood Health. We also have a personal mental health and wellness tool that I'm going to come back to in a moment, but these are evidence-based resources. This is the very, very early in trauma response. So this is not folks who need to be triaged necessarily into specialized care, into inpatient care, but this is someone who at 2 o'clock in the morning is coming home, for example, a first responder, a healthcare worker who's been exposed to something highly traumatic and looking for resources for assistance. And I just really wanted to show this to you, and I'm going to talk about it a little bit more throughout the presentation, because I always want to give resources as well when I talk about PTSD and trauma. So I just wanted to very briefly talk about acute stress disorder, just highlighting that this occurs within the first month of exposure to trauma, and recognizing that at least one of these symptoms is required. When these symptoms persist over the past 1 month, we're looking at a diagnosis of post-traumatic stress disorder. And I really know that all of you know this, which is why I'm not going to spend a lot of time on the diagnostic criteria for PTSD. But just to say that in the most recent survey in 2021 and 2023, about 8% of Canadians report having received a diagnosis of PTSD from a healthcare professional at any point in their life, telling us that nearly 1 in 10 of the patients that we see every day will have received a formal diagnosis of PTSD in their lifetime. About 6% report being currently diagnosed with PTSD. So I think that those numbers are high, and this is Stats Canada data, and I think it's reliable. It's a very large survey. I think it's something for us to really be thinking about when we think about seeing patients and the sort of questions that we want to be asking. I just lost my slides on the screen, so I'll ask for those to come back up if that's all right. Thanks. So you're all, of course, very familiar with PTSD and its manifestations, and things like difficulty talking about the trauma, being easily startled, negative alterations in mood, including guilt and shame. And I want to really argue that PTSD is not simply a fear-based disorder. I've had the real privilege of spending time with Romeo Dallaire. And I remember he has said numerous times to me, it is not fear. I am not afraid of being blown up in the streets of Canada or being attacked. I struggle with the guilt and shame that I experience around the circumstances in Rwanda where I was unable to intervene and assist. But she bravely did, defying the orders of the UN. And I'm going to argue throughout this presentation that PTSD goes well beyond fear as it's traditionally conceptualized. So one important thing, though, before we turn to that is to really talk about the dissociative subtype of PTSD. How many people are familiar with the dissociative subtype of PTSD? Somewhat familiar? Okay. So about 15 to 30% of individuals with PTSD will present with this dissociative subtype. And this involves significant dissociative symptoms, including depersonalization, which means feeling as if one is separated from one's own body, not present in the body, not present in the world around you. And also derealization, the feeling as though things around you are strange or unfamiliar. Having these sensations after a traumatic event can be really startling and really frightening for folks. It also occurs after repeated developmental trauma over the course of development. I'll never forget a friend of mine whose husband died suddenly called me and she fell over my body. I'm terrified. And this was a typical trauma response of dissociation. We often dissociate in circumstances where we can't escape from unescapable trauma. So the example would be during a physical attack, when one dissociates from one's body, which helps us not to feel pain and not to be present psychologically to an extent during that attack. In folks with a dissociative subtype of PTSD, these symptoms persist beyond the traumatic event and are present in their daily life. Having a dissociative diagnosis is associated with greater symptom severity, greater depression, alcohol abuse symptoms, and higher rates of psychiatric comorbidity. Some, but not all, studies suggest decreased or altered responsiveness to traditional therapies for PTSD. This is a different presentation, and you really want to be aware of this in your patients, to talk to them about it, and where appropriate, refer for appropriate treatment for this dissociative subtype. At times, these symptoms can be confused with psychotic spectrum symptoms. So oftentimes people are misdiagnosed with having psychotic symptoms, despite having a very episodic quality. So these are not present. It's not like psychosis continuously present. You're more often in this state than in a hyper-aroused state, but psychosis is different. I'll talk a bit about that. They may also be thought to be malingering, when in fact they're reporting well-documented symptoms of PTSD. So to give you a picture of what this looks like, we see the gentleman on your right, or on your left rather, and he's presenting with the very typical presentation of PTSD, that hyper-arousal presentation. He's re-experiencing likely the events that he's experienced in the combat theater. He may be irritable, easily startled, avoidant of places that remind him of the trauma. By contrast, and that's an emotional undermodulation, his emotions are not being modulated. In the dissociative subtype of PTSD, this gentleman says it all. This is the man or woman or non-binary individual who I would see in my office, and I would think, I'm really concerned about you as well, because these patients, again, tend to be much more ill, in times less treatment responsive, and they'll show those symptoms of depersonalization, derealization, numbing out, not experiencing sensations in their bodies, not being able to connect to others. I would give diagnoses to these folks, and they would often look at me with just that blank stare in their eyes, not engaged, not present. And this is 15 to 30% of patients with post-traumatic stress disorder. And so when we think about this, again, 70% of folks with PTSD are in that, show that hyperarousal of emotions, the hyper-monitoring of their internal states, vivid re-experiencing, just like this gentleman, whereas those in this with the dissociative subtype, which is now characterized in the Diagnostic and Statistical Manual for Mental Health Conditions, show depersonalization, derealization, and emotional detachment. And we also know that individuals with PTSD, this is another way of thinking about this, individuals with PTSD are not typically within what we call the window of tolerance. So if we think about arousal as being either elevated levels of arousal or lower levels of arousal, what we optimally want folks to be in is that window of tolerance, also now called the window of competence, where they're calm, alert, but not anxious. They're able to communicate, ready for problem solving and learning. For folks with that typical presentation of PTSD, they're within that zone of hyperarousal. Their sympathetic nervous system is in overactivation. You see heart rate increases. They're ready to move away from what they perceive as to be threats. Faster breathing, blood pressure increases under threat or perceived threat, with continuous defensive posturing, right? Being ready for the next thing to happen, right? Those with the dissociative subtype, is often they report being tired, they feel spacey, numbed out, not experiencing emotion, difficulty connecting with others. And they may also show even a dissociative collapse. So essentially freezing under threat, right? A shutdown response. And you often hear about this. I just came back from Lisbon. I was at a conference on terrorism and mass violence, and they were talking about the attacks in Las Vegas and how many individuals during those attacks froze. They were unable to move. And often those were the folks who also lost their lives because they were able to be attacked. And this is a very normal response. We see this, for example, among animals. So if a bird is under threat, it will often go limp and feign death in the mouth, for example, of a dog, because it's a way, again, of escaping inescapable stress. And this can give rise to a freezing response that can be maladaptive, but also is associated with tremendous guilt and shame. So for example, if you talk to public safety personnel like firefighters, police officers, paramedics, even healthcare workers. They may talk about freezing under threat. They weren't able to go in because they were frozen. And it's a normal physiological response to trauma. And that's a way of helping folks to cope with the guilt or shame that they may feel by talking about that normal physiological response that's being experienced. These are just some examples of folks with the dissociative subtype and how they describe their experiences. So I was outside of my body looking down on myself. It was too overwhelming to recall the traumatic memory. I was completely zoned out and I could not tell what I was feeling. I was looking down at my body while I was back reliving the car accident. So I just really encourage folks to be aware of this, to talk to your patients about it. Some of the things, I just will mention, this is some work that I've done with Ruslandius at Western. And so really looking at, but what are the brain-based mechanisms of this effect? So we see in folks with the hyperarousal presentation, you're seeing overactivation in emotional areas that are not being dampened down by higher level cortical reasons involved in thought, reasoning, and cognitive control. By contrast, in the dissociative subtype, what you see is actually overactivation in those cognitive areas. Control is too much dampening down of lower level limbic regions. So there's a brain-based signature as well for these two different subtypes of PTSD. So what are some of the things that we could do just, in the office to offer some tools for individuals who are presenting with the dissociative subtype? One tool that you'll probably be fairly familiar with is the grounding technique. So using our senses to help ground us in the moment. So we can, for example, imagine having our feet placed on the floor, feeling the sensation of our feet there, paying attention to that, feeling our roots grow out from our feet into the ground and grounding us in place. We can use candies, for example, or strong taste. So if one is highly dissociative, putting a candy in your mouth and paying attention to the sensation of that on your tongue, the taste that you're experiencing. We can also use sound, so paying attention to sounds, smells, so carrying with you smells that help to bring you back. But what's really important here is creating awareness, right? That people become aware of their dissociative symptoms and begin to learn that they have some control of whether or not they're dissociating or not dissociating. It is spontaneous, it does occur, it's a physiological response, but by gaining insight, we can help folks to manage these symptoms. All of these tools are available on the CanEmerge website. And there are animated videos to guide people through these exercises, which you could easily use in your practice. For some folks, the body scan can also be helpful. So scanning gradually through one's body and paying attention. But it's really important to remember with mindfulness and body scans, for folks who have experienced trauma to the body, it can be very, very difficult to be present in your body, right? So oftentimes when folks report chronic pain, and they also have a comorbid diagnosis of PTSD, they're often reporting pain in those regions of their bodies that suffered assault, even if we wouldn't necessarily ascribe a physiological reason for that. So in survivors of sexual assault, when they're triggered to recollect the memory, they may experience pain in their genitalia, for example, without a known cause for that pain. So if we're thinking about mindfulness, exercises like the body scan, it really needs to be done in a trauma-informed way. And there is guidance around this on the website, but also there's some really good books out there about mindfulness for trauma. And I would really encourage you just to take a look at those and recognizing your patients. We often talk about, building up our muscle, right? We always hear that in psychology and psychiatry and mental health. Sometimes what it is building up even a couple of seconds of tolerance, right? So many mental health conditions, they're not just a sad presentation of being down or dispirited. It's also the inability to experience positive emotions as well, right? So we often see, particularly in survivors of developmental trauma, that receiving a compliment, having someone say, you're amazing, you've done a good job, you look nice, that can actually feel very hurtful. It's hard, right? Because what you've heard growing up your whole life is you're dirty, you're shameful, you're not good enough, right? And so what we try to teach is, can you tolerate 1 second, 2 seconds of that feeling of pride in yourself, to tolerate a positive emotion? And that's, again, building up that muscle. And it can be very similar for being present in the body, building up gradually to be able to tolerate being present and aware of your body and your internal sensations. So I want to test very, very briefly. I wanted to give some tools and do a little bit of talking about underexplored aspects, but just to go back to, again, just this Canadian update on PTSD, knowing that in the present moment, if we were to screen all Canadians, approximately 1 in 10, again, would screen positive for PTSD. Important for us to know, right? I know oftentimes when I go in for a checkup, I receive scales about symptoms of depression, because I have a long-term history of depression. I did have, but we very seldom receive scales for PTSD, and yet 1 in 10 people would probably screen positive for it, right? And there are some really good scales out there for that. We certainly know that women are more likely to screen positive for PTSD than men. I have all these figures for you. I'm not going to read them out, but you're certainly welcome to review them in the package. Age, so younger Canadians are more likely to present with PTSD than older Canadians. Income, not surprisingly, being in the lowest third of household income is associated with higher rates of PTSD. Education, marital status, and the number one predictor of who develops PTSD in the face of trauma exposure is social support. Above and beyond treatment, above and beyond so many other things, it's the presence of social support. You know, we talk about social prescribing for patients. Certainly in the face of a trauma, we want to help people to be surrounded by other folks who understand them, who know them, who may have gone through similar experiences to them, providing that support. We also know that those in fair health, fair or poor health, are more likely to develop PTSD. It's often difficult to know where the chicken came before the egg, right? So we know, for example, many patients who have been treated in ICU, I believe it's about half go on to develop PTSD, for example, from that experience of treatment. Mental health, having a mood or anxiety disorder is not surprisingly associated with being more likely to screen positive for PTSD as well. I think this is interesting. So look at individuals who report heavy drinking in the past months. About 1 in 5 will screen positive for PTSD, compared to 10% of those who report less daily heavy drinking and 5% of those who report no heavy drinking. Interesting, I think. If you look at cannabis use, again, the figures are about 1 in 4 who report daily cannabis use are more likely to screen positive for PTSD. It could be that they're using their cannabis as a way of coping with their symptoms. That's one possibility. There could be risk factors associated with cannabis use. We don't really know the answer to that question, but I think we should always be inquisitive and questioning about the reasons why this occurs. When we look at general risk factors for the development of PTSD, and this is sort of global research surrounding this, we certainly know that our patients with a past history of psychiatric illness, in women, anxiety and depression, in men, symptoms of irritability, impulsiveness, and substance abuse. These are risk factors for the development of PTSD. A history of trauma exposure, so adverse childhood experiences, for example, a family history of psychopathology, lower levels of intellectual functioning, lower levels of educational attainment, and lower levels of socioeconomic status. So you can imagine the exposures that come in some cases from, struggling daily to feed and clothe your children, as an example. Oops, skip ahead. Oops, go back one. So it's really interesting. The past couple of years, it's emerged that dissociating during a highly traumatic event. So let's say, for example, that you are, you're in a car accident and you numb out, you're not present. You feel as if you're floating above your body. This is a very significant, in fact, the greatest risk factor for the development of PTSD in terms of what occurs during the event. So you want to be asking these questions, how did you respond when this was happening? What do you recall? It could be events that are more painful, that involve physical pain, that involve uncontrollable circumstances. So we know, for example, that a man-made disaster is going to be associated with higher rates of PTSD than a natural disaster. If you're involved in flooding or forest fires, this is terrible, and many people will develop PTSD, but you're less likely to develop PTSD than, for example, if you were a victim of the recent Vancouver attack, or if you were a victim of a man-made disaster. We also know that those that have severe impacts, such as frigid weather or severe weather conditions, these can also be associated with the development of PTSD. But again, man-made disasters being at higher risk. When we look after exposure to the trauma, individuals who have low social support, higher levels of initial symptoms immediately after the trauma, high levels of co-occurring adverse or stressful life experiences. So often, I would see patients who were struggling within their personal relationships. They were more likely to develop PTSD because they, in part, weren't receiving the support that they needed. Negative cognitive biases, memory disorganization, negative appraisals of the trauma and its sequelae, difficulties with emotion dysregulation are suppressing your emotion, and again, the continuing presence of dissociation. But I do want to talk here about the disproportionate impact of trauma on equity-denied groups. It's really important for us to acknowledge that we all come from multiple different identities, right? So I can stand before you today and say I'm a woman. My family settled in Guelph in the 1880s. I have a PhD. I work at McMaster University. But we all come from different identities, right? And so we always want to be thinking about our intersectional identity across our race and cultural identity, levels of income, sex and gender. And we certainly know that trauma tends to have disproportionate impact on members of equity-deserving groups. We also know that at this time, the moral arc of the universe is really, unfortunately, swinging away from justice. We're well aware of that, right? And if we think about what happened during the COVID-19 pandemic, for example, with the murder of George Floyd and the rise in social movements, it's really important for us to be aware of that impact of discrimination, harassment, and everyday indignities on individuals, and how that can give rise to symptoms that are very much similar to post-traumatic stress disorder or to PTSD itself. And that's called minority stress. And that's a concept we're really studying here at Homewood as well, is really looking at what is that, how does that disproportionate impact affect mental health? When we look at the COVID-19 pandemic, we certainly saw the combined effect of systemic racism and COVID-19 on racialized healthcare workers, and also higher rates of COVID-19 itself among individuals from equity-denied groups. We want to be thinking about this with respect to our work. It's tremendously important. I want to give you an example from this. We conducted interviews and ran symposiums across Canada talking about the mental health and well-being impacts of COVID-19. We were funded by $1 million donation from Homewood Health to Homewood Research Institute to start this work. And then we went on to develop many other additional resources. But this is Todd, and Todd is an occupational therapist in Toronto, and he's talking about the impact of the pandemic on his mental health and well-being, but he's talking about it from the perspective of his intersectional identity. And I want us to really pay close attention to what Todd says. I am forever grateful to him for what he talked about, because I think there's such important lessons to learn here. Oh, we just need some sound, sorry. This is Garvia Bailey, who's my friend and colleague, who is currently on CBC. She's amazing. We hired her to do the interview. She was incredible.
Was there a moment for each of you when you started to feel that feeling of we're in a place now that we've never been to, and you started to feel the personal risk of where we were in the pandemic, where you were in the work that you were doing? Was there a moment that you can think of that where that sort of the tides turned, let's call it that? I'll start with you, Todd.
I think that's a great question. Because there's multiple times that I felt that way. But I think it, to me, is the tide that turned was the convoy freedom protest that really threw me off guard, because speaking from my experience as a double minority, as an Asian man, but also as a gay man, two of those narrative that I have is going down to psychological safety because of COVID, being Asian, not a good time to be Asian. And then on top of that, being a gay man, but then the third thing that really came on board was the Convoy Freedom protest, that they were coming to Toronto on a particular weekend. And the messaging from my organization was, do not wear or identify yourself as a healthcare worker, just because you might be targeted. So that was a really turning point where it's like, what is going on in the state of the world, where there's three hats that I have, three identities, and I can't show all three perhaps, or it's not safe to have those three identities. So psychological safety was really at the foreground for me in my experience during that time. And that's a new social phenomenon. It's a triple minority, right? Where do you feel safe? Can you be yourself? It's like feeling of hiding oneself during this pandemic was really interesting, which highlighted that. So that was a really takeaway, where it's like, what is going on in the state of the world?
So again, I just want to thank Todd for what he has taught us through his words. We certainly know that there are everyday indignities associated, again, with being a member of an equity denied group, and these can give rise to traumatic response, which is very seldom acknowledged. I know we interviewed over 120 healthcare workers and close to 100 public safety personnel during the pandemic about its impact on mental health and well-being. And almost universally, folks said, nobody talked to me about this. Nobody talked to me about it when I sought mental health care. Nobody talked to me about it in my organization. Yet we had the murder of George Floyd. We had we are now currently facing so much injustice in the world. And so really, how do we ask these questions? How do we support individuals?
Was there a moment for...
Thank you, Garvia. I love Garvia. Okay, so we do actually have a module on canemerge.com, which teaches about minority stress, resilience, and inclusion. So it's not only risk factors, but also resilience and the benefits of belonging to community. This is actually a teaching course with 12 modules. And if you're interested in learning more about this, this is actually available on CanEmerge for you, along with referrals to evidence-based mental health approaches surrounding minority stress and racial inequities. I want to just turn back talking about adverse childhood experiences, just to go back into the office and think about what are some of the things tools that we can use in the office. And so it was really a finding back in 1998 that folks found startling, at least at the time, looking at about 17,000 members of a HMO in the US, and these numbers are very similar across Canada. And learning that so many folks reported experiencing adverse childhood experiences. So, for example, 30% of individuals, or nearly 1 in 3, reported physical abuse during childhood. 1 in 5, much in line with the numbers in Canada, supported sexual abuse during childhood. 1 in 4 reported being exposed to family alcohol abuse. And nearly 1 in 20 reported, or 1 in 10 rather, reported witnessing their mothers being battered during childhood. These numbers are similar in Canada, I will tell you that. There's certain professions that are associated with having a higher history of adverse childhood experiences. So the rates of exposure to childhood trauma among military members and veterans is nearly double in general. And we're starting to also see evidence of this among public safety personnel as well. And you can think about why this may be. So seeking structure, seeking family, seeking belonging. But I think it's important, again, for us to be aware of these numbers and say, I know many people have been exposed to, difficulties in childhood that might have involved physical abuse, sexual abuse. Again, I'm just wondering if that may have been you, if you have reason to be suspicious. There's very, I think, gentle and kind ways of asking these questions, but also providing assistance. Early life trauma is associated with very high rates of psychiatric comorbidity. I'm not going to go through this list, but I would just note that among individuals diagnosed with borderline personality disorder, which I think is one of the most stigmatizing and mental health diagnoses, we know that any type of sexual assault would be about 44% of individuals. Any type of abuse would be about 81%. Any type of neglect would be 90%. So, I was not a clinician who was keen to confer this diagnosis, I'll be honest about that. but it is conveyed. And I think one thing that we can say is, these are patterns of behavior that you learned during childhood. If you learn these patterns, we can help you to unlearn these as well, which I think is really important. My sister-in-law actually was diagnosed with borderline personality disorder, and she recently wrote a book on her experiences with it. And I can't imagine a person that I love more. So I just think really just addressing that, the high rates of trauma and understanding that, I think is really, really important. We can also think about, for example, why are things like sleep difficulties occurring in folks with a history of early life adversity? It's not actually, for some folks, it's not difficulty falling asleep. It's fear of being in bed, being afraid that that was the place where their trauma occurred, and it's difficult to get back into bed. Folks will say this during inpatient hospitalizations. I really can't sleep in the hospital because I am so afraid something is going to happen to me here. So asking these questions, right? What are your sleep difficulties related to? Certainly, we know among folks who present with repeated developmental trauma, what you might see is a very pressured or tangential presentation that can be mistaken, for example, for hypomania or being psychotically disorganized. Folks may be avoidant, shut down, and highly dissociated. And sometimes this can be confused with psychosis or obsessive traits. They may be very controlling. So, ideally, we offer people choices, right? Where would you like to sit in the office? How would you like to talk to me? Would you like me to look at you or not? Do you prefer to look away? They may be very hypersensitive to the intentions of individuals who are asking them questions. And they may overvalue the clinical relationship or become clingy or needy because they haven't had that consistent adult, essentially attachment figure, which in some ways we're mirroring and reteaching attachment. Sometimes these folks can look so highly symptomatic that they are labeled as factitious or malingering, and some may be simply terrified and look paranoid. So these are things that we can think about with the history of repeated developmental trauma in our patients. Also, just thinking about the mistrust due to previous instances of interpersonal betrayal and trauma, right? A lack of continuous self-identity, which was a way of coping, again, a way of coping in the past. We often think about traumatic symptoms is symptoms, negative consequences, but a way of reframing it for your patients is to talk about resilience. You learned to be this way because it helped you to survive. This was your resilient response. You've been resilient, and we're going to teach you different ways, but this is also resiliency that you're showing. I'm going to now just talk a little bit. I think that the best way sometimes to really learn and reflect is to think about our own experiences, right? So if we think about, for example, how some of us responded during the COVID-19 pandemic, we were on the inpatient units. We were seeing patients who were receiving care that was oftentimes futile. Elderly patients were being proned when they were denied, when they were refusing care, but POAs were requesting it. Folks were dying alone. We had to enforce rules that were incredibly difficult to reinforce. And I think for many of us, I think we did, I will be honest, like I struggled during that time. I was going into ICU units and COVID units, providing mental health supports to healthcare workers, and it was not easy. And so we were again asked by the Public Health Agency of Canada to stand up a website really focused on supporting the mental health and well-being needs of healthcare workers across Canada. This website is still active. There are many, many tools on it for healthcare professionals. But I do want to just turn your attention here to, we do have a trauma-informed training course on this website, which is free of charge, and it reviews some of the materials that I just talked about. But it's a module-based learning that you can do at your own pace. There are case studies and examples, reflection exercises. And so if anybody just wanted a bit of a refresher on trauma-informed care, this is actually here for you as well. So the larger argument of this talk has really been that we need to move beyond a fear-based conceptualization of PTSD. Recognizing, for example, that affective difficulties can also give rise to cognitive difficulties, predominantly alterations in executive functioning, memory, processing speed, and attention. And so oftentimes I do studies on treating cognitive dysfunction in PTSD. And people often say, I feel stupid. There's something wrong with me. I can't remember what to do. I can't learn new information. But in fact, this is a very typical presentation in PTSD. It's a symptom of PTSD and changes in brain functioning. And helping to provide that information and normalize that experience alone can be really healing for patients. And one of the first things we do in our treatment groups is we actually talk about, these difficulties with memory and attention, with cognitive functioning. Talk about going on the autopilot, so doing things automatically without paying attention. And how do we bring our mind back to the present moment and be present? And these are treatment groups that we've been running through research, randomized control trials. We also know that guilt and shame is widely reported in PTSD, but is seldom assessed. And we know, for example, that the most commonly cited reason, for, at least in the US, for seeking veterans mental health services is, in fact, feelings of guilt and shame, like Romeo Dallaire described. It's also the presence of guilt and shame in PTSD is highly associated with suicidality. So it's, again, something we want to be mindful of in our practices. I'm going to talk a little bit about moral distress and moral injury, and also thinking with our patients about that family context, including the impact of PTSD and trauma-related illnesses on partners and children, and that intergenerational transmission of trauma. I wish I could talk for longer because I love talking about this, but I will have to wrap up at some point. We also know that we have a long way to go with treatment of PTSD, right? So we're doing well, but we can also do better. So we know that about 40% of individuals show a non-response rate to standard CBT-based PTSD treatment. Looking at traditional trajectories and patterns of response to general psychotherapy, not specialized psychotherapy, but 58% of individuals show a non-response, are non-responders. We just learned in the past months that military and veteran samples actually show lower rates of treatment responsiveness to traditional PTSD treatment than do civilians. We also see high rates of treatment dropout for PTSD, including 1 in 3 military members who will drop out of treatment, along with discomfort among therapists in providing these treatments. So I would argue there's a high need for adjunctive treatments and for personalized medicine, looking at the symptom presentation of the patient before you. I want to show you this as well. These are old data, but they tend to hold true. So if we look at individuals coming into treatment for PTSD, this is showing their mean scores on a symptom severity measure. They come in at very high scores on this measure, but when they leave therapy, including traditional therapies for PTSD, in fact, they still remain above cutoff for a diagnosis of PTSD following treatment. We always talk about, you're coming in out here, we may be bringing you to here, but ideally we want to bring you back to here, right? And that's often the case for treatment for depression, for many mental health conditions. And I would argue that we want to add on additional facets of treatment that address these often underexplored aspects of PTSD. So dissociation, struggling with guilt and shame, struggling with cognitive difficulties, really help to bring people closer to here by using combination therapies, including medication, of course. So as I mentioned, we know that PTSD is more than just poor concentration. This is showing its impact upon the brain. We have developed, I'll tell you as well, that having cognitive dysfunction is actually associated with reduced response to CBT. It predicts response to fluoxetine and depression. And cognitive dysfunction is actually what people with depression describe as the most troubling symptom post-recovery. So cognitive difficulties in depression tend to linger even when people are euthymic or have recovered. And we know that these difficulties interfere with occupational and social functioning, along with health-related quality of life among individuals. I think the slide is missing, that's fine. We worked at Homewood Research Institute to develop a treatment for this, which again, we have available. We think it's really important because to date, there was no treatment for cognitive dysfunction in PTSD. I would like to talk just a little bit more, but I'd ask, but people prefer to ask questions. What would you prefer? I'm open to either, it's fine. Okay, to just do maybe 5 to 10 more minutes? Sorry. Okay, so I want to shift us now back to the COVID-19 pandemic, where we all saw that our mandates, our expectations, our roles changed overnight. And there really was a sense of uncertainty about how long this pandemic would last. I'm part of the leadership team at McMaster, and we would have phone calls every morning, and we would make decisions, and within 2 seconds to 2 minutes, those decisions had changed. And I'm sure many of you experienced that as well in your practices or in your leadership roles. Things were changing continuously. We also know that it was the first time in Canadian healthcare where we called 911, and in many parts of our country, there was no one to respond. So I spent a lot of time traveling across Canada during the pandemic and learning, for example, in Saskatchewan, they simply didn't have paramedics to dispatch. It didn't matter what the call was for, they just weren't there. And you can imagine the moral distress and moral injury associated with that, the guilt and the shame. We also know that having to don and doff, or rather don, protective equipment, paramedics would describe going to calls, and the time it took them to don their PPE, people would lose their lives due to heart attacks because they weren't able to intervene in a timely way. And this was happening in our hospitals as well. Again, we interviewed many people across the country to really understand this. But our patients were also, of course, experiencing the pandemic. And I just want to really echo the words of some patients during the pandemic with PTSD who said, "This is everything that I ever expected. Others now know what I live through every day, and I am fine." And so it's really important for us not to assume what folks' response is going to be to situations like this. For many people, they said, you know, other people know what I've gone through every day of my life, this hypervigilance, this, you know, fear and guilt or shame that I'm experiencing. So just something for us to remember, thinking about patients. We actually surveyed over 1,000 healthcare workers across the province. In the first wave of the pandemic, 1 in 4 already screened positive for a probable diagnosis of PTSD. By the end of the pandemic, it was 1 in 3 Canadian healthcare workers who screened positive for PTSD. We saw that 6 in 10 healthcare workers across Canada were reporting clinically significant levels of depression, anxiety, and stress, and 7 in 10 reported feeling numbed out or detached from other people, from their activities and from their surroundings. So what were some of the factors driving this? It will not surprise you that I'm going to come back to guilt and shame and moral injury. And I want to use the experiences of healthcare workers to illustrate that during the pandemic. So moral injury is a concept that was developed initially largely in the military. And so military members would come back from service and talk about, you know, looking into the eyes of other people was like looking into the eyes of the baby. They just couldn't possibly know my experiences. And I'm so concerned that if they could see inside of me and see inside of my soul, they would see a stain, and a stain that lingers upon me. And those are the words of veterans that we've interviewed around this concept. And it's really that struggle with guilt and shame around past experiences, but also a sense of betrayal by organizations or individuals who we feel have a duty of care to us. Oh, it was falling off. It's funny. So I'm going to now show you a video. This is Krishna, and I want to again thank her. She's talking about her experiences in long-term care during the pandemic. And I'd like you just to think about the concept of guilt, shame, and betrayal in this video, which is also available on Healthcare Salute.
I used to blame myself a lot. I was supposed to be their caretaker, and I couldn't take care of them because I couldn't even take care of myself. My name is Krisha. I'm an RPN, registered practical nurse, and I was also a nurse manager at a long-term care home. I help patients and staff with managing the symptoms of dementia. In early 2020, we were hearing the rumbles about COVID-19. There was a patient who had like a fever, a cough, and like their oxygen started going down. And we self-isolated that person. So the next day, we were all crying because we know exactly what was happening. We were not prepared. We didn't have PPE. All of our face shields were expired. All of our N95s were expired. We couldn't even reorder them. We didn't even have face masks. So we were kind of like, this is like, it's finally here. You know, we're so scared. Like, that was the first time ever in my career that I was scared. I was scared to be a nurse.
I'm sure many of us here in the audience can relate to this experience outside of the pandemic. And so we actually did quite a bit of work around the moral injury that I would argue Krishna is describing. So feeling that we had to act in a way or not act in a way that violated our moral or ethical values, witnessing inactions of someone else that violates our moral values, are experiencing a betrayal by a trusted authority, for example, not having face shields available or masks available. Never forget watching a video from a care home in Southwestern Ontario where the nurses were being told to put a tissue, a Kleenex over their face. We were already 2 months into the pandemic, right? So I think a lot of us do struggle with, those feelings of betrayal, but also that we weren't able to provide adequate care in many cases. We couldn't bring our patients in, we couldn't see them or touch them in some instances. This really is, I think, for many folks, a struggle around that, which I think we have a tendency to try to move past these experiences without talking about them. But I think it's really helpful to talk about them, to acknowledge that they happened, and also to query these experiences among one another and also among the individuals that we provide supports to. The presence of this guilt and shame and moral injury is associated with a host of different mental health consequences. Again, I won't go through all of these, but just to highlight the increases in substance use, suicidal risk, sleep disruption, the onset of PTSD, anxiety and depression, and so on, associated with moral injury. And what I want to show you is that, in fact, during the pandemic, we found that 1 in 2 Canadian healthcare workers were considering leaving their clinical positions. So just imagine if 1 in 2 of us left. And the Canadian healthcare system is already facing tremendous staffing shortages. And we found that the strongest driving reason for this during the pandemic was due to moral injury and moral distress. It explained the majority of variants of why people were planning to leave. We also found that together, moral injury and moral distress they had 87% of the variance in predicting PTSD. So those 1 in 3 Canadian healthcare workers with PTSD, the driving force of that was the presence of moral injury, moral distress, including betrayal, so anger-based betrayal. Finally, we found that increased organizational support was associated with reduction in moral injury and moral distress. So how can we best act as organizations to support healthcare workers? We have a lot of information about this on Healthcare Salute that I'll just refer you back to. So I'll end on that note, but I want to just say thank you for your service, for everything that you do. Really are the front line of mental health care, and we're just grateful to you for everything that you do. Thank you.
Thank you so much, Dr. McKinnon, for sharing your wisdom and experience and expertise with us here today. I'd like to open it up for questions for folks here in person and attending online. Any questions in the room? And I can't see the folks online. Oh, perfect. Great.
Hi, I'm Denisha Naidu. I work at the university and I do mental health work. This might be a bigger question than you can answer. But when you have someone with those dissociative PTSD symptoms, and you know that one of the things they need are supports, how do you help them overcome the fear of like betrayal and all the things that may have led to their PTSD so that they can safely make good supports? Does that make sense?
Yeah, it absolutely does. And thank you so much for the question. So I think part of it is there's a rule in trauma, the 80-20 rule. And the rule is that, 80% of what we're experiencing right now relates back to the past and 20% to the present moment. And I think bringing awareness is one part of this, right? So, as a mental health provider, as a healthcare provider, ideally we're mimicking an attachment relationship, right? We're reteaching, right? And being consistent, showing up, demonstrating concern, appropriate concern, empathic concern, but also making folks aware of how much of what is happening right now is being driven by the past, and peeling back that onion and saying, I'll never forget once I had to cancel an appointment with a patient and she phoned me screaming. And it was actually a really good therapeutic moment because I was able to say to her, what do you remember what happened to you in the past that felt like this before? What did I just trigger in you? Let's build some awareness around that. Let's build up, again, modeling those appropriate, caring attachment relationships. That's one thing I would start by saying. I think with dissociation, It is something that, again, awareness is a big part of it, right? Learning what dissociation is, being aware of when it's happening, what may be driving it, and then learning to control over that dissociation, right? Because with awareness, we begin to learn that we can come back from that as well and exercise control. And then finally receiving specialized treatment for sure.
Thank you. Margaret, when it comes to the dissociative subtype, I'm just wondering about kind of psychological treatment approaches. You mentioned focus on those grounding strategies, building the muscle and the tolerance gradually. But in terms of some of the psychotherapies that we typically employ, like cognitive processing therapy or EMDR or deep brain reorientation, are there certain approaches that in that scenario that have better evidence for dissociative subtype, or ones that you should avoid?
It's a great question. And Carlos, I would say there's very little evidence to make an evidence-informed response. A number of papers have shown similar responses in highly dissociative patients to cognitive processing therapy, for example. Others do not. I would say that for me, I think really focusing on those dissociative symptoms, rather than making them a part of a treatment, also having treatment specific to dissociation, I think is really important. That would be my argument.
That makes a lot of sense. Okay.
Yeah.
Thank you very much.
Yeah.
Another question?
There. Thank you very much. That was a really great comprehensive presentation. And it's actually great to have that resource that you provided, which I think will be helpful. We're sort of from family practice, and most of us at this table, or all of us at this table actually. And, I guess our challenge would be what to do with a lot of these patients who either can't access a lot of the community resources, have limited funds to access even counseling. Obviously, inpatient programs would be almost impossible for some of them. So we're kind of left providing supportive therapy, but we're also unfortunately left with providing drug therapy. And so I guess my question would be is, for us, where we do have to manage it through therapeutics like that, are there any particular medications that are better for the dissociative versus the non-dissociative types of PTSD? Because you did say, especially the dissociative type. I actually have a patient of mine who's gone through the Homewood program, and he did very well, but like 5 years later, he still dissociates with certain situations and things. And as you mentioned, he's been very difficult to kind of treat. But are there any other tricks and tips that you have for us? And then, sorry, my second part of the question is, what about some of the other neurotherapies? Again, access is going to be an issue, but like ketamine and psilocybin.
Thank you. So I have a confession to make. I am a clinical psychologist and not an MD, is billed. So I will not comment on medications just because I don't feel it's within my scope of practice. I want to be careful around that. I do think some of the neurotherapies do, though, show promise with dissociation. There's no question about that. Certainly around neurofeedback is one example. I'd also refer you to a book called Finding Solid Ground. It was developed by Bethany Brand, Ruth Lanius, and Hugo Schlecki, who's actually the trauma services lead at Homewood. They're really experts in dissociation and approaches that can be used with dissociative patients. It's called Finding Solid Ground. It's a workbook as well as a book. And I would, for some more tips and tricks, I would really refer you there for sure. Another thing I wanted to say, which I can't recall. Oh, okay. The other thing I wanted to say is that if we go back to Can Emerge, if we could just go back to the top of the talk, if you don't mind. I want to give you a direct resource as well. Just go to the first slide. I'll advance forward. Yeah, I can do it too. It's okay. No problem. So if we go back here, this website, Can Emerge, actually is meant to be a navigation tool. So what you can do is click within the region, our regions, for all available free evidence-based mental health supports that are available. We have over 300 resources listed here across the country for mental health supports. It will not be perfect, but it will be something, right? So for example, looking for supports for members of the LGBTQ2SIA plus community. We've indexed all of that. We've indexed supports, peer supports for first responders, support for Métis, First Nation, and Indigenous peoples across Canada. So this is a tool. I think it's not perfect, but it is meant to navigate, because I think what we really lack in Canada is a navigation model of knowing where to go for supports, right? And these include national resources, local and provincial resources. Thank you for the question. I'm sorry, I confess to not being an MD. I'm sorry.
No, I apologize about the mistake in the bios. In terms of the medication piece, and as far as I'm aware, there's not really any solid evidence to suggest that kind of one SSRI or SNRI is better than others for different types of subtypes for PTSD. I think it's kind of similar to major depressive disorder, and you kind of think intuitively that stimulating antidepressants might be better in neurovegetative types of situations, or similarly stimulating antidepressants might be better in hypoarousal states, but it just doesn't seem to pan out in the literature. I think there's a lot of promising other treatments that you had mentioned in terms of psychedelic assisted psychotherapies. My guess is that in the next short while, we'll have more solid evidence that we could actually base some of these treatments on. I think MDMA assisted psychotherapy is up towards the top of that list, but obviously not approved at this point. Ketamine, I'm less familiar with the strength of the literature there, but I don't think it's as far along as specifically in PTSD. Yeah, neurofeedback, potentially RTMS, lots of different interesting opportunities, but no clarity on that as far as I know right now.
Okay, we have one question from online. So this question comes in from Afros, and he's asking, can we have culturally/religiously sensitive PTSD resources?
Great question. Yep. I think that I would say that increasingly over the past, I would say 5 or so years, there's been a lot of effort to develop culturally specific and culturally sensitive resources. I cannot currently provide that, but I can certainly tell you that that work is underway. I think that being culturally sensitive to the needs of various populations that we work with is one of the most important things that we can do. I can tell you, first, I'm not gonna use a cultural group reference, but I will refer to, for example, public safety personnel who often when they go and seek mental health therapy, the therapist will start crying. The therapist will say, I can't believe this happened to you. I'm so dismayed. And what we do when we do that is a couple of things. Firstly, that we tell the individual that what you have been through is so abnormal, I can't handle it, right? It's overwhelming for me. What we want to do, and this, I travel to military bases teaching this actually across Canada around disclosures of sexual trauma. What we really want to do is maintain a facial stance of neutrality, right? Empathic, but neutrality, because when we overreact and we get angry and we cry and we say that's horrible, that's terrible, what we're telling folks is that we can't tolerate listening to this. This is so awful that we can't tolerate this, right? And so we do a lot of role play work around that, around really taking disclosures. I think that's, again, a cultural sensitivity issue. But not to, and I apologize, it's not to racial or ethnic groups, so I don't have that example. I do apologize for that.
Okay. Well, great. Thank you very much, Dr. McKinnon. I think everything's working now. Perfect. Okay. Great. Sorry, to ensure that we amplify the voices of those with lived experience, I'm honored at this point to welcome our next speaker, Brianna Martey. Brianna is a high-performance athlete and advocate who represented Team Canada and Team Ontario in women's rugby, earning accolades including U Sports MVP, OUA All-Star, and the Lieutenant Colonel WDC Holmes Memorial Award. While achieving sporting and academic success, Brianna silently battled many physical and mental health struggles. Despite these challenges, she excelled as a student athlete, community coach, and campus leader, serving on EDI committees and advocating for more inclusive environments. Now pursuing her master's in social psychology, Brianna's research explores the role of collective trust in addressing mental health program hesitancy among Black immigrant youth. She is also a knowledge mobilization lead with the Youth for Consent Culture and Sports Initiative, an anti-racism workshop facilitator, and a proud coach with the York Lions women's rugby team. Please join me in welcoming Brianna with her presentation titled Mental Health Struggles in a High Performance Athlete.
Hi, good morning. Wow, what a great intro. Didn't realize I did all of that stuff. Good morning. My name is Brianna Martey. Standing here now, you see me as a Black woman. You see my size, larger than the average person. But what you don't see is someone who struggles with mental health, someone who was diagnosed late in life with diabetes. You don't see someone who had an upbringing that, quite frankly, probably keeps my therapist in business, me alone. But I know many of you are here because you care deeply. You care deeply, but you're working within a system that doesn't always allow you to show up the way you want to. And for that, I want to say thank you. For that, I want to offer you a story, not just of challenge, but of hope, and how the care you provide, even when it feels like it's not enough, makes a difference. My story is layered. I'm a Black woman. I'm queer. I'm an athlete. I'm neurodivergent. I'm high achieving. I'm a sister, a daughter, an auntie. I tick all of the boxes on the EDI forms. I grew up with a single immigrant mother who gave everything she had to make sure that we had a chance. But what I didn't always see was that she was struggling too with her own, with her own health and her own mental well-being, with the weight of doing it all alone. And sometimes, without even realizing it, I became part of a support system that she very well needed. I learned early how to carry the responsibility, how to push through, how to take care of others, even at the expense of myself. On paper, I was doing everything right. Get good grades, work hard, train hard, play for Ontario, play for rugby, play for Canada, be grateful, be the token. But what no one saw was that I was performing my way through pain. Mental, emotional, and physical, it became second nature. It made me look fine on the outside, but I wasn't. Being a part of so many communities, Black, queer, athlete, student, it made me feel like I had to be on all the time. Like I had to be present, visible, and excellent in each space to advocate, to represent, to succeed. But the more I gave to each part of my identity, the more I lost touch with myself. And when I left home and entered an academic space where few people looked like me, it was disorienting. And I was constantly trying to belong to a space while also trying to represent another space. It was exhausting. And through it all, sport was my anchor. It was the one space that gave me structure and identity no matter where I was. And then suddenly it was gone. Through injury, through burnout, and because I was the only one that looked like me. And with that went the version of myself I had come to rely on. And without sport, I didn't know who I was, inside or out. That loss shattered me. And that's the thing. People like me, patients like me, we often look like we have it all together until the thing holding us together disappears. And when that happens, when everything crumbles, the person sitting across from them, you, might be the only person who sees the places. And so what helped? I met my GP, Dr. Luc Lapointe, when I was 4 years old. That means we've been together for over 20 years, 3 clinics, countless referrals, a million moments that shaped me, and a medical chart of over 300 pages. It's still ongoing. When I was 5, I was diagnosed with precocious puberty. I had a team of about 8 specialists. I was a regular at CHIO. When I was 8, I was diagnosed with ADHD. At 16, OCD. At 18, I got a false positive test for HIV, and from a routine screen. And that was right before I was moving away from school. I was scared, confused. I was alone in a new city, surrounded by people who didn't look like me, trying to perform as a student athlete while quietly unraveling inside. Dr. Lapointe was there through it all. He was there when my weight swung up and down from COVID, when I was diagnosed with diabetes, when I had shoulder surgery for the first and second time, when I lost my sport, the one thing that grounded me. And through all of those chapters, what mattered most wasn't just that Dr. Lapointe tracked my A1C levels or prescribed the right meds. It was the resource navigation, the follow-ups, the goal setting. It was that he never treated me just like a body with symptoms. He talked to me like a whole person. He knew when I wanted to be a genetic counselor. He knew then when I changed my mind that I wanted to be an OB. And then again, when I finally said, I think I want to go into social psychology and explore trust and mental health programs for Black communities. He didn't flinch. He actually said, wow, finally, you're going to be around Black people. He told me I'd be amazing at that. Dr. Lapointe still thinks I should be a doctor. He tells me that every chance he gets, actually. Recently, I told him, I'm not sure. I've been made to feel inadequate, like I don't belong in those rooms. But he said to me, I have no doubt that you'll be successful. We just need to get your foot in the right door. And that hit me harder than anything else I've ever heard. It wasn't a new referral. It wasn't a clinical trial or a diagnosis. It was belief. And better than that, it was hope. And when someone has known you that long, through every diagnosis, every hard day, that belief, that hope, it lands differently. And sometimes it's not the medication that saves us. The belief from someone who has seen me at every age, every weight, every breakdown, that moment gave me confidence like I hadn't felt in years. And so even though I was out without my grounding sport, that kind of care stays with someone. And that's the kind of care that changes life. But what could have helped more? I want to be clear though, through the amount of specialists and team of doctors and everyone that I've seen, I don't blame any one provider. I've had many who did their best and some like Dr. Lapointe who went far beyond that. But even the best provider, like you all, are still working in a system that wasn't built for people like me, complexity. The system is not designed for that. And for patients like me, unfortunately, complexity is the norm. Oftentimes, GPs are the first and sometimes the only point of contact, especially if you're not certain how to navigate the system. You're expected to assess everything: mental health, physical health, identity, trauma, systems, stigma, in a 15-minute window, sometimes even less. And that's just not fair to you or to people like me. And so what would have helped more wasn't just more referrals, it was more relational continuity, more moments of validation, more culturally relevant care. What would have helped was having providers who didn't see me as a checklist, but as a whole person, a person who is navigating a system, stereotypes, and symptoms all at once. And here's the thing about me. Here's the thing about hope. It's a powerful motivator, right? When you have it, it drives you, it anchors you, it gives you the energy to keep showing up. But when that hope is lost, when it disappears from inside of you, it becomes hard to imagine that anything will ever get better. You stop showing up. You stop going to the appointments. You don't want to be in the room having the provider ask you why this happened, or in my case, why my sugars are so high. Well, but that's where I was. I had lost my sense of hope. Not because I was weak, but because I was tired. I was tired of masking. I was tired of systems that didn't see me. I was tired of always needing to be resilient. But Dr. Lapointe, my GP, he gave me something I couldn't give myself at the time. And that was extrinsic hope. The hope that's outside of me. Something that was brought out of me. And the thing that's special about something that's brought out of you is that it was already inside of you. And that you just need someone to help you bring it out. He didn't just offer referrals, he offered belief. He reminded me that I was worth investigating in, even when I didn't believe it myself. And that belief changed everything. Sometimes what helps isn't a diagnosis or a treatment plan. It's someone who says, I still see a future for you, even when you can't see it. And that's what keeps people alive. And that's what kept me alive. That's what allowed me to start coming back, to take my health and myself into my own hands. It's what gave them, but also gave me the courage to keep trying. And so I want to leave you with this. I'm still figuring things out. I'm not a finished product, and I probably never will be. That 300 plus page medical file will probably grow before I'm done. But I've come a long way. I've learned how to speak up for myself. I've learned how to ask better questions. And because of that, I feel confident where I am in my education to be able to provide that opportunity for others. I'm so excited to look at the effectiveness of trust within healthcare systems, how we can empower individuals around us to trust their medical team because it is culturally responsive, because they are not just bodies with symptoms, and how to recognize what they need. I was able to do that and to believe that I deserve to have those needs met. It didn't come from a textbook or a diagnosis. It's your humanity as doctors reaching out to the humanity of someone sitting across you in the exam room. It came from someone seeing me over and over again. It came from my doctor, Dr. Lapointe, who, again, he didn't just track my systems, but he stayed with me through all the uncertainty. He reminded me of what I was capable of, even when I couldn't see it myself. Reminded me of how strong I was, not just in my sport. Hope is powerful. But when you lose it inside of yourself, it is hard to find your way back. And for a long time, I didn't believe that I could be okay. And when my sport was taken away from me, I thought I knew I wouldn't be okay. But someone else's belief in me, in a place of power, in a place of knowledge, it helped me to find my own again. And so, even when parts of me felt like I was being pulled in different directions, even when I wonder where I really belong, I have something I didn't always have, a sense of self, a sense of direction, and hope that is truly within me already and just needed to be brought out. And so that's what I want for all of you to take away today. That you may not be able to fix everything, but you can listen and you can see someone fully. You can remind them that who they are right now is enough. You can give them the space to hold on to hope until they're ready to carry it themselves. Before, my hope looked like this, being pulled in so many different directions, having to show up. I wasn't holding this myself. There were so many different areas in my life that required me to be fully present. Well, hope was just a word. Now, my hope looks like this. It's me Standing here before you, I believe that I am hope for those who come after me because of what was brought out inside of me from my GP, who stood before me and you knew who I was. And so to all of you out there trying hard, to all of you sitting here feeling like you're not doing enough, I'm telling you right now, you're doing more than you think. And as I stand here now proudly, knowing who I am, knowing what hope looks like for me, knowing what I've accomplished and what I will accomplish, I say to you with 100% verification that your words matter, and your care matters, and your consistency matters. And that's what Dr. Lapointe did for me. And that's what you can and you will do too. You may not be able to solve every case, but you can hold space. And your empathy, your questions, and your belief in a patient matter. It did for me. I'm still here. And it can for the next Brianna who walks into your office. Thank you.
Thank you so much, Brianna, for sharing your personal story, inspiring, as well as sharing your insights into the impact that many primary care providers are able to have in the lives of people they work with. Questions for Brianna at all in the room or online? Great. Again, thank you so much, Brianna. Great. So I think we're fairly close to being on time. It's time for a short 15-minute break. I forgot to mention a couple of things. One, just wanted to point out the centerpieces. As in previous years, these are actually completed by patients at the health center, I believe in the traumatic stress injury and concurrent disorder program. Will allow you to chat amongst yourself to decide who at your table might want to bring that centerpiece home with you. And also for folks that might be interested, if you're interested in having a tour or learning more about the programs at the health center, we have Paul Obermeyer at the back of the room. One of our treatment consultants would be happy to help set up a tour or answer the questions you might have. So on that note, let's take a break and we'll reconnect at about 1:45. At this point, I'm very happy to introduce my colleagues, Dr. Jackie Kukat and Dr. Rhonda Taylor, in their presentation on chronic pain management, which I'm sure many of you are seeing and treating in your family practices. Dr. Kukat graduated from the Michael G. DeGroote School of Medicine and completed her rural family medicine residency in Fergus, Ontario. She practices general family medicine with the Upper Grand Family Health Team, and in 2021 began working at Homewood Health Center in our medical clinic. Dr. Kukat has a special interest in helping patients struggling with chronic pain and received a certification in pain reprocessing therapy. She supported the launch of Homewood's integrated chronic pain service at Homewood and is currently the ICPS medical lead. Dr. Taylor is an accomplished emergency room physician at the Guelph General Hospital and a med clinic physician at Homewood Health Center as well. Her extensive medical training includes a medical degree from McMaster University, family medicine residency at the University of Toronto, and an emergency medicine fellowship at Western. She is also a mental health and behavioral science tutor at the Michael G. DeGroote School of Medicine. She is one of 2 physicians in the integrated chronic pain program at Homewood Health Center and part of that team that effectively created this program. She is certified also in pain reprocessing therapy, medical mastery of pain reprocessing therapy, and emotional awareness and expression therapy, or EAET, to treat chronic pain. Please join me in welcoming both Dr. Kukat and Dr. Taylor to the podium.
Just let me know if the volume is okay. Does that sound all right to everybody? Okay, perfect. Thank you. I guess before we start, just want to ask, is there any Lithuanians out there? No? Okay. part of my worry was I was going to have an angry Lithuanian heckler saying, "You don't know that." So thank you everyone for coming today. The topic of pain is near and dear to us. We're so excited to present this today, and hopefully by the end of it, you're as excited about chronic pain as we are. If you're intrigued by the title, 1, intrigue was the plan, and 2, that's coming up in the next slides. So I'm Rhonda. This is Jackie. Approximately 2 years ago, we started the chronic pain program with a small group of people at Homewood Health Center. When I started, I pretty much believed that once a chronic pain patient took gabapentin and that didn't work, we're pretty much done. I'm excited to say there's so much more. This is an accreditation slide, don't really know what it means. And here's the objectives. They're all in your handout, but basically I will start with objective 1, which is explaining the neurobiology of pain. And then Jackie's going to take over and talk about the diagnosis and management of nociplastic pain. Okay, so is chronic pain a new epidemic? Yes, it is. 1 in 4 Canadians live with chronic pain. Statistically, they're more likely to attempt suicide, unemployed, have anxiety, substance abuse, suffer sleep dysfunction. And what's even more alarming to me is actually the rate of increase in cases of chronic pain. There's now 52.4 per 1,000 persons per year incidence of chronic pain cases. Just comparing that to other chronic illnesses like diabetes, 7.1, depression, 15.9, and hypertension, very common, less than chronic pain at 45.3. So I suspect many of you are probably already seeing patients in chronic pain. And if you aren't, a big tsunami of pain is coming. And so I just thought I'd get to some definitions before we start. And so I find this new definition really important to look at. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So for example, you sprain your ankle, there's actual tissue damage, your body produces pain. However, if we take our finger, you can participate if you like, and pull it back, you will feel pain, and your body makes pain at the possibility of getting tissue damage, and so you let go. The definition of chronic pain is discomfort that lasts for more than 3 to 6 months, but even more accurately, it's pain lasting more than the usual recovery expected period. And so, for example, a hip replacement can take up to a year to feel better and recover. If a patient came into your office and at 3 months said they were having a little bit of hip pain, you wouldn't call that chronic. It is pain within the expected period of recovery. And so if we just look at the classification quickly of pain, there's nociceptive pain. So this is the pain that occurs after acute injuries. It's pain caused by the activation of nociceptors. It's easy to localize, it has a timeline to it, and it tends to go away. Neuropathic pain is pain caused by an injury to the peripheral or central nervous system. It tends to have very classic qualities, burning, sharp, shock-like, like sciatica. And then there's nociplastic pain, and that's where we are going to focus today. So this is pain that represents dysfunction of the central pain processing system. It occurs in the absence of identifiable peripheral cause. And there's dysfunction in the spinal cord and the brain, creating pain, amplifying pain, and perpetuating pain. For example, a classic example is fibromyalgia. So if we look at nociceptive pain, first of all, can I just say pain is amazing. And I'm sure anybody in pain wants to punch me in the face right now, but let me explain. It is a learning signal for guiding behavior. So if we put our hand on a hot stove, our brain alerts us that there's danger and gives us the ability to move our hand. When it gives us this alert, we may get pain. We might not, and we just carry on. Okay. Mm-hmm.
Yeah. Bratwurst with onions. Bratwurst with onions?
Is that like online people? And I can't get this. Oh, there we go. Sorry, it wasn't working. Okay. So as we've mentioned, the fundamental nature of pain is protection. It's a warning signal. And if there's good reason to believe that protection is needed, the brain makes pain. However, the brain can make mistakes. We show this picture. There's a classic case report of a construction worker who backed onto a wood board and stepped on a 7-inch nail. Immediately screaming in pain. He's, rushed to the emergency room, given sedation and pain medication. And then when the doctor removes the boot, sees that the nail entirely missed his tissue. He didn't even have a scratch. And so this concept of the pain switch, this is actually referred to as salience. It allows us to focus our limited perceptual and cognitive resources to what is salient or pertinent. The salience network detects salient stimuli and helps determine how our attention is allocated, and then decisions are made regarding pain. Practical application. So these pictures, kind of funny, I used AI and I typed like person chasing a deer. And this guy's actually chasing him to eat him, but it looks like they're playing tag. Anyway, you're chasing a deer, step in a hole, break your ankle. The pain switch is likely to go on and say, stop moving so that you don't do more damage. However, reverse that. Now you're being chased by a lion, step in that hole, break your ankle. The salience, the more important issue right now is survival, and likely your brain is not going to turn on pain. On the next slide, I'm going to show you about 5 minutes of a TED Talk by Lorimer Moseley. He is a pain expert. We show this to our pain patients, and I thought it would be interesting for you to see it and perhaps use it as a resource as well. Some weirdness happening on my screen. Oop. You guys got this? Okay, it is just YouTube and then Lorimer Moseley TED Talk. Sorry, everyone.
As everyone goes, great, quick nap. Don't have a nap. Raise your hand, just squeeze your left ear as hard as you can. Raise your hand if it hurt. Fantastic. Thanks for having me. No, that's not true. Let me tell you a story. I just want to take that off the screen for the moment. I want to tell you a story that will explain to you the first 3 years of the neurobiology of pain that you would study at university. 8 years ago, I was walking in the bush. I had a sarong on. Very cool. This is what happened. Did you see that? Hang on. This is what happened. Biologically, I'm going to tell you what happened just then. Something touched the outside of my left leg in the skin. That activates receptors on the end of big, fat, myelinated, fast-conducting nerve fibres. And they stream straight up my leg, straight into my spinal cord, up to this part of my brain. And they say, you've just been touched on the outside of your left leg in the skin. Meanwhile, whatever it was is sufficiently intense to activate free nerve endings. We call them nociceptors. They're thin, unmyelinated, slow-conducting LADA neva. Someone knows what a LADA neva is. Nerve fibres. And that message travels up to my spinal cord, and it gets to my spinal cord, and that's as far as it goes. And it says to a fresh neuron in my spinal cord, you've just been, something dangerous has happened on the outside of your left leg in the skin, mate. And the spinal nociceptor takes that message up to the thalamus, which sits in there somewhere, and says, there's danger on the outside of your left leg in the skin, mate. Now the brain has to evaluate how dangerous this really is. So it looks at everything. And the way that I make sense of this, of what happened to me, is the brain thought, frontal lobe, have we been anywhere like this before? Hang on, I'll just ask the posterior parietal cortex. Have we been in this environment before? Yes, we have. Has it happened at this stage of the gait cycle? Yes, it has. Is it coming from the same location? Yes, it is. What is it? Well, your whole life growing up, you used to scratch your legs on twigs. This is not dangerous. I'm going to give you, the organism, just something so you can kick off the twig and continue on your merry way. And that's what happened for me. I can't show you now, but I took off my sarong, got in the river, got out of the river, and that's the last thing I remember, having been bitten by an eastern brown snake. Survivor. Thank you very much. Now, for some reason, the eastern brown snake works by poisoning you, clearly, and one of the things that it does is activates nerve fibres. So actually, my brain would have got all these messages saying, danger, 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 danger. And in its wisdom, it said, no, 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 no. 6 months later, I'm walking in the bush with a boring talker. You know what a boring talker is? Those people, it doesn't matter what they say, it's boring. That's irrelevant, but we'll call her Naomi, because that is her name. Anyway, this is what happened, right? Yo, wah! And I am in agony. I have got a white-hot poke of pain screaming up my leg. I'll tell you biologically what's happened. Something touched the outside of my left leg in the skin. That activates big, fat, myelinated nerve fibres, which send a message up to here. Just been touched on the outside of your left leg in the skin. It's sufficiently intense to activate these free nerve endings, danger receptors. Take the message to my spinal cord. Just been, something dangerous has happened on the outside of your left leg in the skin. Yes. Well done. You weren't planted. That goes to the thalamus and says the same thing. Something dangerous has just happened on the outside of your left leg in the skin. Nice. So the brain says, thanks very much, thalamus. Kids all right? Good. Anyway. Frontal cortex, anything to tell me about this? Hang on, I'll ask the posterior parietal cortex. Where are we? We're walking in the bush. Oh. You're a bit mate happy. This stage of the gait cycle, where's it coming from? Have we been here before? Oh, yes, we have. Last time we were here, you almost died. I'm going to make this hurt so much that you can do nothing else. And I was in absolute agony for what seemed like minutes, screaming pain, until one of my mates looked at my leg and there's a little scratch from a twig. The pain in those situations was totally different because of meaning. I want to try and convince you that pain is an illusion 100% of the time. Here's a visual illusion.
Awesome, thank you. So just to go back to the definition of pain and bring that together with Lorimer Moseley, pain equals a sensation and emotion. And whether his leg was touching a twig or being bitten by a venomous snake, his brain got involved and outputted the experience. So there's a really cool study done at Northwestern University They scanned the brains of people who had recently injured their backs. They found that the brain activity associated with the back pain was in the main pain processing area of the brain. They followed these people for a year. At that year mark, 50% were better and 50% still had pain. And they rescanned their brains. Now they noticed with the functional MRI that the sets of regions that were highlighted were associated with emotion, meaning making, and learning. They actually caught on camera the transition from acute to chronic. And so why do 50% get better and 50% develop chronic pain? In the old model that I was trained in, the biomedical model, we sort of just looked at the tree, like what are the symptoms, what investigations can we do, and give you some medication or some therapy to work on your pain.
What's your worst assignment?
Sorry. So let's just say in the biological model, there's an injury causing tissue damage. During this time, the brain creates pathways. But the brain doesn't simply forget these pathways once there's healing. So the body can heal, but the pain pathways are still there and they can still cause pain. That's the biology. Other factors that access these pain pathways can cause the pain to perpetuate beyond the expected healing time. These factors are psychological and social. Your emotions, your cognitions, your beliefs, your early history can all influence this pain message that can continue to descend down these pathways. So the psychology. There are psychological risk factors that actually predispose patients to chronic pain. Stressful events throughout our lives, especially in childhood, can sensitize this danger signal. There are certain personality traits that are common amongst people with nociplastic pain: perfectionism, conscientiousness, people-pleasing, anxiousness. Even a family history of chronic pain is a risk factor, and you can have seemingly unrelated painful conditions, but it is an indicator of nociplastic pain due to shared psychology and neurobiology vulnerabilities. Cognitions, in particular catastrophizing, is one of the most predictive cognitions of amplifying pain, and a history of mental health can put you at risk for developing chronic pain. And are you unintentionally keeping your system on high alert? So many of us are unaware of how our daily activities activate our nervous system, like social media, excessive news consumption. My kids were worried every time I turned CNN on lately. Don't take her away from that. And when you're in a state of high alert, you are more likely to interpret everything as dangerous, including sensations. Finally, the title slide. So whiplash is a social disorder. This comes down to the social part of the biopsychosocial model. There is no structural basis for chronic whiplash syndrome. There are varying rates of it depending on like the different countries and their level of awareness. So chronic whiplash doesn't exist in Lithuania. A study was conducted which, following a car accident, almost half of the subjects develops pain. 10% had neck pain, 19% had headache, and 18% had both. After a year, they were resurveyed, and patients went back down to having the same level of baseline pain as a Lithuanian who had never been in a car accident. These patients have real symptoms because of their belief system in this syndrome. The pain, their brains expected pain and therefore experienced pain. So based on the biopsychosocial model, chronic pain isn't the result of a single pathogen or a broken part. It's the consequence of cells locked in a danger state. And this can occur over years. Two things I didn't learn in medical school: the nature of pain and the power of the brain. In this video, an actor runs an experiment to show patients the power of the brain. I giggle every time the hammer comes out. So in that experiment, their brain made them believe the rubber arm actually belonged to them. Gonna have us do our own experiment, and just with your eyes, take a look at this. We've actually, probably many of us have seen this before, but what do you see? Do you see a woman, an old woman, a young woman, both? Let's do the same experiment with our ears. I'll try to push play. Yeah, oh, nope, doesn't work again. That's okay, we'll skip it. Yeah, because I'm actually kind of going over my time anyway, but when you play this video, I suspect about half of you will hear the noise Yanni and the other will hear Laurel. And I've done it in a room with people and we hear different things. It's actually the same sound, but you hear differently. So this is actually predictive coding or processing in action. So this is a theory of brain function that suggests the brain is constantly building and updating a mental model of the world, sorry. And based on our biopsychosocial experiences, it takes in sensory output and outputs our experience. And this is updated all the time to minimize errors, and yet errors can occur, like thinking you own a rubber arm. I have my own quick story, predictive processing error recently. I was at the airport in Copenhagen, and I'm going through security, and I'm nervous. I'm on high alert, and I'm worried they're gonna ask me hard questions. And so I'm like rehearsing and I'm expecting certain questions, like, where were you? How long were you there? Where's home? And so I walk up and I'm ready. And then he says a whole bunch of words in English, but they weren't what I was expecting. And I didn't hear him. Like, I didn't hear him, except he ended with the word Montreal. That's all I heard. And so I stood there awkwardly staring at him. And then eventually, figuring he needed a response, I said, bonjour. And then I walked away. So the brain can make mistakes with hearing, vision, and nociceptors. Yeah. This is just one more example of predictive coding, and it's a Vietnam soldier who had a shrapnel injury. A chopper comes down, he's medevaced off the field. He has surgery and he is pain-free after appropriate healing time. 20 years later, he's walking and he hears a chopper and he gets pain in his injured leg. So our brains are constantly on guard for threat or danger. It's how we're created. And over our lives, our brains learn and encode threats. We learn if we are generally safe in the world or generally unsafe, and what things make us safe or feel unsafe. All of this is remembered and encoded in our brains. Society values sort of a sucking it up attitude, actually also kind of an attractive quality for a mate. But as we look at people with chronic pain and consider that they seem weak, I would suggest consider them strong due to factors out of their control in the biopsychosocial model and predictive processing. They have a brain coding and outputting pain, and yet they still get up every day and they go to work and they take care of their families. And so all of this just shows symptoms become learned and automatic in the brain, just like the way we learn to talk, ride a bike, play the guitar, shoot a basketball. And this occurs like entirely subconsciously and automatically. There is no imaginary pain and no real pain. It's pain. All pain is real.
Sadly, I don't have quite as many fun videos as Rhonda had, but nonetheless, now that Rhonda's turned you all into pain experts, I want to talk to you about how to apply it to your practice. Now, the first step is gaining confidence in diagnosing nociplastic pain. The exciting thing is that we're starting to have some evidence-based tools that can help. Chronic pain is a rapidly evolving field, and I think over the next couple of years, we're going to start to have even more tools and more evidence that can help us do this. New in the past year, in fact, is a clinical approach to diagnosing nociplastic pain that was developed by Dr. Howard Schuberner's team and was published in the Journal of Pain in March 2024. A copy of this table should be in your handout, so don't worry about trying to read it up here. We'll go over it. Basically, the approach consists of 2 steps. First, You want to rule out a clearly identifiable structural condition, and second, rule in nociplastic pain. This approach was applied in a physiatry clinic to over 220 patients with chronic neck or chronic back pain to determine if they had either nociplastic pain, which they called primary pain, or secondary pain, meaning the pain was secondary to a peripheral etiology, or if they had a combination of both, which they referred to as mixed pain. Here's a close-up of the first step. It starts with doing a history and physical to look for structural causes, for instance, rule out those red flags for concerning etiology. Now, if imaging is indicated, be careful not to overinterpret findings. For instance, degenerative disc disease, is a normal sign of aging, like gray hair, wrinkly skin, and not the cause of pain. It is worth mentioning here that most patients in this study, actually almost 90%, were determined to have primary pain, despite almost universally having some sort of anomaly on spinal imaging. This highlights that the presence of imaging abnormalities isn't necessarily the cause of the symptoms. Then you want to rule in primary pain, nociplastic pain, by listening to them and gathering evidence. So this is where you put on your detective hat. You can start by looking at their chart, reviewing response to previous treatments. So for instance, was there a response to a lack of response to treatment that should have addressed an underlying structural cause, physiotherapy, injections, surgery, or was there a significant response to a treatment with a strong placebo component, taking supplements, Reiki, acupuncture, et cetera. Then you want to look for other functional conditions that could indicate central sensitization, for instance, other pain syndromes. And I'll elaborate on this in a couple of slides. Then the bulk of it is going to come down to getting information about their pain characteristics to identify any characteristics, or we call them the FIT features, so functional, inconsistent, and triggered. So for functional, we want to see if their symptoms seem functional in nature. So did they arise despite no injury, or did they injure long after a physical injury would have healed, or they don't make sense from an anatomical perspective? Secondly, are they inconsistent? So do the pain symptoms switch on and off, change at random, or spread in a way that's not typical for structural pain? Or maybe the pain increases after an activity or exercise instead of during it. So for instance, be very reassuring if they tell you they have pain standing or walking 10 minutes, but they can play pickleball for 30 minutes without developing pain until afterwards. Then you want to look at the triggers. So are the symptoms triggered by things unrelated to a structural cause, such as stress or the anticipation of stress, strong emotions like fear, anxiety, sadness, anger, or sounds? For instance, Rhonda's slide about the vet being triggered by that sound of the helicopter, lack of sleep, weather, light, or even triggered by the act of thinking about the pain. Now, how do you put it all together? Well, primary pain was diagnosed when there's no clear evidence of a structural disorder, and many criteria were met for primary pain. Now, at this point, there's no strict cutoff for the number of criteria at this point. We're kind of awaiting further research on this. A diagnosis of secondary pain was made when there was clear evidence of a structural disorder and few or no criteria for primary pain. And then mixed pain was when there was convincing evidence of both. Now, if this all seems a little bit too vague and nebulous still, here are a list of sample questions that will help lead you to the answers that will confirm the diagnosis. This is in your slides. Feel free to come back to it. I do want to bring your attention to this table, which is fascinating. We can actually get some clues from the physical examination. If the patient has disproportionate hypersensitivity to light touch or allodynia, the odds ratio for predicting nociplastic pain is 30-1, which is wild. Just a refresher, an odds ratio of 1.2 means there's a 20% increase in the odds of an outcome with a given exposure. Odds ratio of 2 means that there's a 100% increase. So an odds ratio of 30 is very convincing, very reassuring that your patient has nociplastic pain. This is something that we've actually often incorporated into our assessment and have found it really helpful when it is present. Sometimes I've even done light touch with and without distraction and then reflected my observations back to the patient afterwards and found that can be pretty powerful for the patient. So I want to come back to the idea I referenced earlier when I mentioned that you can inquire about other functional conditions that might indicate central sensitization or nociplastic pain. So what did I mean by this? If a patient has multiple pain conditions, likely the unifying diagnosis is nociplastic pain. When you have one pain disorder, there's often nervous system hypersensitivity, which is causing multiple sensations in the body to be interpreted as dangerous and result in pain. Basically, the nervous system is turning up the signal on a variety of sensations. When you treat one, the others will improve as the underlying cause is the same. I also want to circle back on the idea of abnormal imaging findings, because as physicians, we do tend to focus on this. We're trained to look for structural causes, and so we're focused on the biomedical model, not necessarily the biopsychosocial model that Rhonda described earlier. And when you look for structural changes, you're likely to find some. Let's look at back pain, which is the most prevalent form of chronic pain. A study in the New England Journal of Medicine showed that 64% of people with no back pain on MRI had disc bulges, protrusions, herniations, disc degeneration, and this is 64% of people that don't have pain. Another study looked at 3,000 healthy, pain-free volunteers and found that 37% of 20-year-olds and 68% of 40-year-olds have degenerative disc disease on imaging but are pain-free. These numbers show us that imaging changes are not always related to symptoms, and we have to remember that correlation does not mean causation. You know, perfectly unblemished spines? Babies. As we go through life, we develop wear and tear, and at the same time, our bodies are very robust and resilient. Another interesting fact is that studies have shown that many of the most common back surgeries are simply not always effective. In fact, continued back pain after surgery is so common, there's even a name for it, failed back surgery syndrome. It's estimated that up to 40% of people will experience persistent pain after spinal surgery, despite addressing the underlying structural cause that was felt to be the cause of the pain. The bottom line is that we're often overinterpreting normal imaging findings. And this isn't just happening with back pain. You might already be aware, but studies are now showing that plain X-ray, osteoarthritis on plain X-rays are not always correlating clinically to people's symptoms. And pain is often more closely tied to psychological distress. We have all of these studies showing lack of correlation between medical findings and pain. This might all leave us completely confused. For instance, when a patient asks me if I think that their X-ray explains their pain, the answer might be closer to, I don't know. And finding the answer might have you asking questions about their stress, their emotional status, their coping skills, which might not be totally what you were planning for their 10-minute appointment with you. Regardless, the bottom line is that we need to start looking at pain through a different lens. So why does this all matter? I've really focused on hammering in the diagnosis here. Why? Why do you need to determine that your patient has nociplastic pain or primary pain disorder? Well, not only does it explain why further investigations or invasive treatments are not indicated, it provides reassurance and it gives the patient answers. Most importantly, it starts to change the patient's belief that the cause of their pain is from something that is wrong with their body. Now, why does that matter? Because the first step in treatment is to shift that patient's belief that the pain is dangerous and it indicates tissue damage. Studies show that providing pain education on its own can improve pain scores. It will soon become clear why this is, but it's vital that the patient stops fearing their pain and starts believing that it means that there's something dangerous going on. Having the diagnosis is really the first step towards this. And it all comes back to this equation. As Rhonda described, pain is a danger signal, and since it's triggered by something that is dangerous, it automatically induces fear. Without the fear, pain is just a sensation. This leads us to pain reprocessing therapy, which is one of the most evidence-based techniques to treat chronic pain that we have right now. PRT focuses on retraining the brain, specifically as it pertains to the perception of pain. It helps patient unlearn chronic pain by working directly with the fear of pain, which is often the primary driver of symptoms. How, you might ask? As you heard earlier, pain is a danger signal. However, the sensitivity of the alarm is related to fear. Now, we've all experienced this phenomenon. If we watch a scary movie, a loud noise or light touch might make us jump or overreact. It's natural to fear pain, especially when there's a belief that tissue damage is the cause of the pain, or there's a preoccupation around how the pain might affect one's job, hobbies, and their life. This fear, frustration, or worry puts the brain on a high alert status, which sensitizes the central nervous system, causing more danger signals coming into the brain, which makes it feel less safe, which causes it to produce more pain. This is a pain-fear cycle, and it results in persistent pain. Basically, when we respond to the pain with worry, fear, and frustration, or try to fight it, we're actually sending messages to the brain that we feel the pain to be dangerous, and the pain gets learned in the nervous system. The good news is that we can also unlearn this as well. So how does pain reprocessing therapy actually rewire the brain? There's 5 main components. I won't get too bogged down with them during this talk. However, I've included some resources in that one-pager handout that you should have in your folders that will give you more information if you're curious about incorporating this into your practice or you want to learn more. Basically, the first step would be teaching the patient about how the pain originates in the brain and how it is reversible. So this is why Rhonda spent so much time on the psychoeducation in the first half of this talk. We want to explain to them that pain is a danger signal. We can give them that hot stove example. We can explain to them how pain can be a false alarm present in the absence of any tissue damage. And we can give them any of the examples that Rhonda gave earlier. That's where sometimes the videos can be really helpful. And it's also, of course, important to teach them about the pain-fear cycle. Then we listen to them, we put on our detective hat, and we gather evidence using that kind of fit criteria in the table that we discussed earlier. We can then feed back these observations to the patient to start changing their belief system. So for instance, you might say, oh, your MRI didn't really show anything actually concerning, or you're told me that your pain is worse with stress, or that you don't experience pain when you're doing something fun. As an aside, I do want to mention that PRT can be effective when patients do have mixed pain, like both structural pain and nociplastic pain. For instance, they may have osteoarthritis with deformities or from previous surgeries or trauma, but they may also have the pain-fear cycle turning up the signal on those sensations, and PRT can reduce it back down. So structural changes don't preclude them from treatment. This brings us then to the central technique in PRT, which is called somatic tracking. So this is a mindfulness approach to teach them to pay attention to the sensations through a lens of safety. Basically, this shows patients that they don't need to ignore their sensations and push them away. They can look at this through this lens of acceptance or curiosity because the sensations are not dangerous. There's nothing to fear. Now, it's also important for them to address other emotional threats, difficulty coping with strong emotions, trauma symptoms. These all contribute to a hypersensitive nervous system, and you've heard about that, earlier, and from Dr. McKinnon as well. This is where a good relationship with a psychotherapist is so vital. Finally, we can also help patients gravitate to positive feelings and sensations to try to unlearn the focus on negativity and shift to the positive, which many of them do struggle with. Okay, so does it work? Now, it was developed by Alan Gordon and psychologist researcher Yoni Ashar, who spearheaded a randomized control trial in 2021. There were 151 participants who on average had lower back pain for 10 years. The intervention arm was randomized to PRT after an initial assessment by a physician to rule out a structural cause. The intervention arm, there was 2 control arms with participants either randomized to placebo with saline injections in the back, and then another arm to continuing routine care. They measured back pain intensity scores, pain beliefs, and fMRI studies on response to evoked pain. I want to highlight that this study is without patients. So that's great news for primary care providers because it is applicable to your patients. What did they find? Well, it was pretty remarkable. 98% of patients improved in some way, and 66% were pain-free or virtually pain-free post-treatment, compared to 20% of those randomized to placebo and 10% to usual care. This is pretty amazing. So these are patients with on average 10 years of chronic pain, and then 66% were nearly pain-free in 1 month. And the best part is that these gains were largely maintained through a 1-year follow-up, and now we actually have follow-up to 5 years. Now, this is really cool. I'll be brief, but fMRI studies before and after treatment show that the brain is actually changing with PRT. Basically, what this imaging showed is that when people in the PRT group were exposed to a noxious stimulus in the scanner post-treatment, the brain regions associated with pain processing had quietened significantly, which shows us that we can actually change the brain response to pain. Now, pain reprocessing therapy is not the only evidence-based approach that is available to us. There is also evidence for mindfulness-based stress reduction, CBT for pain, and improving pain scores, although the response is not quite as robust as PRT. You can also see here that there are new psychological techniques that are being developed. I think more and more is going to be coming out every year. And a lot of these do seem to have similar principles of desensitizing the nervous system in some way and emphasizing the importance of pain education. However, PRT is more focused on changing pain beliefs, which likely explains why it's more effective. Now, you can also help by giving patients ideas about how to desensitize the nervous system on their own. We want to highlight this because most of these patients are sitting in that high alert status that you've heard so much about today, fear and hypervigilance. And sometimes pain reprocessing and somatic tracking just won't be effective or even tolerated until this changes. You heard Dr. McKinnon saying how, sometimes people with a history of PTSD, they can't even tolerate mindfulness for a minute. Basically, in effect, healing can't occur if the brain is still in danger mode, because it's going to be likely that they're going to continue to overreact to normal stimuli. All of these techniques listed here have been shown to help get the brain out of that fight or flight state to help safety signals override stress signals. This slide just shows fun ways that we can turn that list of suggestions or activities into like a handout or prescription to try to make it fun homework for the patient. And, it's okay to be silly. Sometimes silly sometimes leads to a smile or a laugh, and that can be treatment on its own. As we want to wrap up, I want to emphasize some take-home messages. Basically, Rhonda and I are really hoping that we've made chronic pain a little bit less scary. Because the bottom line is that there is hope for recovery, and patients can and do get better. And I think sometimes we forget this in our practice. Hopefully, you now have a sense of the underlying causes and contributors to chronic pain, and understand that the brain can create a mind map to pain, and pain can get out of control with that fear-pain cycle. And, it's not the patient's fault. This is a natural process, unfortunately. Now, we want you to feel confident making the diagnosis and to be able to explain it to them in a way that also is very validating. Of course, do your best to normalize normal imaging findings and to avoid giving patients more fuel to drive their fear and belief of a structural cause. Now, Rhonda and I just see inpatients, but in terms of outpatient support, more and more providers are getting trained in PRT. I'm aware of a couple in Guelph, a couple in KW region, and also there are PRT practitioners that do offer online therapy in Toronto, so offer like virtual appointments that are based in Toronto. There's also a number of local psychotherapists in Guelph who use other modalities to treat pain, like CBT, while providing trauma therapy or DBT, and I can give you guys a short list on request if that's helpful. And that's it. Although Rhonda and I could probably talk for days about this topic. Lucky for you, we'll leave it at that. And we're certainly happy to chat more offline. We did promise a list of resources, and I would refer you to the handout in the folder, which is a bit more extensive and has the QR links to each resource. And it's kind of separated into things that are helpful for patients to see, as well as things that are more helpful or aimed for clinicians if you're looking for more tools to help you with your next patient. Personally, I do find the short YouTube clips really helpful. Patients really enjoy looking at them, and certainly you can watch some of them too. And the ones that you did see here are also linked in that handout. Okay, I want to leave you with this slide while we transition to taking questions. Thanks so much for listening.
Thanks so much, Jackie and Rhonda, for that very thorough review of the foundation of chronic pain and an approach to diagnosis and treatment as well. Questions in the room or online for Doctors Kukat or Taylor? Oh, sorry. If you don't mind, just because there's people online.
Just wondering, in your experience, how much what I'll call the mainstream pain clinics, Toronto, Hamilton, and anywhere else, are utilizing this as part of their approach?
And we can both pitch in, but I think it can be really hit or miss. I do think things are changing. Unfortunately, I don't know that patients are always getting the right message from a lot of these big chronic pain clinics, which I do find are still really focused on more invasive interventions and prescription treatment. I do think there are some handouts, maybe they're giving patients that I've seen that do say, you know, this is nociplastic pain, these other things are contributing to pain. And then they often are, you know, jumping to the more invasive treatment. And so I'm hoping things are shifting, but I haven't seen a lot of that yet.
Yeah, there's a stat where I think spinal injections have increased about 600% over the last few years, and the studies aren't super strong to the patient's benefit. That being said, I don't want to sound anti-medication or anti-intervention. If you've been in pain for 20 years and you're absolutely exhausted, I'm kind of pro, how can we help you feel better? And then maybe if you can get to a certain baseline, then, you know, then we can do the inner work.
I think we find that we're often we're trying to treat both at the same time to say, okay, well, if there's something obvious here, let's treat it. If there's something that you haven't tried that might be affected, let's try it. And let's also treat things from this biopsychosocial approach and treat that as well. And so I find patients often find that helps a little bit with buy-in as well. And then, you know, you feel like you're able to treat things like holistically.
So a quick comment and then a question. The comment is I've had a couple of patients who found apps as well that have been really helpful to them. So particularly for patients who don't have access, both because there's not good access to this, but also because of cost, that also have been really helpful for them point of care. So I've kind of offered that as an option to other patients. But my question is actually around how we get patients to seeing this vision of pain and pain management, because I think many of us see with people all day, every day, and we know that their pain experience is probably more in their brain than in their body. We know that all of the things we offer, like medications and pain clinics, are not likely to be the solution, but the patient is not ready to accept that taking a cognitive approach to their pain is going to fix it. So what's your magic there?
I wish I had magic. And I have to say, like, just like this talk where I'm bursting with wanting to say everything, I want to do that with the patient as well. And one of the biggest things I've learned is just having to meet them where they're at. And so if there was one magic thing that could make, I've had patients one appointment and they're done. They're like, I'm not meditating to get rid of my pain. That doesn't work. And so I think it's you know, where are they at? And sometimes it's just nervous system work where, like, let's just start with some breathing, going out in nature. But yeah, I haven't found one thing that I could say that would just,
yeah, no magic, but it's a little bit magic. I will say, yeah, the Curable app, I think some people like. Is that the one you're talking about? Yeah. That's pretty educational as well. It has like tracking systems too for patients. Now, I think I would say that I'm always surprised, like every day I am surprised with how much I can get buy-in with people. And so I do want, you know, to kind of pass that experience on, where when you really truly like educate people about what is happening and you show them the evidence, it does help them get on board with this. So when you listen to them and you can get all of these little facts, right? This is where the evidence gathering is so important, because when you have all of these little bits of evidence that is in line with this being a nociplastic, you can feed it back to that, back to them, and they can just keep chipping away at their belief system that this is structural. And I do find it effective, like when you can really kind of have all of these different bits of evidence, you can package it up back to the patient. It is surprising. I've had patients say, oh, I've had back pain. It seems like it's triggered just by structural things. They don't really give me much to say, okay, well, yes, it's worth the stress, or yes, it's worse when I'm depressed. But even in the end, when I kind of package a couple of little things up, give it to them and explain it, and explain the pain pure cycle, explain how their brain can be conditioned to expect and experience pain, they'll say, yeah, okay, like that makes sense. And then sometimes I sit back and I'm like, oh, really? Okay, I didn't think I was going to get that from you. And so it can be really surprising when you explain it to them in a way that they can understand and apply to themselves. And then the personalized evidence gathering is super vital for that too. So I will say, like, it is hard, and you can be really surprised at how effective this can be.
I have a question over there, but prior to that, I just have one question from online. In the Guelph community, where can patients access PRT therapy?
I don't know where the person asking the question is from, but there are a couple of therapists that do offer PRT in Guelph for outpatients. So the Women's Health Associates, I think there's Laura DeRossier offers it. Monica Bees, I think, also offers it. I can kind of give you a list here. There's two I'm aware of in Guelph, a couple in Kitchener. And then again, if you actually just go to, there's a website, Pain Reprocessing Therapy, online, you can put in your location and it'll just let you know who is trained in that area. And so I'd probably just refer you to that website for that. And if there isn't someone in your area, you can also just like reach out and look at some of the local psychotherapists, because a lot of them will specialize in chronic pain. Maybe they, do CBT for pain and these other techniques, and they can also treat underlying trauma, PTSD with, EMDR, things like this, that can be really helpful as well.
The beauty of geography no longer being a limitation. So there's lots of therapists that do it online.
I just had a quick question about preventing the cycle in the first place. We often see patients that we kind of have a spidey sense that they're going to enter into this after an accident or an injury. What would be the approach that would you take at the beginning? Would you treat it aggressively, or does that reinforce injury? How would you suggest we approach those?
Yeah. Ron and I are just both very excited about this, so we're just jumping at the bit here. You're right. There's actually studies that show, for instance, if you look at the pain catastrophizing scale, the PSC, if you can do that after like hip replacement, even knee replacement, it's actually been really shown that high scores will be able to predict who develops like chronic pain after surgery. So it's a great question. This is also a bit of an evidence-free zone. Like we can't say, oh, this intervention earlier on was effective or not effective. So I'm going to comment that this is just based on like anecdotal experience and personal opinion. But I do think that providing that reassurance is really important, because you want to be able to take that fear, exactly like what you said, take that fear away and that belief that this will become persistent. And so if you can say, oh, like, this has happened, this is normal for you to have pain at this point, that's okay, your body will heal, you'll recover, we'll help you do it by these ways. I think that's probably really good messaging for this, for the patient to hear, because they're going to be worried it's going to last forever. And if that belief is there, it's going to predispose them for that, to become persistent. And so giving them the messages of reassurance is going to be really helpful. And of course, depending on what the nature is of the injury, to try to move, focus on the positive, the mind mapping to pain, or condition responses to other activities that don't cause pain. Maybe it's yoga or qigong, which is kind of like an easier version of Tai Chi. If they can focus on things that they can do, I think that emphasis is important as well. Not sure if that answers your question.
Just going to add to that, surgery is like a controlled injury. It's brutal what we do to people. And I think the thinking was that depending on how deep we cut was how much pain they were going to have after. And as it turns out, it's more so what the patient brings to the operating room. And so I like when you mentioned your spidey sense, and it's probably more than that. You probably know the patient and maybe they have some history or trauma. And so kind of reinforcing that, and just to say, like, meet with them and say, pain is expected after a painful procedure. And so, here are some tools that when you're starting to feel fear around the pain, take a deep breath. Go find something to look at that gives you joy, like just even little things. We have lists in our handout as well that might just prepare them or give them some tools for after the accident or after the surgery. Does that help? Did that answer?
Hi, thanks so much for your talk. Especially loved the videos. I thought those were pretty wild and very, very cool to see. My question is also a bit about accessibility, but in terms of cost. Do you know if this like PRT is covered by most insurance companies? If not, like I appreciate you may not know individual people's rates, but like how many sessions would be maybe typical of doing PRT in terms of setting expectations or talking about what cost to do something like this for a patient would be? Thanks.
Yeah, so not OHIP covered. I don't know. I think it would just go under the rates of what a therapist would charge and whether your insurance would cover that or not. The study did 2 sessions per week for a total of 8 sessions. And so that's the validating study. And so, if we are giving patients a guideline to say, typically might take 8 sessions, but it's also so dependent on their other comorbidities. I don't know if you want to.
Yeah. I think there's a huge range because patients are all very different. I think Rhonda and I have both seen people, maybe let's say fibromyalgia, where they already have this belief. They've been told, consistently, this is not structural, like you are fine, there's no tissue damage. And they have that belief and they come into PRT. And after a couple of sessions, they're like, oh yeah, like I'm better. And it's really amazing. We see them come back, we do the somatic tracking and we're like, your pain's gone? What do you mean your pain's gone? And it's very surprising. They can respond really quickly. They don't necessarily need that full 8 weeks, 8 sessions. But then, of course, we often see a very complex patient population, and for inpatients that are definitely much more complicated or different than that PRT study. And they have a lot going on, both maybe physically as well as psychologically. And we know that's going to take a lot longer. Like we have a lot of experience with trauma patients where that nervous system work, like needs to be focused on, and they just can't even do the PRT for so long because their nervous system is just like too much on high alert. So there's no like one size fits all. That's kind of what the study showed, but we can see things on either spectrum for sure.
Okay, great. Thank you very much to Jackie and Rhonda. Awesome. Great. So at this point, I think we're going to take a break and have some lunch. And I think the plan to reconvene is at 12:30, but we were ending off a little bit late, so maybe closer to 12:45. All right, thanks. So ready to kick off the afternoon. I'm very happy to introduce my colleague, Dr. Naomi Mudachi. Dr. Mudachi is a psychiatrist at Homewood Health Center, and she supports individuals facing acute mental health challenges, providing thorough assessments and personalized treatment plans to support their recovery. With a collaborative approach, with interdisciplinary staff and the patient, she focuses on creating a safe space for patients to regain stability and driving progress in their mental health journey. Dr. Mudachi started her career as a registered nurse, providing a strong foundation in patient care and an appreciation for interdisciplinary collaboration. She later pursued medical training and specialized in psychiatry, where she developed a keen interest in working with complex cases and helping people through both crisis and long-term recovery. Please join me in welcoming Dr. Mudachi and her insightful presentation on borderline personality disorder management in primary care.
Okay, thank you very much. Thank you all for being here. So let's just see here. Mike, have to put it on. Just make sure. Oh, okay. Yes. Yeah. Where am I pointing it? Yes.
Okay, so thank you for that lovely introduction. I have no conflicts of interest or financial supports. And I think you've probably seen this slide a number of times. Okay, so my hope here today is to review the diagnostic criteria of a borderline personality disorder and explore specifically how it might present for you in family practice or primary care. Try to develop some effective communication strategies. It's okay. Oh. Sure. Can I move it this way? Okay. The chat part. That's great. All right. Perfect. Okay. Is that better? A little closer. Okay. Sorry for all the technological. Okay. So developing effective communication with individuals to strengthen our therapeutic relationship and also provide some clear boundaries and describe the importance of interdisciplinary collaboration with families, mental health professionals, and other care providers. And then also there's a couple topics or specific topics around BPD that I think might be helpful or relevant for individuals who are working in primary care. So I hope to cover that too. So what is a personality disorder? So it is an enduring pattern of inner experience and behavior that deviates markedly from what we would expect culturally or socially. And it's manifested in two of the way that we think, perceive, interpret the world, how we react to certain situations, our interpersonal functioning, and impulse control. Generally speaking, when people don't have a personality disorder, there is a level of stability in their personality, but also there's a level of flexibility and adaptability. So they're able to adapt to new situations. They're kind of the same person, but able to adapt in most situations. With someone who has a personality disorder, they have a lot more difficulty with new situations are often quite rigid. And the difference between individuals who have personality disorders and those who don't are they more often use immature coping mechanisms versus most often people who have no personality disorder will use mature. And I'll get more into that in a bit. Okay. So before going into the criteria of BPD, I thought it might be helpful, and you'll have to bear with me for a few moments, just to talk about a little bit about the causes. So I think it becomes more clear why people behave in the way that they behave if we understand some of that. So it might seem like a digression, but I am getting there. So when we are born as babies, we are not able to, we deal with what's in front of us. So whether we're hungry and caregiver comes and gives us food, they're a good object. When a parent is no longer there, we can't imagine that they are around. We just assume that they are, well, we don't know that there are. So that's the idea of object constancy, or that a person still remains when we can't see them or interact with them, is a part of development for children. And so oftentimes people children who have BPD often show a temperament early on in life that is difficult for caregivers to respond to. So they might cry a lot, they might be fussy, and parents might provide them with some support, and it may not be enough. And then that dynamic can sometimes cause some challenges later in life. So they have that challenge in navigating in childhood, and then that goes through adulthood. They also have difficult childhood experiences. So sometimes there's the idea that's kind of batted around that people who have BPD have also had trauma. That's not necessarily the case. A large number do. Between 60 to 80% of people who have BPD have had a history of trauma. But there are certainly people with BPD who have not. And so some of those individuals might have had a mismatch between their temperament and their environment, or their temperament and their caregiver. So parent didn't respond the way that they needed to, or there might have been maybe not abuse, but The parent withdrew when the baby sought out support. And so that mismatch makes the baby feel insecure, and subsequently the adult has difficulty with navigating those, feeling secure in any relationship. And then those, the neurobiological components. So there's the amygdala, and then there's the prefrontal cortex. The prefrontal cortex is our thinking kind of area, and the amygdala being our fight, flight, freeze, our response, our looking for danger. And so oftentimes there is an overdrive of the amygdala looking or sensing threat when there isn't. And so you might see the fight, flight, freeze in different ways. So in a primary care office, you might see freezes, someone dissociating and just totally detaching. And the flight might be running out of the consult room. So you've given them some news that they didn't like or share with you your opinion and ran out, rather than discussing and following up on the discussion. And or the fight might be big anger. You don't care about me. I just come here and you don't listen, and so on and so forth. So that might be how it presents in that setting. Okay, so on the basis of that, so I was talking about immature defenses and more mature defenses. So immature coping mechanisms, basically any defense is to help us cope with anxiety, distress. So we all use them. And with individuals who have BPD, they split. So there's that black and white. They don't know that nuance is in gray, like mom's here or mom is not. My family member is loving, or my family member is terrible and abusive. So it's that all or nothing kind of thinking. My doctor is fantastic, or my doctor does absolutely nothing for me. Projection is, I can't really deal with these negative and difficult emotions. So how do I tolerate that? I put it onto someone else. So if I feel that I feel bad, then I'm going to make the other person bad. This is all unconscious. So people are not thinking about doing this, but this is, again, really how they manage their inner world. So projective identification is a little bit difficult sometimes to understand, but I think you can appreciate this oftentimes when you're in a room with someone and they say to you, you're actually the bad person. It's not me. I did nothing wrong. It's you that's the bad person. And you, after spending a half an hour, 45 minutes talking to that individual, say, oh my gosh, like, no, like, or you slip up and say something that can be considered invalidating, and then then you act in the way they actually expect you to. So you're invalidating and you're a terrible person, because over time, it actually gets kind of difficult. So individuals with this personality structure can cause different reactions in you, can cause different reactions in a team. So for example, the nurses are great, the doctors are terrible, and that can happen in your clinics as well. And then the other thing that might be very relevant for you guys is somatization. So, if they can't process their emotions, it gets kind of manifested as body pain, as body complaints. Sorry. Okay, so with that explanation, I think then a lot of the criteria becomes a little bit simpler to understand or to remember. So ultimately, there's an instability in the way people think about themselves or others. So they will look at their parents, children, coworkers as all good or all bad. They will look at themselves as either all good or all bad. So you might see one day, the person comes into the office, they're super confident, they're doing really well in school, they've done so for 4 or 5 months, and then, you see them at a 6-month follow-up and everything has sort of just blown up, crashed and burned. And, the only thing that you can kind of identify as like a personal life stressor. And then similar with the sense of self, in addition with the sense of self, sorry, they can feel like they are nothing as well as feeling numb. So that sense of identity is really quite fluctuating. The challenge with identity fluctuation is that it dovetails with relationships. So people who have BPD will sometimes kind of become what is wanted or needed or emulated in the relationship they're in. So, if they're dating someone who is into, I had a patient who was telling me she was doing all these sexual practices, not because she necessarily enjoyed them, or she didn't know that at the time, but because her partner, that was what he wanted to do. So, so their interests might change very rapidly between relationships, within relationships, and that leaves them feeling very unstable because they don't have a kind of personal sense of self. And then unstable affect. So if somebody is really sensitive to the environment around them for rejection, abandonment, invalidation, they're just biologically kind of like cued that way, then they will react very quickly. So they react intensely, and they can go from happy to sad to angry quite quickly. But it can last hours to days as well. So those people in their circle are often kind of brought up and down in these waves of emotion. Oftentimes what you'll see is that the patient will say, well, I don't know why they couldn't get over it. I got over it. So, they might say something cruel or intense or insensitive to their partners, but when they're over it, they expect that the world is over it as well. Inappropriate intense anger or difficulty controlling anger. So this can be extremely dramatic as well. So it can go from yelling, swearing, hurling insults, throwing things, and physical assaults. But also a lot of anger can be directed inwards. So individuals can become very shameful, feel guilty, and be quite, as a result, sad. People with BPD are quite impulsive, and usually in two areas or more that are self-damaging. So that can be sex, substance, gambling, shopping, eating behaviors as well. And again, that is either a method of self-soothing or just coping with really big feelings. So you'll see those behaviors often kind of pop up when things are more difficult for them. Recurrent suicidal and self-harm behavior, we'll get more to it afterwards. Though this is, again, the self-harm and suicidality can be like the anger turned inward. It can sometimes be a reflection of people really trying to feel and or, no longer feel numb. Individuals will frantically avoid real or imagined abandonment. So again, if somebody has difficulty existing without somebody else to provide that structure and frame, the minute that person leaves, they become quite dysregulated, having a lot of difficulty. So they might, again, sort of do dramatic things to have people not leave, including threatening to self-harm or end their life. Though that is the separate criteria. So they, in a smaller way, what might happen is, my husband goes away, goes to the store. He's supposed to be back in a half an hour. He doesn't come back. 2 hours later, I'm texting him. He's not answering me. He's cheating. He's a terrible human, and I can't believe I ever trusted him. And why did I have a baby with him? So that's so it can also be like them constantly bombarding with texts or calls similarly. Okay, and then the chronic feelings of emptiness are also related to, again, this sense of identity. So if we don't have a really great sense of our identity, then we might feel alone without others. We feel numb without others. And again, sometimes when people are feeling, this is chronic. It doesn't come up kind of interpersonally. You would expect this to be longstanding, but when people are feeling more empty, they're more likely to self-harm and or use the risky behaviors to kind of feel something. Okay. And then transient stress-related paranoia or severe dissociation. I think dissociation, I think you guys heard about probably earlier today. The stress-related paranoia might show up as, your nurses are out to get me. They never listen to what I have to say. And, they purposely didn't fax through the referral. Those kind of things might come up as related paranoia, but usually it comes up again with interpersonal stressors that have nothing to do with the people in the office or nothing to do with you. So oftentimes there is, this is not in the criteria itself, but what we often see is that people who are just about to achieve a goal of theirs, whether that be school or work or a project, or even like a relationship, that there is a series of behaviors or circumstances that kind of self-sabotages. We see that also in a hospital when people present. The use of a transitional object. I don't know if you've seen people in your offices kind of come up with teddy bears or other or pets even sometimes. And that is because they can't tolerate being away from people. It helps them A, self-soothe, B, has again a constant object for them to have with them. The micropsychotic symptoms. So we talked a little bit about the paranoia, but sometimes people can hear voices and also again, sort of that paranoia seems very overvalued or even kind of delusional, but they're brief. They're short lasting. And usually, again, you see a flurry of kind of more symptoms when somebody has an interpersonal loss. Okay. So, unfortunately. So this is really more for your reference. I know that time is very valuable and you don't have a ton of it. This might be helpful for you to quickly screen your patients if you have a hunch or you're thinking about a referral to someone. So it has good reliability and validity, and it's worked in different settings as well globally. The cutoff is 7, and if someone is getting 5 or 6, then they usually should probably send or assess for a definitive diagnosis, ruling it in or out. It's essentially the criteria. Okay, so remission. What do we consider remission of BPD? They don't meet the criteria of BPD for 2 years or more. The challenge is that oftentimes, while we see the symptoms improve over time with or without intervention, it's typically they're often the externalizing behaviors or sometimes the self-harm behaviors. What we don't see necessarily is the recovery in terms of the social, interpersonal, and academic or work functioning as much. So recovery is the remission of the symptoms altogether. They're no longer meeting criteria, and that they're in a stable relationship. That doesn't have to be an intimate relationship, and some type of work-related experience, whether it's work, home duties, or volunteering, or going to school. That's how we know people are getting better. Okay. So why is it important for primary care? So general population anywhere from 0.7 to 2.7%. Adults are presenting to primary care at 6%, and then 11 to 12% in outpatient mental health, and inpatient settings 22%. But 6% is pretty relevant because what it works out to is about 1 out of 16 of the visits that are coming to primary care is involving an individual with BPD. So it certainly is coming across in your day-to-day. There's only a slightly higher rate of BPD in women to men in the community. So the numbers that we see, like that women are more represented, is probably more in inpatient settings, and or they're not being diagnosed. Men are not being diagnosed as much. Okay, so the challenge with individuals who have BPD is that they have a whole slew of both comorbid medical and psychiatric concerns. So they are complicated, and they require not only a lot of time per visit probably, but subsequent visits as well. So there are often medically unexplained symptoms or somatic complaints. There's chronic pain syndromes. There's a lot of obesity, cardiovascular concerns, and also risk-taking behaviors. So even though there is the risk of suicide, there's about a 4 to 10% suicide rate in BPD, the life expectancy on average, reduced life expectancy, is 20 years, and it's not explained by the suicide rate. So there's a lot of those health-related concerns that are causing morbidity and mortality. And they use a lot of there's a lot of system use with individuals who have BPD. Psychiatrically, you will see anxiety, depression, substance use disorder, eating disorders, PTSD very commonly, and other personality disorders, and then repeated self-injury or suicide. Okay, so I probably don't have to tell you this, but like I said, there's frequent medical and psychiatric comorbidities. Other challenges are a limited time that you have for primary care visits. Oftentimes people are presenting in crisis, and that there are multiple needs per visit. Often people don't feel comfortable or confident in managing patients with BPD because of the complexity, and then challenges of interpersonal communication, and then frankly, just the resources in the community to be able to send people to either psychiatry or psychotherapy. Okay. So I'm going to talk a little bit about Monica. So she's a 28-year-old single female. She lives with her parents. She has an on and off boyfriend. Relationship is tumultuous and characterized by infidelity and frequent arguments that sometimes get physical. She completed a 2 out of 4 year nursing degree and recently started a culinary arts program. She's had several job losses due to quitting or being fired. So the psychiatric history involves depression and anxiety, alcohol use disorder. She was abstinent in the last month from your last visit, and binge eating. Past medical history, so even at a young age, has type 2 diabetes, chronic fatigue syndrome and fibromyalgia, and migraines. So on a slew of medications, antidepressants, antipsychotics, clonazepam, and medications to manage her weight, and Percocets for pain. So we'll get back to her. So how do we start communicating with individuals with borderline personality disorder? The takeaway from the life history and from the presentation is that they are suffering a great deal. And so, empathy is the foundation for all of our relationships with patients, but is critical in our relationship with individuals with BPD. And the way to at times it is very difficult. It is very difficult when you are on the onslaught of a lot of negative comments and criticisms, and everybody is doing everything wrong, to maintain what I will talk about later, like a calm and open demeanor, and it actually doesn't have anything to do with you. It is really just intense emotional pain, behaviors at attempts to cope, and they are doing the best that they can when they see you. And just to remember that as a physician or a primary care provider, you are an attachment figure. And so that means that things that have happened to them in the past and relationships that they've had may get kind of pulled into your relationship with them. So again, the reactions aren't necessarily about you, but they are, they might be aimed at you because you're representing a person of authority, a person who's supposed to be caregiving, so on and so forth. So we talk a lot about validation. So what is validation and what is it not? So validation is affirming a person's feelings and opinions are valid or worthwhile. So we listen, we observe, we accept a person's feelings, we acknowledge distress, suffering, and difficulties. We understand, so this is the kind of pinnacle, that we understand that in every invalid response, it makes sense to the patient in some way. And oftentimes there is something, a kernel of some sort that we can understand, appreciate, and feed back to them that helps us build rapport. It is not agreeing with the person. You do not have to agree with their perspective. You don't validate what is actually invalid. Validating inappropriate accompanying behaviors. So they might be distressed, but they're still accountable for their behavior. You don't change your treatment recommendations, and it's not about problem solving for the patient. Okay, so why do we validate? Validating helps us turn down the emotional intensity in the relationship at the time where we're trying to actually do an intervention with the patient. It demonstrates to the patient that we're engaged, we're trying to understand, we're trying to listen, we're trying to meet them where they are. Mostly, it improves the communication through minimizing the defensiveness involved in both parties. So coming into the conversation, it's not about who's right and wrong. It's not about the negative way in which someone responds, and it's not about anger, both on the part of the clinician and both on the part of the patient. And so all those feelings that rise up in the moment, just trying to remember that it is actually not about what is right to do, what is wrong to do, but just about the relationship and what is the emotion being communicated. So I say this, it's bold and italicized because it gets us closer to a shared problem and it gets us closer to problem solving, but the validation itself is not interchangeable with these things. So you might have to, in a situation, validate a patient, validate them again. You get to a point where you have a mutual understanding, and then something you do or something that's said or something that's perceived gets fed in again, and you might have to go back to validating. So validating, you really have to match the where the patient is on this thermometer to where you're going to go. At the top of this thermometer, the patient is amygdala is going, and at the bottom of this, maybe some of the prefrontal cortex is online to be able to talk and work through some of this. And again, we want to share our goal with our patient. We don't want to have our goal and put it on them or have their goal made to be our goal. And again, we want patients to closer to problem solving because we want to encourage the patient to problem solve for themselves and take accountability. So when and how to move from validation, I talked a little bit about this. So really, we move on to problem solving and reflection only when the patient is in a place to hear it. We want to maintain a strengths versus a deficit-based approach, asking them, okay, in the past, what has worked for you? When you were with Bob and you had the fight last time, it sounded like you came to a good resolution. How do we do that this time? Really drawing on their own experiences, because often there are situations in which they have managed to repair relationships, have managed to cope in a adaptive way. Ask them to, so again, when the brain is kind of like, when we're in fight, flight, freeze mode, we are not connecting our thoughts, we're not connecting our emotions and our behaviors. Oftentimes when patients are presenting in crisis, if there was something that happened before, likely interpersonally, that has caused a flurry of emotions and behaviors. So how do we help them slow down and say, okay, well, what were you thinking when this happened? And again, asking them to problem solve and asking them permission to give suggestions. Okay. So this is pretty intuitive. So managing the BPD in primary care settings, active, collaborative, interested stance, respectful and non-judgmental approach, de-escalating emotional intense confrontations with a calm and neutral demeanor. So again, this is very difficult at times, especially if you have a busy clinic or your gas tank is mostly empty. Again, it's sort of feeling those and you'll feel the body responses in yourself and trying to kind of, again, repeatedly say they're doing the best that they can. They're trying to express something to me. And the patient may just need frequent reassurances. So you've said something and maybe you have to say it again. I do care about you. This isn't not about me not caring about you. In fact, you know, I'm making this recommendation because I don't want you to sustain further harms. And then a willingness to discuss misunderstandings or disruptions that arise and take responsibility for one's own part. So like I said, we all trip up, and in complicated and longer drawn out conversations with patients, you are going to make a mistake. You're going to say something that's either invalidating or at least I do. You're going to say something invalidating, or they're going to take to be invalidating. And it's just being able to say like, hey, I get that wasn't the best way to describe that or say that. I'm actually meaning X, Y, and Z, and trying to appreciate one another's kind of perspective. So again, you're communicating to them what you're thinking, which they likely are not able to do if the personality disorder is severe. Setting clear boundaries for the relationship with BPD and setting them early. We'll get back to management contracting. Scheduling regular structured appointments, discussing and identifying short-term and long-term goals with the patient. Realistic knowledge that this is a long-term illness, and it is also has a fluctuating course. So we're not going to expect like rapid improvement in the BPD, but are there things that we can work on? The pain, the low mood, behavioral activation. What are the things that we can do to help people improve? So short-term and long-term goals. And then, you know, we talk a lot about boundary setting and keeping the boundaries, and then also knowing like, when do we take a step back and when can we have a little bit of flexibility? Okay. So I imagine that suicidality is a difficult presentation to manage, but I guess I should just ask, is that something that people are finding difficult in their practices to manage suicidality and self-harm? You can raise your hands or. Okay, perfect. Thank you for sharing. Okay. So, and I will say, so that's I think it's also difficult for psychiatrists. So we are not, I think we're not great or we're not perfect at assessing, predicting people's suicidality and risk. So we do the best that we can in a cross section, and that applies to people who are working in primary care. So, you know, we go through the risk factors, we go through the situational factors, and we'll go from there. But we will talk about that. So self-harm is about 85% of those with BPD self-injure. However, the people who are showing up to your clinics are likely not, you may see people who have BPD and don't self-harm or have suicidality. So more often those presentations are going to emerge and less often showing up in primary care. So that number may not be reflective of actually what you see. 10% of people die by suicide. The suicide rate is about 50 times higher than that of the general population. So it makes sense that we need to actually be able to assess. And 2/3 will attempt suicide at least once in their lifetime. The other challenge is that sometimes the behaviors, the overdoses, actually lead to unintentional death as well. again, suicidality and self-harm is a way to deal with really big emotions. And so it is a coping mechanism. It just is very harmful to the patient. Okay, so I actually found this book, which I now love. It is How to Manage, it's from Australia. Australia has like the most wonderful resources for mental health, I think, and now primary care. So there's a full book on BPD in primary care settings, and they have this lovely pictograph of how to manage. So, I'm going to ask the group, when you are assessing suicidality, so let's say this is a new person in your clinic, you never met them before, what are you asking them in terms of their history of suicide? And the people in the chat can also feel free to add some. Okay, great. Excellent. That's great. Yeah, for sure. Sorry, someone else was saying something and I didn't quite get it. Family history. That's great. Yeah. So, sorry, I realized that maybe people can't hear. So, family history, if they've attempted before, and the quality of their suicidal ideation. I don't think I missed anything there. Anything else? Okay. So, essentially, one of the most important pieces is to get the historical information about self-harm and suicidality so that you can assess whether there's been a change. So how many times has this person tried to make an attempt on their life? The most recent time, the most significant time. Did that land them in an inpatient setting? Did that land them in an inpatient medical setting? Did that land them in ICU? What method they utilized? How lethal is it? Do they know how lethal it is? Because sometimes people will pick something like, oh, I took a Tylenol overdose. I didn't think it was going to do anything, but Tylenol, as you guys know, it can be very, very lethal. So do they intend to die? Did they seek care? So if a person took a bunch of pills, didn't call anyone, went to bed, and then woke up the next morning and they didn't regret what they regret that they are alive the next day, then we take that very seriously. And did they get taken to care? Were they in the car, in the garage, and then they called their friend and said, hey, goodbye? That again, there may have been an opportunity to abort. But if someone has gone to bed after an attempt and not sought care at all, that's really concerning. So, so we have our whole list of both self-harm and suicidality, what people are doing at baseline, and then we look for changes. So low chronic risk are individuals who are like have low lethality attempts or talk chronically about suicide and don't act on it. And they come in, there's no interpersonal stressor, there's no new thing that's happened. So the risk is kind of chronic and low. Sorry, so the other thing that we're looking for when we, let me just jump back for a minute, evaluating suicidal ideation is in the history of your suicide attempts, what was the trigger? What made you want to end your life? And so then we know the next time around when they have a breakup or, you know, if they failed a test at school or whatever the situation might be, that's something, a flag for us that maybe this is more serious. So, so low chronic risk, doing low lethality and or chronic ideation, and they're not ending up in emerge or doing anything. New emerging risk. So this is the only thing that I take from this is that don't pay attention to this part over here. So new emerging risk, we don't know whether it's lethal or not. We don't know if there's no history or we don't know the history. That is a little bit, I don't want it to seem like it's still a low risk. It's a new pattern, but we want to assess why the pattern has changed. High chronic risk is people who have high lethality attempts They're frequently in hospital with consequences of their suicide attempts. They have like a lot of near misses. Regardless of whether there are kind of multiple hospitalizations, like they might still attempt. And you really want to have kind of more careful, intensive community treatment at that point. That's not necessarily provided by you, but that is something that isn't necessarily going to be mitigated on a one-time assessment. And then acute high risk is somebody is presenting with a new acute stressor, new acute way of harming themselves, or a new pattern of self-harm. So what might that look like? So an individual who typically will take, a handful of trazodone, go to the hospital, and suddenly they've broken up with their boyfriend, and they are harping on this anyway. They've broken up with their boyfriend, and they are now considering, a different method. And they've presented to emerge about 5 times over the last month, whereas the last 6 months before that, they've presented once. That is a significant change in their presentation and should be taken seriously. Okay. Oh, I guess then the question is like, what do you do? I think ultimately speaking, if you are concerned about a patient and you are unsure about whether to send them to emerge or not, just send them to emerge. Over time, you will get to know the patient. Sometimes staying in emerge for a few hours is the containing event that helps them kind of leave and get some extra support. But ultimately speaking, if you are concerned about a patient and you are unsure, it makes sense to send them. So you're not bothering emerge, you're not troubling them. And I would say, like, if you can provide some kind of collateral, why things are different, why you're concerned, that's often really helpful for the person in emerge. So if we struggle with kind of suicidality, but we have the containment of an emerge or an inpatient hospital, nobody expects you to know necessarily definitively. And if you need to send someone to emerge, send them to emerge or crisis care. Does that make sense? Does anyone have questions about that? Okay. So, Monica talked a little bit about her and her medications, and she's showing up with in crisis with a plan to overdose on Tylenol. How would you manage this situation? I don't know if and people in the chat could also kind of jump in. Any thoughts?
Yes. I think it's remarkable that she has disclosed that she's going to, and probably acknowledge and validate that she must be going through something really difficult, and it's great that she has come forward for help, that something inside her wants help.
Yep. So that's great. And I think according to the initial case, which I don't expect you guys to remember right away, but there isn't a history necessarily of suicidality and self-harm. And so if that's presenting itself, then likely it's possible that there is something, and there is enough kind of safety and trust that maybe they came for a different reason and they disclosed it to you. But that they've been able to come forward is great. Okay, so maybe some of the other things that I would kind of look at in a situation like this is, okay, so last time you saw her, she was not drinking. Is she drinking now? Is there been an exacerbation in the binge eating? Has there been self-harm? Has there been suicidal thoughts? And then kind of going through the whole lack of criteria we talked about. So what is the stressor? What is going on in your life? How's school? How's work? How's your relationship with your partner? Those would be some of the things that initially kind of look at when when approaching Monica in this situation. So she's talked about Tylenol as an overdosing method. She's looked this up, she's researched it. You kind of have managed to have some contract of safety, but you're not sure. She says she's willing to be safe, but she's going back to her boyfriend. Then perhaps it is time to have someone else kind of assess her. Okay. So elements of a crisis or a safety plan. So this is really generated in collaboration with the patient. You want them to look for what are some of the warning signs, what historically has triggered suicidal ideation, what kind of strategies can you distract yourself with, what kind of coping strategies do you have, relaxation, exercise, people that you can contact for support and distraction, and then people you can contact for help, and then a professional agency support, and then any crisis lines. Where are we in terms of time? Is it 15 minutes till the end, or is it? So, okay. Have I run out of time to talk is what I'm looking at. I have. Okay, all right. So I wonder about whether this, so I'll ask you this with a raise of hands, how many people struggle with management of medically unexplained symptoms with people with BPD? Okay, all right, so let's go to this then. Okay, I might just talk my way through it rather than having participation, but so Monica's coming in, increasing anxiety, new onset lower back pain. She wants benzos and she wants opiates. So you've taken all the right steps. You've done a complete history, you've done a fulsome exam, you've fully worked up the patient, you've fully worked up the complaint, you've considered more rare presentations, you asked for a second opinion where it was appropriate. So you've done all the things that from a primary care standpoint, you need to be doing. So the main tasks are acknowledging, doing all the investigations you need to do about the concerning symptoms, and then minimizing the risk of over-investigation, and also providing the appropriate treatment, which sometimes is no treatment at all. So the yellow flags for a medically unexplained symptom might be a longer list of problems presented with infrequent resolution of symptoms, and when the person is not responding to treatment as we would expect. So patients can be invalidated by us saying, you know what, there's no more tests indicated. There are, I can't give you a medication for this. It's not going to substantially change treatment. If I give you a medication, it might in fact make things worse or harm you. And then on the flip side, providers might feel hopeless. I mean, our jobs are to diagnose and provide a treatment. And so if there isn't an available treatment that feels, or diagnosis that feels satisfying, we can often feel shame, guilt, and hopelessness. And then just because we're frustrated, become dismissive of patient complaints. They're coming frequently and coming often with complaints that don't resolve. That would be reasonable response, personal response. So ultimately, when you're discussing with patients, you're validating the patient is suffering and that the symptoms are distressing, provide an explanation for the medically unexplained symptoms, and offer a review of symptoms if they persist or worsen. So, so sometimes what I'm doing in hospital is kind of undoing a lot of the things that have happened in outpatients from multiple providers. So a patient has been diagnosed with recent case with like colitis, and but the imaging didn't match that. And then they went to this place and they got the diagnosis of, so they come with a variety of diagnoses with like a smidge of symptoms that could be explained. So like gastroparesis by 5%, and yet they can't tolerate any food. And these kind of lists grow and grow and grow. And so that at some point I can say to the patient, okay, like, let's look at all these symptoms. Let's look at all these tests, and what are these practitioners actually telling you? So when I'm giving a diagnosis of a somatic symptom disorder or a functional neurological problem. So I open up my laptop, I show people their results, I talk to them, often like with a provider who knows what they're talking about. So I don't do this on my own. With the imaging, the lab results, and the trajectory over care. And I avoid documenting. I try to say that my goal is the same as their goal. I want them to stop suffering. I want them to be able to fully function, and I want them to be able to get the right diagnosis so they get the right care. And that sometimes just because we have the same long-term goal, that our steps to getting there might be different. Okay, these I think you can read on your own. Essentially, you want to actually address the symptoms rather than dismissing them. Okay, and then how do you manage? So how do you manage this request now? How do you manage her request for medications, knowing that opiates and benzos aren't necessarily the next way to go for, let's say, chronic back pain and anxiety? Any thoughts?
Think it would be worth asking what Monica worries this might be.
Yeah. Exactly. I think that's it delves a little into the medically unexplained symptoms literature, and that is true, is that patients often fear that it's something big and bad, and it's not necessarily invalidating for them to hear that it is not. So that's a great step. So I frequently get patients who are asking for more opiates from me and more benzos. And I tend to take the approach of, especially in the early phases, saying like, I'm not going to rip out the rug from underneath you. I'm not going to take away the benzos. I'm not going to take away the opiates if they're not there for addictions issues. But I'm not going to prescribe them again. So set limits early and set them the minute they walk into the inpatient setting. So, and oftentimes, like we know, we give patients medications and they do not improve. So I will say, like, talk about the harms, talk about the consequences, and then getting people, then I'll talk to them about how difficult it is to get them off of benzodiazepines. So I might just stop there, but just for, I know that you guys have the handouts. There are psychological treatments for BPD. DBT is the most common. And then there are resources. I just want to point to SashBear. This is a wonderful organization for parents, loved ones, caregivers. It is free. They do online supports across Canada. And the people who come from it say that it's great. So I've heard nothing but great things. So yeah, so there are some other resources as well. That was quite a whirlwind. My apologies. Any questions?
Great. Thank you very much, Dr. Mudachi. Again, any questions in the room or online for Dr. Mudachi?
Thank you for the talk. I have often struggled with the diagnosis itself and disclosing the diagnosis or talking about the diagnosis. I work not in mental health care, I work in the hospital, but patients will come with the diagnosis and it's the top one and it is truly the root cause. How do we have that conversation? How do you recommend the disclosure goes? Do you even talk about it? Like, how can we, because otherwise it's the elephant in the room.
That's a fantastic question. So, and I can't tell you the number of people who have had the diagnosis of BPD and have showed up in hospital and they have no idea what it is. So I don't know that we do we try our best, or I don't know how that's communicated to patients, but oftentimes, or whether they can hear it at the time, but oftentimes people are not really well educated on what BPD looks like. So, so how do we, there's actually, so one of my colleagues who's coming up next, or one of the two colleagues coming up next, there's a resource, it's called Good Practice Management, I want to say, from Harvard. And really, like, there's a book as well that you can use that I found at the last minute prior to doing this talk that is really good about how to provide the diagnosis of BPD and describe it. I don't know as a person in a hospital that's your job to do. And I can appreciate that it's part of the presentation and causing some significant kind of treatment communication concerns. I would wonder about kind of perhaps, are they frequent flyers? Yes, no, they're frequent flyers. So then that would be the time where I would say, like, reaching out to the psychiatrist or in the or family doc in the discharge note and saying, like, this person is frequently presenting with X and Y. We're seeing that this is perhaps psychologically or situationally based. Is there a way that we can come up with a plan that every time they come in, we don't have to do a workup from head to toe? Does that work or no? Yeah. And I think that's fair. A lot of people avoid it, and it actually can be. So there are times in which I've given the diagnosis of BPD, then the patient has been appreciative of that. Oh, that makes sense of my symptoms. There have been lots of times where people don't agree with the diagnosis of BPD, and I've given it to them again and again. I say to them sort of this, so it is not your job to convince them that they have BPD and or that the clinical presentation is consistent with a symptom of that. What it is for you to provide an explanation and say, again, like, you can go get a second opinion. You know, we can agree to disagree. In my clinical opinion, I've seen you multiple times. This is what I see. And this is the most important thing, is that I'm giving you the right treatment. And again, good BPD, good care and communication with someone with BPD doesn't mean that you guys are going to agree at the end of it. And the other thing is that I often see it as an opportunity to plant a seed. At the time, they may not be able to appreciate it, but if nobody says it, then this is just going to happen again and again and again and again. But that's a lot. Like, that's a lot for a practitioner in a hospital or where maybe you're not seeing the patient kind of over time.
Good. I know, personally speaking, I've found it really important in our role as a psychiatrist to not avoid the diagnosis. It can be a difficult conversation to have, but you're gonna, like, as long as you're approaching it in a validating and empathetic way, not just giving a label and not saying you have borderline personality disorder. Well, what does that mean, doctor? Well, you cut yourself and you're volatile and you don't have bipolar disorder. No, that's not the way you do it. Again, you could talk about the whole constellation of the presentation, the impact it has on their life, the background as to how they got predisposed to this. And people typically, from my experience, tend to receive that much better. They might be more likely to have that response, say, now that I understand the bigger picture, maybe not in that moment, maybe the next day or the next week, they might, and you give them some additional reading. I actually think that makes sense. And sometimes they also appreciate that with the clear and accurate diagnosis, that maybe they come off their mood stabilizers, maybe they don't need other medications.
Yeah.
Because the treatment's different, which is why part of the big reason why it's important to clarify diagnosis, because oftentimes people are misdiagnosed with other conditions or overdiagnosed with other conditions, and you're not necessarily addressing the root cause. Dr. Friars, one second.
Yeah, thank you very much. That's excellent presentation. One of the questions that we didn't, I don't think, get to is self-care, and being in primary care for a long, long time, and with the high prevalence of BPD in our patient populations, they tend to be people who take a lot of gas out of the tank. And much like when people show up at a hospital unabated, they do the similar thing to family doctors in primary care. And it's been my experience that also creates, because of the way their traits are, that they can create tremendous disruption in your office staff, being from reception to nursing to, and so it would be really interesting to know if there is any type of standardized planning that offices can do to help deal with people with the disorder, and because it is one of the more difficult things that I think over my practice years I've run into is the people with the borderline personality disorders and managing them in the office, managing the time and your staff. Any comments would be helpful.
So obviously I don't work in primary care, so I can only make suggestions and hope that they might be relevant. But again, about setting clear boundaries and limits. So if it means coming up with a plan for the office, when this person presents, if they're yelling, if they're screaming, if they're swearing, they can go and come back when they are feeling like they can actually have a conversation. So setting, like, we are not going to accept this kind of behavior. And really, it's because I can't get from you what I need to get from you, and you can't give me what you need to get to me for me to be able to do that work. Setting time limits for how long you're going to spend with the patient and making that clear to the patient. I want to see you. I want to be able to address your concerns. Look, like, even when we spend 45 minutes, like, I haven't gotten to what you presented with initially, the door handle comments. I can't manage, acute pain as you're walking out the door and you say to me, my back has been hurting for 4 weeks. So being very clear and having the patient go over this with you, and having that an understanding for everyone. I'm not going to listen to you tell me that the nurses at the front or the admin at the front are FBs. Like, that's not what I'm going to do. When you, like, this is our expectation, and you can go to a walk-in clinic, you can go to somewhere else if you're not going to follow these. And the thing is that as long as you're providing a safe disposition, like, if you're feeling unwell and you're feeling unsafe, then, we need to send you to emerge. If you have to form the patient, whatever the case may be, but that these behaviors are not going to be acceptable in your clinic. And it's really about setting limits that make sense for the clinic. Does that answer your question?
Yeah.
I tend to be very hard with boundaries, though. So
it's a tough balance to balance the boundaries and the validation piece.
Yes, agreed. But I think that's a good point. But having a contract and be able to do that, not in an acute situation, but later, is really, really important. Is to say, like, we want to be able to help you. This is how we're going to go overdo it. Do you agree with it? This is your shared accountability in this? This is my shared accountability in this.
Thank you. I'm just wondering if the symptom profile of this kind of individual is such that it is going to consume this kind of time for us. How reasonable is it for us to say you need to fit into our normal 15-minute portion that we treat for colds? What is the system doing, or what are we doing to look at pushing the system to help us accommodate the needs that these individuals have? Because now they're paying the price for when we say, well, you just need to understand that we can't do this for you.
And I'll throw another wrench into it, is that, you have appointments and then they no show. And so, you put in, let's say you schedule a patient towards the end of the day where you might have a little bit more time, and now you don't have, they don't show up, and then they present in crisis again.
That's what the individual physicians will do to try to accommodate that. But the system is still short servicing the providers to be able to provide the needs that actually these people do require.
100%. I mean, I have no answer for that, because there's lots of things in the system, like consult only model, that is not helpful for family physicians.
Because what I hear in these kinds of conversations is the focus then gets displaced from the individual, and we really aren't there to provide service that we have learned to provide, and they have come to us to receive. A difficult question.
That it is a difficult question, and I would say, so there are limits to what a psychiatrist, there are limits what a family physician can do, and I think that's part of speaking to the self-care, is you can provide only what you can provide that is reasonable, and then the individual is also accountable for how they show up. And it sounds like I'm not being empathetic, but I actually am for the patient. They are going to have these boundaries in everywhere in their life, including in the office. And so and that's where that flexibility between the boundaries and knowing when something different is coming up. But the system kind of downgrades on all of us, and we all have bigger and bigger portfolios, bigger and bigger things we have to do. And at some point we have to say, this is no longer what I can provide in this moment. So limits go for patients as well as ourselves. I know that's not exactly the answer you were looking for, but.
Great. Well, thank you so much, Dr. Mudachi. I have too many microphones here.
Yeah. Perfect. It just clips back.
It is on now. Thank you. Thanks very much. Great. Happy to welcome our next speaker for this afternoon, who's actually a recent addition to Homewood Health, and we're very fortunate to have welcomed Dr. Lisa Gagnon to the Guelph community and to Homewood very recently as our new chief of our traumatic stress injury and concurrent disorder program, as well as the assessment and stabilization unit in comprehensive psychiatric care. Dr. Gagnon comes to us from Alberta and brings a wealth of experience and dedication to perinatal mental health. She founded 2 perinatal mental health programs in Calgary, one nearly 2 decades ago, and one more recently focused on the care provided to Indigenous mothers. She has extensive experience working on a general adult inpatient unit for 16 years, providing compassionate and comprehensive care to her patients. And she's an expert in trauma-related conditions, women's mental health, and particularly perinatal and postpartum depression. Among her many accolades, Dr. Gagnon has been recognized with multiple teaching awards at the University of Calgary, highlighting her commitment to educating the next generation of mental health professionals. She's also received the C.A. Roberts Award for Clinical Leadership, awarded by the Canadian Psychiatric Association in 2018, recognizing her outstanding contributions to clinical leadership. Please join me in welcoming Dr. Gagnon.
Thank you very much. I'm really happy to be here. And I'll just say new jobs and really want to impress the bosses. So laugh appropriately. Well, so perinatal mental health, I love this area, partly because you can help families who are suffering, but there's very little areas of medicine where you can do tertiary care and prevention at the same time. And how many of you actually work with pregnant postpartum? Most people? Yeah. And I just learned before we started, Catherine Jones here, we do have some perinatal services here in Guelph that, and Katrina's going to be adding this to the resources and sending it out. But Guelph Family Health Team has some peer support, and that can be a self-referral. Do you want to add anything to that, Catherine? No. Yeah, I've only been in Guelph about a month, so it was a bit of a scramble to find what the local resources are. So yeah, really great to hear that there are some. So my disclosures, I'll just mention that it was quite a long time ago that I was an expert witness for GlaxoSmithKline and Alliance Against Violence and Adversity. I'd encourage anybody who's interested. They actually have a lot of research platforms like learning opportunities. But we have some funding for actually a PhD student, and they're trying to work on research in community settings. So it's an excellent organization. So going to move into the objectives. Going to just talk about common presentations for perinatal mental health, effective patient-centered communication around this, and how to engage professional teams and community resources. So of course, everybody's heard of postpartum depression, right? Yeah. How about anxiety? Way more common. Agreed. So for the longest time, the focus was on postpartum depression. But actually anxiety disorders are more common, and it's highly comorbid, that women struggle with both. And if it's a high-risk pregnancy, more likely, if they've had previous stillbirth or previous neonatal-related losses, more likely to have depression in pregnancy. And the rates are elevated if for those women who've stopped their medication, especially if they've stopped it abruptly. The statistics, of course, we don't want anyone to suffer. Like the family suffers, the women suffer, but the other consequences of untreated perinatal mental health problems include that there seems to be a slightly increased risk of miscarriage, some obstetrical complications. It influences the child's development. And the biggest risk factor for postpartum depression is actually how mom's doing in pregnancy. I'm sure all of you have seen that. I'm going to be fine once this baby comes. I'm feeling really crappy right now, but it's all the pregnancy. Have you guys heard that before? And you're like, no, it's not going to get better when the baby's born. It's not just going to get all better, but people feel that way. It's just, they feel like it's the pregnancy itself. Anxiety, as you're pointing out, is highly comorbid and highly common in pregnancy and postpartum. And that actually also impacts neurodevelopmental and obstetrical risks. So managing anxiety can be quite important. And often having difficulty with generalized anxiety can also have difficulty with panic, other forms of anxiety. And this also is associated with previous losses. And COVID did nothing for anybody's health, mental health, hey? Nobody felt good with COVID. So COVID was shown to increase pregnancy-related anxiety. Anybody use the EPDS? Yeah. I see some nods. I feel like I'm talking to a well-educated group around perinatal, so I might go quicker in some of this. It sounds like you guys do a lot of it. Okay, good. Excellent. Excellent. Love hearing that. Yeah. So you probably know only 2 questions out of 10 for anxiety. So I don't love that there's not a lot of emphasis on anxiety because it is so common, but it's a start, and it can flag if there is a big risk of depression. In pregnancy, it can be used as well as postpartum. Lots of languages it's used in. So an excellent measure for a good screen. ADHD is actually in our clinic. We started looking at ADHD the last, 10 years or so. What we were finding is if mom's having trouble executive functioning, wow, it's really hard to executive function for, their baby and sometimes their partner, the whole family. So we actually were seeing quite a bit of ADHD within our clinic. And it is one of the most common neurobiologic conditions worldwide. But the studies are mostly in boys and men. The studies tended to be a little bit more common looking at males. And so what we know about ADHD is a little bit different than, we don't have as much evidence as we'd like. But ADHD is a risk for miscarriage. ADHD more likely to have teen pregnancies and more complications. And it could impact the interaction as well. Are you guys seeing much ADHD in your pregnancy, postpartum? Yeah. Yeah. So in terms of the research, there is, historically it's felt to be a broad ratio with much more common in males and females. But as I mentioned, there's a data gap there. And girls tend to have more internalizing symptoms. So, boys might be jumping up and interrupting the class and causing disruptions, whereas girls are more likely to be internalizing and perfectionistic and more likely inattentive in school. less hyperactive, less impulsivity. Emotional lability is common with both genders. I'd say, like most people who see a lot of ADHD would note that it's not part of the criteria, but most people say that emotional lability can be quite common. And long-term studies actually show there's not been a lot with women, but there has been some long-term studies showing an overlap of kids who are presenting like ADHD when they're young in preschool age, going on to have borderline-like features and not appearing very ADHD-like in their teen years. So it's kind of interesting, and I'm curious what this research is going to show over time. Need more research. So ADHD in women also increases the risk of substance use, sexual activity early on, sexual partners, getting into difficult situations. And part of why I bring this up in the context of perinatal, we need to bring it back to that, is that I get this question a lot around what do we do in pregnancy around meds. So I'll come back to that. I do have some patients who really function quite a bit better on the medication. So it's important to be aware of that literature. Do you see that much in your clinics, patients on stimulants becoming pregnant or asking about stimulant use in pregnancy? Yeah, some. Okay. I'll just mention eating disorders are probably likely underdetected in pregnancy and postpartum. It has been associated with hyperemesis and bleeding, as well as anemia. And if it's quite severe, it could interfere with the weight of the baby and fetal growth, and as well as correlated with not as good outcomes for the baby. And relapse postpartum is quite common. This a few years ago, actually, I was doing this presentation for medical school, and I'd never seen it precipitated an eating disorder by pregnancy. Have any of you seen that? And actually, the day before I gave the talk, I had a patient, and I hadn't seen it, but in the literature, it's described that sometimes pregnancy is precipitating a lot of concern about body image. Actually, a lot of fertility difficulties, up to a third of fertility difficulties, actually seems to be related to eating disorders, which makes sense if someone's really quite low birth weight and having difficulty with menses, that certainly would impact fertility. And do you have, is it easy to refer to an eating disorder team here? No. Huge wait list, yeah. Years, yeah. Yeah. So this is not a very practical point I have here, is that a program specializing with eating disorders would be ideal for perinatal. Yeah, so in terms of, I was trying to broaden the talk, so because a lot of the literature is looking at usually higher income countries, as well as probably overrepresented by Caucasian women, trying to broaden it. And there actually wasn't a lot of literature on immigrants. So hopefully down the road, we can have more to say about that. But there's some studies that in terms of obstetrical and child outcomes, that actually there is a risk of things not going quite as well for immigrant mothers and their children. There was a Quebec study that actually showed a lot of perinatal stress, which makes sense, which would impact, of course, the fetus around cultural concerns. So they're stressed about cultural-related things, health and social service access, as well as discrimination. And a study actually in Lethbridge was looking at African immigrant women and showing that they had really good knowledge of postpartum mental health, but not necessarily knowing a lot about the impact for the child. So it's interesting, it's starting to come. In terms of Indigenous populations, the risk of mental health problems is about double the Caucasian population, which actually is lower than what I would guess. I would actually think it might even be a higher risk than that. Working with Indigenous mothers, what my experience has been is that, you know, intergenerational trauma really impacts them greatly. And I would say I've actually over time come to think that perinatal mental health almost most of the time is a trauma-related condition. Most of you, have you had the experience where they're talking about how they were parented, or you know, this and difficult experiences they've had where they've maybe lost a baby or had a late demise? So, and with the Indigenous mothers, I certainly see that quite a lot. You know, they had really difficult upbringing, and I think their family was trying the best they could, but you know, a lot of factors were getting in the way. The risk is higher with teen mothers for Indigenous. Some countries, had lower rates, and that was actually seemed to be the case if they were engaged in their cultural and community practices. So they were using some Indigenous ways of knowing or engaged with their own community. And in the US, there was studies showing that racial trauma was, that's where the research was. I would expect that maybe that's the case in Canada as well. But there is racial trauma and healthcare interactions for the Indigenous population. So there is really an increased risk of depression, anxiety, and substance misuse. And it was really interesting, my experience working in a general clinic. So when we started the Women's Mental Health Clinic in Calgary, we need referrals from care providers. And we certainly saw a minority, we saw immigrant mothers, but probably not representative of the population. And we did not serve the Indigenous community very well. If they came, they didn't end up staying very long. And so what I had done a couple of years ago is went over to, it's a family medicine clinic in Calgary, Elbow River Healing Lodge. And a lot of learning, and I still have a lot of learning to do, and trying to work on, there's a lot of Indigenous ways of knowing that is really quite helpful for them to heal from mental health challenges, including, you know, aunties and more getting into smudging and getting to the land. And there's a lot of, so we're trying to bridge both our Western and Indigenous ways of knowing. I'll just also mention that the level of children's services involvement and the severity of their mental health conditions is so different than the other clinic. And it's difficult because they don't show up regularly because housing and like basic needs are not getting met. So I'm going on, but anyway, that's been my experience there. So we're gonna take a pause here. We're not gonna do the breakup quite yet. I just tell you about a case. And I thought at the tables maybe, and my friend Raymond, if you wanna join another table, some of the smaller groups could join others, but maybe discuss amongst yourself this case, a 29-year-old married mother of one, considering more children. Less than half people plan their pregnancies. So this is actually really nice that you're having the opportunity to talk about what the consideration is before they get pregnant. But so she had a previous postpartum major depressive episode with generalized anxiety and was stabilized on escitalopram, which she still takes. She's not had any other episodes of depression. She tends to be anxious though, and her anxiety at baseline doesn't really interfere in her functioning as an insurance advisor. I'm thinking this might be kind of pretty straightforward for some of you, you manage, but just how would you approach this? She's been stabilized over 12 months and asking if she should be off her meds before pregnancy. So maybe in the break, in the rooms, you can talk amongst yourself and give it a few minutes. We'll go 5, and then we'll just hear back from a few of you about how you would approach this. And we'll do breakout rooms for virtual too. Thank you. And that the baseline population risk is 3 to 5%. And that, so 3 to 5 out of 100 babies are going to born in the population with some sort of defect, regardless of the medication. And talking about spontaneous abortions, we don't always know the rates of that, partly because people are more likely to report problems with it, miscarriages after they've had medication. Obstetrical complications is that they've been exposed to the medication all throughout the pregnancy, neonatal withdrawal and toxicity being the 3rd trimester, and any long-term neurodevelopmental outcomes, they're taking the medication throughout the pregnancy. It's really any time. How many people use mother to baby? Yeah, you're familiar with that? Yeah, really excellent website. How I approach, you really did have, I felt like you covered a lot of how I tend to approach things. I actually tend to, I try to document on capacity, have a capacity kind of note on it, risk and benefit conversation with the patient and loved ones. And I have some patients that I honestly would rather they don't go off their meds, but they're going to do what they're going to do. And sometimes they've done quite well. Actually, I've been surprised more than a few times. So, you know, having that follow-up, it's really quite important. Monotherapy is favored because there's studies showing that combining medication, especially the benzodiazepines with some of the antidepressants, there seems to be an increased risk of the major malformations in combination, as well as some of the anti-seizure medications, which we wouldn't be using anyway in pregnancy. And then how I pick, if somebody is actually coming to me and not doing well in pregnancy, I look at what is their efficacy, what have they tried in the past, what's worked well. And I have had patients where we've needed to go to paroxetine because that's what worked before for them. And they'd been on other medications. So, and what have they been on in pregnancy? Because if they're on a medication, they're doing reasonably well. I wouldn't necessarily switch them to something else and risk them becoming sick. And then they're exposing that fetus to 2 different medications, as well as the available safety, reproductive safety information. So probably all of you know this, like anything new, we don't really have medication information, like what the safety. So I'm always 10 years behind my colleagues and knowing all the latest medications and how they're helpful. In terms of general findings overall, neonatal adaptations more likely in preterm delivery, in neonates who are born prematurely. In full term, it's about 15 to 30% are going to have the neonatal adaptation. It's, I would say, controversy. Go back here. If medications cause an increased risk of miscarriage, as I mentioned, we don't really have the rates. Lower gestational age and a smaller birth weight, we don't, some of the studies suggest that, but also depression, anxiety, uncontrolled causes increased risk of both of those. So it's not clear it's the medications versus the underlying condition. When we had the Women's Mental Health Day conference a number of years ago, one of the obstetricians, we had a panel, and he said, these meds are studied more than any, speaks to the stigma of mental health. These medications are studied almost more than any medications that we use regularly. And yet there's still so much controversy around it. And it just, I think he was pointing out to the controversy and the stigma around mental health conditions. Like, do you really need your meds if you're anxious and depressed? Tends to be the question. But I'm already I'm singing to the choir here. With regards to SSRI medications, I'll just, everybody can read that. So I'll maybe skip ahead because it sounds like everybody knows that. SNRI medications, we have less research than the SSRI medications. Bupropion, I don't tend to use a lot of bupropion in pregnancy and postpartum, partly because anxiety is so common and bupropion doesn't tend to be quite as effective for anxiety. It's good for depression, but some people do quite well on it. They did find an association with ADHD, which I think is quite interesting because bupropion used to be in the guidelines for ADHD treatment. So was it that these kids were getting ADHD from bupropion, or is it that moms had ADHD and responded well to the medication? And that's why there was this association. And of course, off-label smoking cessation could be a consideration.
Sorry, Dr. Gagnon,
Yes.
sorry, I apologize for interrupting. We just
Yeah.
had a question about neonatal adaptation.
Yeah, what was the question?
Can you
Can I explain it? Yeah, you bet. So neonatal adaptation, that's baby comes out, neonate comes out, I'm looking over here, but a little bit jittery, breathing harder. Their tone is different. They're more likely to have reduced tone. It goes away. It's not life-threatening, unlike the persistent pulmonary hypertension of the newborn. It depends on the half-life of the medication, how soon it goes away. So in fluoxetine, which has the longest half-life, it would probably take a couple weeks for the neonate for that to gradually go away. Whereas for something like paroxetine, which has the shortest half-life, that could go away within even a couple days. Yeah, great question. Thank you for asking that. And I'm sure some of you have had the experience. They freak out. My baby's going to have withdrawal then, right? Oh my gosh, I'm giving medication and it's going to, and of course that is worrisome for mothers and their families. But I think, again, going back to, it's a risk-benefit analysis, and your mental health can cause problems for your developing baby as well. Benzodiazepines are a very unpopular medication class. I do sometimes use them. Partly, have you had the experience when you start someone on who's really anxious on antidepressants and they just makes their anxiety worse? Sometimes with really, really anxious moms who I do use a little bit of benzos if they can't tolerate a bit of an SSRI to just get them on, or those postpartum moms who are like, I'm sure you've seen them, the deer in headlights, just so anxious, can't sleep. Sometimes I've used a little bit. So this is the information around benzodiazepines. Of course, we would really want to limit the use very short term, avoiding high doses, especially around delivery. The long-term effects have not been fully researched. There is a risk of neonatal withdrawal with that as well. I have included a little bit of information on the stimulants. The short is that we don't have a lot of information. There's slightly more information on dextroamphetamines than there is. It seems to be slightly safer than the methylphenidate class, but we don't have a lot of safety information. It appears that at prescribed doses, it does seem to be safer than, stimulants of abuse where there's preterm delivery and more likely lower birth weight. So in the postpartum, postpartum blues is probably a normal phenomena. Most women, birthing persons go through this. Begins a few days after they deliver and having difficulties with mood, crying, anxiety, irritability. Depression in our manual that we use is supposed to be 4 weeks postpartum for postpartum depression, but clinically we'd say up to a year postpartum. Most of the symptoms, 60% present within the first 6 weeks. And it's up to like super common, up to 20% of moms. Risk factors for postpartum depression, difficulty, as I mentioned, with their mental health through pregnancy, stressful life events, low social supports, previous history, and medical complications. Now, all the time, I have patients going, doctor, you know, I'm just so nervous that I'm not feeling well in pregnancy. I am so anxious because I'm hurting my baby by my anxiety. Do you guys get that quite often? Yeah. When the studies are showing that if mom's going on to have chronic mental health problems, you know, that's going to impact the development. So I tend to focus on you're coming in for treatment, you're working on things, and actually the impact of the first 5 years of your baby's life or child's life by that time is probably more impactful than what's going on through a few months of pregnancy, and trying to focus on that. And there's a really high proportion who go on to have chronic difficulties with it. More likely if they have limited support, they've had a trauma history, and there's a lot of situational stress. OCD in pregnancy. So you're all familiar with that, yeah. So OCD, it's about 1.5 to 2 times more common in pregnancy and postpartum. Postpartum more likely to have the thoughts of harming the baby, and ego dystonic, meaning really alarmed by that. That's a good sign. That's a sign that it's OCD and it's not psychosis. And more likely, they're not as likely to have compulsions postpartum. And anybody's experienced people really forthcoming with this information? Yeah, often people are really, I feel like I'm talking to a very experienced group here. People are very worried about bringing this up. They're very nervous to talk about this because they think that you're going to take their baby away. They're very unlikely to say, well, when I'm cutting vegetables, I think of stabbing my child. Like, yeah, they tell you later. Yeah, I had a patient who actually had trouble going to their freezer because they would see a turkey in their freezer, and that made them think of popping their baby in the oven like a turkey, and really distressed by it and really hesitant to talk about it. Yet you kind of need to ask and dig, and still sometimes you don't get it because they're really worried about that you're going to call children's services. If it's ego dystonic, if they're alarmed by it, if they're really disturbed by it, it's more likely to be OCD. And actually the studies suggest they're less likely to hurt their baby than the average population. Of course, OCD can interfere with the relationship with the baby, because sometimes they're over-parenting or they're avoiding the baby. As I mentioned, it's up to 2 times more common. The literature around PTSD is interesting because it's primarily been focused on PTSD related to delivery. But as I mentioned, lots of our perinatal moms are saying, I don't want to be like my mom. I don't want to be like my dad. And they're quite worried about that. But the studies around delivery is that 3 to 15% of women or birthing people go on to have PTSD secondary to delivery. I actually, I'm just working on a paper because we did a trauma therapy. It's called accelerated resolution therapy on 3 moms in pregnancy to help with PTSD from previous pregnancies, and it went well. But PTSD is not how the delivery would have gone by the team that's delivering. It's actually how the mom perceived if they felt like they weren't heard, if they didn't have a lot of control, if they felt like they didn't have a lot of support. They had a previous psychiatric history. And actually up to 5% of partners, fathers, also went on to have PTSD, so quite common. and actually very high mental health problems in the NICU. This is probably, my guess is lower now because there's more support. I think depending on the ICU, of course. But a lot of parents were having difficulties with depression, anxiety, even suicidal ideation from the NICU. I shouldn't say from the NICU, associated with the NICU. Intimate partner violence is highly common with in pregnancy and postpartum, and does increase the mental health outcomes. It is something that is very hard to get at times. I find that I have to have a very, very well-developed relationship with my patient before, and even then I don't always hear about what's going on. The risk factors for it is common law relationships, shorter relationships. There's substance use. There is higher risk in the Indigenous population, stalking, and lesbian partner relationship is slightly more common as well. A number of years ago, working with my obstetrics colleagues, quite shocking. We were reviewing all the deaths in Alberta, all causes of mortality. And what came out of that was actually suicide and drug overdoses was a leading cause of death. And that's true in the UK. There's some data here in Ontario that suicide actually is a leading cause of death in up to a year postpartum. And you guys are way ahead of lots of places in Canada, but we test gestational diabetes, we test blood pressure, but how often are we saying, how are you doing? Yeah, how are you really coping with this? More likely to be late postpartum. So they kind of classify it early postpartum as the first 3 months, and then late postpartums after that, more likely at that time. And risk factors for that are perinatal loss, so previous infant loss, or late preterm loss. There's psychiatric symptoms and a family history. And it's such a shame that this still is a problem in Canada. So there is some evidence for depression, for psychotherapy, for pregnancy, postpartum depression and anxiety, IPT and CBT, as well as psychodynamics seem to be leading, but sometimes we need medication. If somebody has more of a moderate to severe course of the illness, medication, I don't know if you've seen this, they just are so unwell that they can't take in any therapy. Like they're just, and some of the moms I've worked with are so anxious that you have to kind of scrape them off the ceiling, like so much reassurance, and they're really struggling. So going back to mother to baby, which it sounds like you're all aware of, I've always gotten most nervous when I have a patient with bipolar type 1. They are the highest risk patients of decompensation postpartum. I think the rates were 28 times more likely to get sick in postpartum than any other time. So as well as schizophrenia, if they're staying on their meds, they're not higher risk to have difficulty postpartum, although bipolar type 1 still can get quite sick if even on medication. So I would recommend that they're followed by a psychiatrist if that's available. Okay. I'm almost done. I just wanted to talk about postpartum psychosis for a minute. Postpartum psychosis, there's not a lot of psychiatric emergencies, but this is one of them. My experience with, as it was mentioned, I worked on an inpatient unit for over 15 years. And I tended to see all the postpartum psychosis that came to our hospital at the Foothills. It's 0.5 to 1 in 1,000 deliveries, but it presents really kind of differently. They present more like a delirium, I'd say. They fluctuate. I had a number of cases where, you know, they got a couple PRNs, got some sleep, and they were floridly psychotic, and then they got some sleep and they presented okay. And like I have one like that I remember who actually was a week later that she came back really psychotic. But we had several instances where people, you know, they appear okay and then they're not okay, and, you know, kind of perplexed and I don't understand what's going on. You know, I just really can't grapple. Lots of cognitive symptoms, I'd say. And litmus test for psychosis for a woman is postpartum. The highest risk time for a woman to have a psychotic episode is postpartum, and 50% relapse without treatment. So really concerning. And why it's concerning: high risk of infanticide and suicide without treatment. They can present with auditory hallucination or delusions. It can present with, and I actually had one patient referred to me. She was hours postpartum, and I just started the clinic, and my colleague from CL called me and said, "Hey, do you want to take this patient over the clinic?" I said, "Sure." We arranged it, and maybe 12 hours later, she was catatonic and needed transfer to psychiatry. So she, like, it just developed so rapidly, but it can be. For postpartum psychosis, it is up to 6 weeks. Usually we don't, if it's presenting later, it's not typical postpartum psychosis. They can have mood symptoms, but not all of them do. If the literature suggests that this is bipolar disorder, I would argue with that, but if you have a multiple choice test, you won't, but I'd say bipolar disorder. But I would say what my experience has been is that it depends how they present. If they present with bipolar, present with a manic episode, yes. But I've seen lots of patients with a depressive episode who had psychosis, or atypical, they only had psychotic symptoms, who went on to not actually go and develop bipolar. Because I had some patients who had many kids with me. So that was not the outcome, but high risk of suicide and infanticide. And my usual advice to people is, if you think you're seeing someone with postpartum psychosis, have them assessed, send them in. I had one woman who she compared her baby to a worm, and it sounded very subtle, but it was very close to hurting this baby or taking the baby's life. And she had 3 older kids, and it was the older kids who kept her from, actually she was considering drowning the baby. And she left the baby for like 12 hours without feeding, and then was kind of hearing the baby crying. This before they ended up in the hospital. And it was the kids that prompted her to go and feed the baby. And she's like, "Oh, something really smells." And she hadn't bathed the baby for a couple of days after she was born. So really sad, but she got better. She really was, we had our intensive treatment team follow her after, and it was a good outcome. But it isn't always so. It's important with postpartum psychosis that they have really secure follow-up. Okay, so we have an updated resource list coming. And if you had more to add to, please let me know, because I'm very interested in what the resources are here, and opening up for questions. And I'll just comment, it seems like you didn't need this topic anyway, but. Oh, I love mother to baby. Yeah, great question. So the mother to baby website, if you go under fact sheets, it has conditions as well. Like, so what's the risk of postpartum? What's the risk of depression and pregnancy? But it also has medications in PDF form that you can print off and give your patient. So for fluoxetine, for paroxetine, like you can print off something you can give patients. No. Yeah, it's all medications. No, all medications. Yeah. So all sorts of things. It's a great website. Mother to Baby was put out by Otis in the States, so organization Teratogen Information Service. So they keep it updated. So it's a great site. And why I really like it is instead of classes of medications, it drills down to specific ones. Yeah.
I've got the mic here. I was just it was intrigued by the ADHD in pregnancy. Were those people some like people who had any features of it prior that like you said, for example, women are a little bit more likely to have the kind of hypoactive symptoms, withdrawing symptoms that often I'm seeing in my family practice as emerging in kind of quote unquote emerging in adulthood, but really you look back and it's been a history that going back through their life, or was it a truly kind of like new issue that came up for them?
Yeah, no, it was really diagnostically, they'd had it the whole time. It's just having the pregnancy and postpartum, like the hormone changes and the executive functioning, lack of sleep, it just made it, I think just made it much more apparent postpartum. Yeah. And so I've had a couple patients who elected to stay on medication. They were ones that I had, I got them either in their first or second, and they had more kids, and they elected to stay on because they had such a hard time in their pregnancy and postpartum. And, how I approached it is these are the risks and the benefits. We don't know. And frankly, they really had a hard time postpartum. So it set them up for it to go easier for them. And early days, but the babies were doing fine. Yeah.
Is the evidence for progesterone postpartum growing or dwindling for postpartum depression?
That's a good one. I actually don't, I should know that, but I don't. Does anybody else? I'm happy to, if you want to email later, I can look it up, but I don't know that. Yeah. Mm-hmm. Mm-hmm.
Any further questions in the room or online?
When we were talking about SSRIs, previously we used to always say, well, we have evidence for Zoloft or sertraline, therefore we should switch over to that. And then when you were saying that you're comfortable using any, has that changed? And is there a resource to sort of look that up?
So I think if somebody hasn't been on anything in terms of pregnancy and lactation, I'd say sertraline has pretty good evidence. It's pretty safe in pregnancy and lactation. In terms of like paroxetine, there seems to be slightly increased risk of cardiac, although that's controversial. I think probably what I've seen over time is people have been on 4 or 5 different ones, and what's worked well for them is, but if you're starting somebody new, and pregnancy is a consideration, I'd lean towards probably sertraline. But that's a great question. And that slide I had around how I pick, it's usually like what's been effective, can we get away with one medication, because that's always ideal. And what's the latest safety information? And it's not usually the latest medications or the newest. Yeah. Did that help? Yeah. Mm-hmm. Mm-hmm. So sometimes like I usually present what the evidence is with the patient, and we could talk about sertraline and switching, and they might prefer to do that. And if that's what they want to do, and would work with them around that. But if the risk of switching, if they've responded really well to that, they're not necessarily going to respond well to another medication. And they might have to, if they want to wait till you don't want them sick when they're getting pregnant, ideally. Usually I would continue on if they feel comfortable with the risks with that. Yeah.
Any further questions at all? Or? Okay, well, I think we'll end things there. Thank you so much, Dr. Gagnon.
Thank you.
Great, so I think we are teed up for a break, but Katrina is pointing at these lovely packages, which happens again, lovely booklet, includes the evaluations, which we're hoping you all can complete. There's one for each session. And if you could complete it, please, again, it's important in terms of shaping future events and us getting feedback on each one of the sessions. So thanks for doing that. And we'll take about a 10-minute break. Okay. Hello, folks. Hello. Great. I think some folks are just coming in with a snack and a coffee. Hoping we could move on to our next session on mindfulness or mindful moments by one of our experts, Dr. Tara Riddell. Dr. Riddell serves as a physician wellness lead at Homewood. Her journey in medicine began with a medical degree from Dalhousie University, followed by a psychiatry residency at McMaster and a fellowship in clinician health and well-being through the University of California. Dr. Riddell has a long-standing passion for the health and well-being of healthcare providers. She has held leadership positions advocating for and supporting the wellness of learners and physicians at the both local and national level. She holds key positions, including Student Affairs Director for the undergraduate medical education at McMaster Hamilton campus and Wellness Curriculum Coordinator for McMaster Psychiatry Residency Program. Dr. Riddell was also the faculty wellness lead in the Department of Psychiatry. Dr. Riddell demonstrates a deep-seated commitment to physician wellness, and her contributions in the field are invaluable. She has presented at previous mental health symposiums, and her presentations have always been very well received. So please welcome Dr. Riddell.
All right. Well, good afternoon, everyone. It's nice to see so many of you still in the room as our day begins to wind to a close, and also a nice welcome and hello to those who are joining us online as well. I'm really excited to be back at this kind of enriching and informative day, and also really excited to speak to one of my areas of interest and inviting some mindful moments into your afternoon. My hope for this session today is really twofold. One, not only to offer a moment to pause and reflect, and maybe to provide some practical tools you can take with you in the care you're providing to patients. But also I'm hoping that this session serves as a reminder that you matter as well, and that tending to our own presence and well-being, even through small acts like mindful moments, can also be a tool to sustain us in the work that we do every day. So, oops, you've heard a little bit about me already. I am an employee of Homewood, but not receiving any financial incentives for being here and have no other disclosures to make. So we'll have about half an hour together or so, during which time we'll review a little bit of the origins and background to mindfulness. We'll recap a little bit of the evidence base for this, including for healthcare providers specifically. And then we'll also have 2 opportunities, optional practices to get some real-time exposure and experience with mindfulness as well. So as many of you know, mindfulness has been around for centuries, rooted in ancient traditions, including Buddhism. It became more widely recognized in the 1970s in the Western world, particularly fueled by Mr. Kabat-Zinn's expertise in bringing some therapeutic applications to mindfulness. And he importantly defined mindfulness as the awareness that arises from paying attention on purpose in the present moment and non-judgmentally. So breaking that down a little bit more simply, mindfulness has 3 core elements. intention, which is bringing a sense of deliberate choice or act to the practice, attention, which helps to fuel that present moment awareness, and importantly, and often forgotten, compassion, which is how we meet that experience as well as ourselves in so doing it. And so these three elements also help then to promote a sense of curiosity, helps us to maintain that beginner's mind so that we can approach experiences with fresh interest, a sense of openness so that it promotes willingness to experience thoughts, feelings, and sensations in a way to experience them as they are without challenging them, pushing them away, avoiding, or resisting, and also without becoming preoccupied and clinging to them. So physiologically, we know that mindfulness regulates the nervous system. It tends to reduce activation of the sympathetic nervous system, your fight or flight response, and also increases activation of the parasympathetic nervous system, our rest and digest response. So we see evidence of that by increased or decreased heart rate rather, decreased blood pressure and respiratory rate, reduced muscle tension, and also cortisol. If we move up closer to the brain and take a closer look there, brain imaging research shows that mindfulness practices, even over a short a time of 8 weeks, brain-related changes. This includes slowed age-related cortical thinning, especially in the prefrontal cortex, which helps to preserve our cognitive and executive functions. It also reduces activation of the default mode network, which is most active when our brain is at rest, which can be associated then with mind wandering, daydreaming, rumination. You've heard a little bit about the amygdala already today, so you know that that's our emotion center, and mindfulness can help reduce the size and activation there. There's also been studies to show that there's increased gray matter density in a number of key areas of the brain. That includes the brainstem, which is really the relay station between the body and the brain, especially for sensory and motor processing, our hippocampus involved in memory and emotion processing, and the temporoparietal junction, which is associated with empathy and perspective taking. We also see that mindfulness is associated with increased neurochemicals, specifically GABA, which is our inhibitory neurotransmitter. Serotonin, which many of you will have heard about earlier today, has several roles, including for mood, but also things like sleep and digestion, and also increases in brain-derived neurotrophic factor, which tends to be more so suppressed in chronic stress and trauma, and is a protein that supports the survival and growth of neurons. So that's a lot of neuroscience background. I hope I don't scare anyone with this slide or bring back thoughts of neuroscience from your post-secondary days, but we'll zoom out a little bit and to bring this kind of home in a clinical kind of way. So I'd like you to imagine a patient or maybe someone in your life, perhaps even yourself, at a time that they were distressed or dysregulated. Maybe they're angry or tearful or just totally shut down. And you might think about the ways in which you tried to engage with them. Maybe you tried to talk them through it, offer solutions and problem solve. Maybe you were successful, but I'm suspecting that oftentimes something didn't land or the conflict escalated or you found yourself feeling stressed and frustrated in response. So if we think back to our brain, and think through that a little bit. As I mentioned earlier, the brainstem is that relay station. So sensory input is coming from the body up through the brainstem, and then it moves upward. So it travels to the limbic system, like our amygdala, which is our emotion center. And then from there, information and signals travel up to the cortex. That is our thinking part of the brain. That's where we can involve logic, planning, and problem solving, and thinking more rationally. The problem is when someone is stressed or dysregulated from the limbic system, the fight or flight and sympathetic nervous system is becoming active, and the connections up to the cortex become delayed or distorted, which makes it really hard then to connect with that person, to have them relate to you, and to engage them in reasoning. We need to regulate first before we can relate and reason. So that's where mindfulness comes in. We know from everything we just reviewed that mindfulness supports bottom-up regulation. So it helps quiet the amygdala, reduce activation there, reduce the sympathetic drive so that that connectivity up to the cortex can occur. Studies have also suggested, however, that mindfulness may support top-down regulation as well. It strengthens connectivity in the cortex, especially the prefrontal areas that allow us to better notice, name, assess, and evaluate experiences and the thoughts and emotions that are occurring to keep us grounded and to allow us to have more intentional, rational responses rather than being more reactive and impulsive and driven by the emotion brain. So just in case that slide is still provoking a little bit of stress or tension or thinking about that situation in which you were recalling someone who is distressed, we're going to take our first practice of mindfulness and do a short meditation that involves some breath awareness. This will probably be a couple of minutes long, and I'll guide you through doing some box breathing, kind of following this picture. But then we'll shift into following a natural breath rhythm and bringing a little bit of intention. This is an optional activity, so if you decide that right now that's not what you need, I totally respect that and commend you for attending to what you need in this moment. I just ask that you sit quietly to respect your colleagues who may be engaging in the practice. So for those who would like to participate, I invite you to take a moment and find a comfortable position, maybe with your feet flat on the floor and your hands resting gently in your lap. And you may wish to soften your gaze or close your eyes, whatever feels right for you. So we'll begin with a few rounds of box breathing, a structured breath pattern that can help calm the nervous system. We'll breathe in for 4 seconds, hold for 4, exhale for 4, and hold again for 4. So let's begin together. Inhale for 2, 3, 4, hold, 2, 3, 4. Exhale, 2, 3, 4. Hold, 2, 3, 4. Inhale, 2, 3, 4. Hold, 2, 3, 4. Exhale, 2, 3, 4. And holds, 2, 3, 4. Now gently allow your breath to settle into its natural rhythm, whatever pace that feels comfortable for you in this moment. There's no need to control or to change it. Simply follow the breath as it moves, in and out, letting it be easy, effortless. And from this place of gentle awareness, we'll begin to bring a soft intention to the next few breaths, using each one as an opportunity to connect with ourselves more deeply. With the next inhale, bring your attention gently to your body, noticing any places of tension or tightness. And as you exhale, imagine letting that tension soften, like releasing a held breath or unclenching a fist. Breathing in, we notice, and breathing out, letting go. With your next breath, become aware of any emotions that may be present, whatever you're feeling right now. And as you exhale, remind yourself that there's no need to fix or change anything. Just allow it to be. So breathing in, we notice, and breathing out, we accept. It's okay to feel this way. As you breathe in, imagine drawing in warmth and kindness, the kind of care you might offer a friend. And as you breathe out, extend that same compassion to yourself, recognizing the effort it takes just to show up. Breathing in, we offer warmth. And breathing out, we offer compassion. I'm doing my best. Let's take one more slow, steady breath, offering yourself whatever you need in this moment. And now begin to gently bring your awareness back to your body. and the space around you. You might notice the feeling of your feet on the floor, the weight of your body supported by the chair, or the temperature of the air on your skin. Maybe invite some small movements, a wiggle of the fingers or of the toes, a stretch if that feels good. And if your eyes were closed, you can slowly open them or lift your gaze and just notice how you feel now compared to a few moments ago, without judgment and just gentle awareness. So I appreciate you, those of you who participated. And I recognize, with this activity, it's more of a meditation, but through that experience, we practice box breathing, we practice bringing intention to the breath. So there's a lot of aspects of breath awareness that can be utilized moment to moment, even in the course of your day. That being said, mindfulness can also extend beyond breath practices. There are body awareness exercises, yoga, tai chi, body scans, focused attention using the 5 senses, or bringing mindfulness into daily activities like walking and eating, formalized meditations, which you're getting some exposure to today. And then, of course, there's formalized therapy programs. Those that are mindfulness-based include mindfulness-based stress reduction, cognitive therapy, self-compassion, as well as several of our other therapies, acceptance commitment therapy, DBT, relaxation therapy, all also integrate mindfulness in a lot of the skills provided. So as we've reviewed a little bit of the background of mindfulness and how it works, it helps to understand and appreciate the different ways that mindfulness may be conducive to wellness. I won't belabor this because this may be self-explanatory and many of you here may already be familiar with this, but just to highlight that there's a lot of evidence-based ways that mindfulness can support different domains of well-being. So to highlight a few from the physical domain, we know that it's associated with improved sleep and pain management, enhanced immune function, and perhaps also promoting healthier lifestyle behaviors. Cognitively, it's associated with improved attention, working memory, insight, and self-awareness. Emotionally, we've talked a lot about emotion regulation, but also can help to reduce stress, anxiety, depression. And socially, enhanced empathy, compassion, communication, and connectedness. So all of these we can identify could be helpful for any one of us, including our patients. But mindfulness-based interventions have also been specifically studied in the healthcare provider population, both for individual and personal practices, but also from organizational-driven interventions as well. And what we've seen from that literature is mindfulness can support clinician well-being by mitigating risk of stress, burnout, and mental health concerns, enhancing adaptive coping through increasing our capacity for self-care, self-compassion, and relaxation, and is also associated with improved job satisfaction. And also for healthcare providers who do engage in mindfulness, there's some thought that there are secondary benefits from a clinical care perspective, where providers may be more attentive to possible errors, which may mitigate adverse events. There's improved communication with patients and with teams, improved therapeutic skills. And there's also been some studies, although results are a little bit mixed, that patients of providers who engage in mindfulness themselves might have greater or faster reduction in symptoms from interventions like therapy. So while we just looked at some of the evidence of mindfulness for healthcare providers, it's important to recognize that mindfulness doesn't just help us stay well or, be present and do better in the jobs that we're doing, but it also helps us stay in touch with our humanity amidst the work, amidst the competing demands, amidst the ongoing adversity and suffering. And so I wanted to use our second practice today to introduce a meditation called Compassion with Equanimity. And this comes from mindful self-compassion, which is developed by 2 psychologists, Dr. Kristen Neff and Christopher Germer. And it's really designed specifically with the caregiver in mind, recognizing sometimes the tensions of having two parties who may both be experiencing suffering. It's really great for moments we find ourselves caring deeply for someone, but also recognizing the limits of what we can do. Those moments where we're noticing and experience suffering and know that we might not be able to fix or solve the issue. And also moments that we need to hold space and compassion for someone else, but also need to hold space and compassion for ourselves. So this is a slightly longer meditation, again, totally optional if you wish to participate. And I will mention if at any point there's distress or you're feeling distracted, it's okay to pause or return back to the breath at any time that you need. So for those who do wish to participate again, I'll invite you to find that comfortable position. Again, feet flat on the floor, hands resting gently into your lap, eyes in a soft gaze or closed, whatever feels right for you. And as we settle into this practice, again, we'll come back to the breath, and I'll invite you to take a few deep breaths in through your nose and out through your mouth. And when you're ready, begin to call to mind a recent caregiving situation. Perhaps one in which you cared for a colleague, a family member, or a patient. Imagine being there with that individual. Allow yourself to get in touch with some of the stress and difficulty of being a caregiver. You might notice feeling overwhelmed or tired. Allow yourself to feel all your feelings, even if they're ones you think you shouldn't be having, like anger or irritation. Just let everything arise. Although we feel we should or are expected to be superhuman, remember we are just that, human. We have our own limitations and vulnerabilities. We are not invincible. To help remind ourselves of this, allow these words of equanimity to drop into your awareness. Everyone is on their own life's journey. I am not the cause of this person's suffering, nor is it completely within my power to make it go away, even though I wish I could. Moments like these are hard to bear, yet I will try to help if I can. Allow those words to settle into your conscious awareness. And as you do, begin to notice your breathing, particularly your in-breath. Notice how that breath nourishes you, gives you the oxygen your body needs. And as you breathe in, imagine that you're breathing in compassion for yourself. You might also imagine a white or golden healing light or warmth filling your body with each in-breath. With each breath in, you are breathing in care and concern for your own struggle and difficulty as a caregiver, giving yourself what you need. Perhaps that's strength, courage, patience, or peace. And now take a few moments to refocus on the person you're caring for, the person who's suffering in some way. Bring the image of this person to mind and take a few moments to reflect on what they're going through. As you do, start to focus on the out-breath. As you breathe out, imagine that you're breathing out compassion for the other, for their suffering and difficulty. You might imagine that as you breathe out, you're filling your body with a golden healing light, using the breath metaphorically to send your well wishes so that they have what they need, whether that's strength, acceptance, kindness, or peace. And then bring together both so that as you breathe in for you. And as you breathe out for them. In for me, out for you. One for me, and one for you. And if you like, you can adjust that ratio. Maybe your own distress or fatigue is coming up. Give yourself permission then to breathe in more for yourself. Perhaps the suffering of the other you're caring for is standing out. In that case, feel free to breathe out more for them, just making sure you always include both yourself and the other in your breathing. In this circle of compassion, remembering that the source of this compassion is unlimited, a vast, boundless ocean, more than enough for you and the person you're caring for. And once more, remember these words of wisdom. Everyone is on their own life's journey. I am not the cause of this person's suffering, nor is it completely within my power to make it go away, even though I wish I could. Moments like these are difficult to bear, and yet I will try to help if I can. Take a moment to return to your breath, feeling the natural rhythm. Notice the support beneath you, the sensation of the chair, your feet on the floor. Begin to invite in some movement, wiggling your toes or fingers. And when you're ready, gently open your eyes or lift your gaze, allowing yourself a few seconds to simply arrive right here, right now, just as you are. Again, thank you for your participation. I did want to make one comment regarding this meditation, because I know some of you are probably thinking, well, this all is well and good, but I may not have 5, 10, 30 minutes in my day to sit down and practice a formalized or guided meditation. And I'd say you're absolutely correct. And what has often stood out for me from going through this sort of meditation exercise on a few occasions is that it doesn't have to be a formalized meditation. For me, there's 2 anchors that I often come back to related to this. One are these 3 lines, which is central to the compassion with equanimity. Sometimes in those difficult moments, I will just kind of remind myself of those words to invite back in that sense of humanness, to attend to the suffering that I may be feeling as well as the person in front of me. Or I'll also come back to the breath, which can actually be utilized in, a clinical or patient encounter or meeting with someone, especially if you're noticing your own emotions occurring or they're really dysregulated, as a reminder to both. And that can also be really helpful just in regulating the situation, as we talked about earlier. Before I leave you and as we wrap up, I did want to impart a few of my kind of tips and tricks, whether for the work you're doing with patients, if you're telling them about mindfulness, or perhaps in your own journeys. I think the first important reminder is to remember that you already have the capacity to be mindful. This is not about acquiring something new. You all have the ability to pause, to reflect, to notice. And developing a mindfulness practice is really about expanding that awareness into daily life and strengthening that capacity. On a similar note, start small, make it doable. I think often the biggest barriers that I hear about are I don't have the time, or when wellness gets attached to something, if it's too time consuming or it's too involved and involves too much effort, it loses its value in that way. And so hopefully we've shed a little bit of light today on how mindfulness can already be added on to activities that you're already currently doing or routines that you have. So I think about, often when I'm walking to my car at the end of the day, that's where I'll invite in some mindful movement or use my senses to connect with what's happening outside in nature. Maybe taking a few mindful sips of your water or coffee before you open that email inbox, or a box breathing round, or a few deep breaths before you answer that page. Using these small moments over time can help to sustain and build a long-term habit. As well as with any intervention, there are always potential pitfalls and risks, and mindfulness is no different. Especially with mindfulness for some people, it can stir up emotions, memories, discomforting sensations. Also, sometimes for some people, the body may not feel to be a safe space, and certain parts of the body can also be triggering, and that's okay. My suggestions are often to monitor your window of tolerance for hyperarousal when you're noticing increased emotionality, distress, agitation, anxiety, or hypoarousal when you're noticing numbness, disconnection, dissociation. And if that occurs, know that that's okay. That's a time to pause, to reconnect with the breath, or to use a grounding tool. And if the body does feel to be an unsafe place or certain body parts are triggering, know that these meditations can be adapted, where we focus more on distant body parts like hands or feet, or use an external anchor. And my very last bonus reminder and tip is to know that mindfulness is not just about being calm. It's about being present with whatever is. You don't have to come in a particular state for it to work. Some days it will come easy, and some days you'll feel restless and distracted. Some days you'll feel really settled after, and some days you'll find that you're just sitting and noticing sense of discomfort and distress. That's all part of it. And that can all be a sense of success and in progress. It's not about changing how you're feeling. It's remembering that you're meeting your experience with curiosity and compassion. So in my final few seconds, I just wanted to share, might have a little technical difficulties, some resources. If I've inspired you to bring this into some of the work you're doing with patients or for yourselves, these are a few great introductory resources, some apps that have some lovely meditations, some courses, and some workbooks or general information. And of course, if you have any questions, you're welcome to reach out to me at any point in time. And my parting words will also be to mention, I think this came up in one of the sessions earlier about system challenges. And I know we're also talking about our own well-being in this session as well. And I recognize sometimes talking about mindfulness, which is a very individual practice, can sometimes bring up tensions and mixed emotions. And I just wanted to provide a caveat that when we're talking about healthcare provider wellness, for long-term sustainability, that is going to need to involve organizational and system change. Though I think all of us here can attest and recognize that that is going to involve a long-term investment of time and patience and a lot of resources that go well beyond those of us in this room. And I think in the meantime, that's where we often focus on those individual measures like mindfulness. I don't wear rose-colored glasses to believe that's the cure or solution, but I think it can be a helpful temporizing or harm reduction measure, if you will. So with that, I'll end there, and I appreciate your participation and your presence, and wish you all a wonderful rest of your afternoon.
Thank you very much, Dr. Riddell. Any questions for Dr. Riddell at all?
Just a quick one. Some say that where you breathe into is kind of important, whether into the chest or into the abdomen. Do you have any comments on that?
Yeah, it's a great question. I think historically I've heard a lot about diaphragmatic breathing and really, noticing if you're filling your, breathing into that space. I find for me personally, and I think increasingly over some of the courses that I've done, that has been less of a focus. I think it's just bringing awareness to, you know, the inhalation and what that means and bringing some intention to it. And I think that might also vary based on someone's comfort in terms of breathing into their chest versus abdomen. So I don't necessarily, you know, when I'm talking with patients about it, provoke a specific. I don't, yeah, it's a good question. I don't know if there's been specific literature around, you know, more diaphragmatic breathing. I think that actually brings attention to trying to fill your chest as much as possible. But I think even, you know, through box breathing, and it's one of the reasons that I chose to evoke that in terms of our experience today, is really just to help slow, right? Bringing intention and being mindful of taking a long drawn out inhalation and exhale just helps to regulate the nervous system.
Thanks very much. Thank you again, Dr. Riddell, and thank you all for being with us thus far. We have one more session, and I'm very happy to introduce Dr. Zainab Mohamed and her presentation on bipolar disorder in primary care. Dr. Mohamed is a distinguished psychiatrist at the Homewood Health Center. She excels in delivering care to patients with complex psychiatric needs in the acute care setting. Dr. Mohamed is one of our Trillium psychiatrists. She has a deep-seated dedication to community and to academic psychiatry. She completed her medical degree and residency training at McMaster University, earning the prestigious Dr. Emile Zamora and Family Excellence in Psychiatry Award for her outstanding performance, leadership, and commitment to advocacy. Dr. Mohamed is a former member of the board of directors of the Professional Association of Residents of Ontario and serves as an assistant clinical professor adjunct in the Department of Psychiatry and Behavioral Neurosciences at McMaster, contributing to the next generation of mental health professionals. Please join me in welcoming Dr. Mohamed.
Thank you all for making it to the end of what is, I'm sure, a long day with lots of learning. I am very excited to be able to talk to you a bit about bipolar disorder. I was just talking with one of my colleagues, Dr. McKinnon, about how this is a population where, of course, things can get complicated very quickly. And while there are lots of things we can do, sometimes these can be really scary cases to approach when things go sideways quite quickly. So I hope that we're able to provide some pearls today that will make things a bit easier in the primary care practice. So I am an employee of Homewood. I don't have any other disclosures to make, and I'm not receiving any honoraria for this presentation. Right. Okay. So objectives today is hopefully developing an approach to managing bipolar disorder in the primary care setting. I will be spending some time talking specifically about mood stabilizers, hopefully equipping you with some more pearls that you can share with your patients to stress some of the importance of appropriate management in bipolar disorder, and identifying when to involve specialists like myself. So we're going to start with a quick review of the bipolar disorder criteria and differential. We will then talk about the approach to treatment by illness phase. I'm going to focus more on kind of general pointers for each of these phases rather than just going through each one of the medications. We'll talk a bit about mood stabilizers, as well as some quick notes on special populations and managing comorbidities. So just a quick review. What is bipolar disorder? So bipolar disorder is a chronic episodic mood disorder that involves episodes of mania, hypomania, and/or depression with periods of euthymia in between. Bipolar 1 is typically mania and depression. We do get the odd patient where we actually can't retrospectively identify an episode of depression, but it's quite clear that they've had mania. Bipolar 2 is a combination of hypomania and depression. It's important to note that this is not a milder form of illness. It can still be quite debilitating because of the proportion of time that patients spend depressed with bipolar 1 or with bipolar 2. We typically do see a return to functional baseline between these episodes, which is one of the key ways that we distinguish between bipolar disorder and other types of psychiatric disorders like schizoaffective disorder. But there is a pretty significant burden of symptoms over one's lifetime. The average age of onset is about 25, and unfortunately, this is a condition where symptoms often do worsen later in life. We do see a large proportion of older adults who've had bipolar disorder throughout their adult years can develop a quite brittle illness as they get older, where, you know, we just managed to treat the depression and now they're manic again, or vice versa. And it is a fairly common disorder, so about 1% prevalence in the population if you combine both bipolar 1 and 2. So mania versus hypomania, just some things to stress here would be that if someone is getting to a point where they require hospitalization, so if they end up in hospital because of their symptoms, or they are experiencing symptoms of psychosis, that automatically qualifies the episode as a manic episode. Even if otherwise their symptoms don't necessarily seem that severe or that bad, or if it hasn't been a full week, they are manic as soon as one of those things happens in the context of other manic symptoms. Importantly, not due to substances or another medical condition. Hypomania, how I often describe this to patients and families is that hypomania looks like you're having a really good week. And that's often what patients experience, is it looks like you're just having, you know, that person is on their game. They're feeling extra confident, extra creative. They're getting lots of stuff done. So hypomania typically doesn't present as a problem to the patient or to the people around them. It just looks like a really good week. The reason, of course, it becomes a problem is because of what it signifies in terms of this person's risk for then becoming depressed. Bipolar depression, same criteria that we use to diagnose unipolar depression for an episode. So of course, knowing that they have a history of bipolar disorder does change our approach to treatment quite significantly. I wanted to spend some time talking about some of the diagnostic pitfalls here. So I find that in the acute setting, a lot of the time we are spending the first phase of someone's admission reassessing their diagnosis. So if someone is coming in with a history of bipolar disorder, part of what we're doing when I'm observing them in hospital is deciding, do these symptoms really fit? Does the history fit? Does the collateral fit with a true diagnosis of bipolar disorder? And there are lots of things that can get in the way. And there are lots of ways that patients end up with a label of bipolar disorder on their chart. And not all of those, unfortunately, are accurate. So one challenge that we often see is that a lot of our patients come to us using mental health terms and clinical language quite colloquially. And I think in some cases, this is maybe an unintended side effect of, you know, we've gone to a point where there's a lot more awareness about different mental health conditions, but sometimes that comes with patients coming in saying, oh yeah, I was really manic last week. I spent a lot of money at the mall. So being really clear when patients are using that language of, was there a diagnosis of mania in your life? Has anyone witnessed this? Did you see a doctor about it? Are important things to double check. A lot of use of the term bipolar as well. Unfortunately, sometimes in not the nicest way or in derogatory ways, but there is kind of an understanding amongst the lay population that bipolar is referring to someone who's really moody or really emotional. And we know that that's not the case. Role of substance use is another really important one. So we often have patients who come to psychiatry with a diagnosis of bipolar on their chart, likely in the context of them doing a number of different things under the influence of substances. So I've had several patients who have ended up with a bipolar diagnosis, but when we look at their history, they haven't really had any sustained periods of abstinence in their adult lives. And it's very, very challenging to make a reliable diagnosis of any mood disorder, but especially bipolar disorder in that circumstance. Bipolar versus BPD is probably one of the biggest questions that we get as psychiatrists of, is this bipolar or is it BPD or is it both? Because both is of course a possibility as well. I would say that that is one that can get tricky, but if we take it back to the core of what is bipolar disorder and remembering that we're talking about sustained episodes here. So what I will often hear from patients is that, you know, they'll have 1 or 2 days where they're really happy and really productive and they don't need to sleep that much. And then they kind of have a bit of a crash after that. That is often keeping within the limits of the emotional dysregulation that we can see in personality disorders, and is often not in keeping with a true bipolar disorder. What I often draw out for my patients when I'm trying to explain the difference is kind of if we make a graph of mood versus time, that in bipolar, we are seeing sustained elevation and sustained periods of depression. Whereas BPD, the emotional experience, if they were to track their moods, is going to look more like a zigzag. So we're not seeing the same sustained episodes of elevated or depressed mood. Again, for people who have both, you can see both, where they're going to zigzag a little bit up here and then have a bit of zigzagging down here as well. But being very clear that we can actually identify that. The other thing, rapid cycling, often gets thrown around as well. So rapid cycling, just keeping in mind that the definition of rapid cycling is having 4 mood episodes in the course of a year. So that's different than someone who is having mood changes on a day-to-day basis. We are still wanting to see some evidence of a sustained episode, or likely for many of our patients, at least a few weeks, but happening multiple. MDD is the most common misdiagnosis, and that's a trap that really any of us can fall into, because it can be really hard to catch if someone has had some subtle hypomanic episodes many, many years ago. It's hard to identify those in retrospect, especially if you don't have access to collateral. So just keeping in mind that it is important to ask about periods of elevated mood and reduced need for sleep, in particular when you're thinking about starting a medication for depression. And then my final kind of pitfall to be mindful of here is to be wary or be skeptical when someone's treatment history doesn't align with their diagnosis. So another common scenario I get is someone in their 40s or 50s coming in saying that they were diagnosed with bipolar disorder in their 20s, but then when we look at their treatment history, they've actually never been on a mood stabilizer, they've never been on any treatment for bipolar disorder. And unfortunately, it's unlikely, not impossible, but highly unlikely that that person truly has bipolar 1 if they have not needed any management for their symptoms and haven't been ending up in hospital or things like that. So that's a situation, again, where collateral, both from loved ones and also from hospital records, becomes quite important.
Sorry, while we're waiting for the technical issues to be resolved, just wondering if anybody has any questions for Dr. Mohamed in the meantime.
Psychosis. So as soon as someone starts to actually veer into actual like grandiose delusions or things like that, or religious delusions, which we often see, then that would kind of automatically qualify them for a diagnosis of mania. So really common ones are people feeling like they've had a spiritual awakening and things like that, connecting with higher powers. That's quite common. The other one that's really common too is people believing that they've come up with some fantastic idea that's going to change their lives and change the world, like curing a disease, or they're going to be a multimillionaire through their new business, even though it's something they haven't really done before this episode of illness.
And for the folks joining online, the question was, what were the 2 unique diagnostic criteria that might lead to the diagnosis of a manic episode, even without meeting the kind of usual number, and the 2 were hospitalization and psychosis. So we have another question over here, Doctor.
Excuse me, Dr. Zainab. We have a question from online as well.
Oh, okay.
We'll do the question.
Okay, you're welcome to go ahead with the online question.
Hi, my name's Tanya Kilmer. I'm just wondering, we talk about, the difficulty in diagnosis when, borderline personality disorder may be present. There's other comorbid things going on, whether it's traumatic brain injury, etc. But I'm wondering, in terms of PTSD, I've seen quite a few clients that have gone through significant trauma, and whether it's 2 years later in life, without having that genetic component for bipolar disorder, they are having hypomanic, either one isolated episode or a couple episodes as a result. So how do we distinguish what is PTSD related, or whether we go ahead and make that diagnosis of bipolar based on those hypomanic episodes?
Yeah, that's a great question. And I think something that I definitely see a lot of as well is there do seem to be a number of patients who experience trauma, have this history of PTSD, and then their presentation ends up becoming quite dysregulated and a lot of struggles with managing emotions, which can often resemble symptoms of bipolar disorder or symptoms of hypomania. So typically what I would recommend in those cases is the biggest question that always comes to mind for me in those cases is whether this is someone who actually has more of a complex trauma picture. So I find that the patients that we tend to see that in are people who have had persistent, repetitive trauma throughout their childhoods or, throughout many years of their lives. I tend to see that less in patients who have your more kind of classical single incident type of PTSD. So I often end up concluding after spending some time with these patients that what we're seeing that looks kind of like hypomania is actually a result of some of the emotional dysregulation that's common in people with more of that complex PTSD picture. And the way that that affects the brain to grow up in some of those more chaotic, traumatic, difficult environments in terms of learning how to regulate. Because I think sometimes when we talk about dysregulation, we are often seeing patients come in because they're in crisis. They're on the lower end of that. But part of that dysregulation too is also the other side of they are going to have periods of time where they're brighter and more impulsive and having a good time, because unfortunately that dysregulation works both ways. They're not kind of recognizing when things are changing in time to intervene. So that is probably a really good situation to have a psychiatrist weigh in, because those are incredibly complicated patients to tease that out of whether this is complex trauma or whether this is truly bipolar.
Now, I don't know if you can comment on how the course of treatment would change if it was a PTSD related hypomania, or like I said, more than one episode, or whether it was an approach where we're diagnosing bipolar. How would treatment change from the entire rehabilitation team, not just in terms of medication, but also from other care providers?
Yeah, so probably one of the biggest things that changes is the role of psychotherapy. So bipolar disorder, again, many things in psychiatry and in mental health we're recommending psychotherapy for. Bipolar disorder, as we'll talk about, unfortunately, there is a role for psychotherapy, but it's unfortunately not going to be your primary treatment for someone with bipolar disorder. Whereas if we are concluding that this is more of a trauma-related picture, then therapy does have a much bigger role to play there. Sometimes there are cases where there's enough uncertainty that maybe we try the medication route. And in that case, I would probably be opting for medications that have some evidence, knowing that all the evidence is fairly weak for helping with emotional dysregulation. So agents like quetiapine, for example, that might also provide a bit of mood stabilization.
Thank you.
We did have one more question, but don't know if you wanted to ask now. Okay.
Okay. All right. Okay. So again, we ended up talking about PTSD and personality disorders. So just a couple other notes on differential diagnosis here. Psychotic disorders are one of the things that we're looking to differentiate from. And again, that often goes back to looking at the pattern in the course of the illness of, is this truly distinct episodes, or are we seeing more impairment, more symptoms throughout someone's life? Medical conditions. So there are a few medical conditions that we wonder about, especially if someone appears to be a new presentation of bipolar disorder, especially mania late in life. We do start to wonder about different types of brain syndromes like stroke. There are a number of different autoimmune conditions like MS that can also result in manic-like presentations. When it comes to substances and medications, some of the most common ones that we're seeing from a substance use standpoint would be things like stimulants. Medications, steroids are a pretty common culprit there. And then the other one that tends to cause some confusion is the whole concept of like an SSRI-induced mania or hypomania, which we'll talk a bit about in a moment. I've included some of the slides directly from the CANMAT guidelines. So a lot of this presentation is based on the 2018 CANMAT ISBD guidelines. So there are some features that we look for that help us figure out if this is someone who might be at risk for declaring themselves as having a bipolar disorder rather than a unipolar illness. So I would say, you know, the patient that I might be particularly worried about, to kind of sum some of this up, is if you are seeing a young person, so late teens, early 20s, with a profound episode of depression. So very, very severe. So having that early onset, very severe symptoms, especially those neurovegetative or reverse neurovegetative symptoms. And especially if you have a young person who ends up, you know, with a diagnosis of psychotic depression, that is someone who should be monitored fairly carefully throughout their life for emergence of a bipolar disorder. Also, again, considering the family history, as that's a pretty strong risk factor as well. So some general comments on bipolar treatment. Combination therapy is often needed. Obviously, in most of medicine, we are aiming for as little medication as possible, monotherapy where we can. In bipolar disorder, we don't necessarily see it as a failure to have someone on multiple agents because that is often what is needed. And you'll see as we go through some of the different phases of illness that unfortunately, part of the reason for that is that a medication that works in one phase may not work in another phase. So we often are relying on combinations to help keep people well. This is a condition that has a very high relapse risk when people are not on treatment, and therefore maintenance treatment is very important. And it's also important that we think about this, and I say we, including ourselves as psychiatrists, to think about the maintenance treatment needs when we start acute treatment. So if, for example, in the inpatient setting, if I start someone on medication that only treats their mania, and then they leave hospital, there's a really high chance they're going to become depressed. And if they don't have a medicine that's going to help them or prevent that, then we've left them in a bad spot. I think something that has become definitely more common in recent years is treating bipolar disorder with second-generation antipsychotics. There are lots of reasons why that has become more common, and some of them are practical. You know, they're a lot easier to start and monitor in a lot of cases. They're less finicky with blood work in a lot of cases. You don't have to mess around with blood levels. And for many of the patients that I'm seeing on acute, these are patients who are ending up in and out of hospital repeatedly, and we end up concluding that they would really benefit from something like a long-acting injectable. And of course, we don't have that option for our mood stabilizers. So it makes sense that these have become more common, but I hope that getting a little refresher on mood stabilizers today will also help you think about those when you're seeing patients who have bipolar disorder in your practice, because they definitely have a role, and lithium remains the gold standard for treatment of bipolar disorder. Something that I really want to stress, similar to what I said at the beginning, is that these patients can become very unwell in a very short period of time. I do some call in the emergency department too, and I have spoken to way too many family doctors who are so apologetic when they have to send in their patient who's depressed or manic. And I'm here to say you don't need to apologize. We are more than happy to see them. We know how quickly these patients can decompensate. So if you're ever in doubt, that is a very appropriate situation to send someone to emerge to be assessed by psychiatry. Patients often ask about what they can do that isn't medication, because unfortunately, it's not always the best news for patients when we tell them that medication is really considered an essential part of treatment for this diagnosis. So if you have a patient who's motivated and wanting to try some other things, all of the general advice that we give in other disorders still applies. So optimizing sleep, nutrition, exercise is important for improvements in depressive symptoms. Education is a really important part of things. And when I have people in the inpatient unit, I often talk to them about what I call the 3 S's of relapse prevention. So stress, sleep, and substances are the things that often put people at risk for relapse. Stress management, of course, is difficult for most of us. But what I tell my patients and families is, you know, are there ways as we transition back to your regular life that we can take some things off your plate or make things more gradual? Sleep, we are typically aiming for a minimum of 6 hours a night to help prevent a relapse. More is obviously better. But if I am seeing someone who has a history of bipolar disorder and they tell me that they've only been sleeping about 4 or 5 hours a night for a couple of weeks now, in my mind, we are heading into the danger zone. And that's a time where it might make sense to be a bit more aggressive with your prescribing and think about sleep medications that we otherwise might shy away from, like some of the sedative hypnotics. knowing that that would be kind of a short-term intervention over a couple of weeks because stabilizing their sleep might prevent them from going into a full-blown episode. Psychotherapy can be helpful, but it is not an alternative to medication, unlike MDD. Dietary modification, I have had a number of patients over the years ask about the keto diet. I'm sure there's something out there that is telling people that if they go keto, maybe they don't need to take their meds anymore. Unfortunately, that is not the case. So there is not sufficient evidence for keto or other diets to show that that would be a viable alternative to medication. There is some very weak evidence that omega-3 or N-acetylcysteine supplementation may have some benefit in terms of symptom severity. Again, that's not going to be enough as a standalone, but if your patient really wants to try something like that, that would be a reasonable low-risk thing to add on to usual care. Okay. So mania and hypomania, to talk a little bit about those, they're treated basically the same way. Like I said, we want to treat any sleep disturbances aggressively, because if we are intervening when we're starting to go into a mania or hypomania by stabilizing sleep, we can prevent things from getting worse. We also want to get to a therapeutic dose of medication as quickly as possible if you suspect that someone is tipping into mania. So a common thing I see in the outpatient setting is we might suspect someone is going manic, and then our typical practice in outpatient is to be fairly gentle with the way that we're titrating things. This would be a time where you don't want to be so gentle. So knowing that if you're planning to start quetiapine, for example, you want to be getting into the hundreds of quetiapine relatively quickly, rather than staying at 25 or 50 for an extended period of time. And it's also important to screen for mixed features. So that mixed features, when people are manic, they can also have feelings of distress, suicidal ideation, things that don't normally go with mania. And if someone has mixed features, they are at elevated risk for suicide. The way that that often presents is if they're depressed with mixed features, it kind of looks like an amped up depression. They have all the emotional state of a depression, but all the energy of someone who's manic. And I'm sure you can see how that could be a dangerous combination. In terms of antidepressant-induced mania, so just a quick note on this is that there is some controversy about whether someone who has a unipolar depression could really be tipped into a mania or hypomania without having some degree of underlying bipolarity. So in general, we're quite suspicious when someone becomes manic or hypomanic on an antidepressant about whether they actually have bipolar disorder. Most of the antidepressants we're using do not have very long half-lives. So if someone starts an antidepressant, becomes manic or hypomanic, and they're still presenting with those symptoms several weeks later or more than a week later, that is a situation where it'd be quite suspicious, again, for an underlying bipolar disorder. You also might want to think if someone has a family history of bipolar disorder, looking at agents that have a lower risk of manic switch. So a common kind of culprit here are TCAs, are some of the higher risk agents for switch. And I know we're not commonly using those to treat depression, but many patients end up on them for a variety of reasons, especially chronic pain and sleep. So just being mindful of those as well. Substance-induced mania. So the DSM actually tells us which substances they think can induce mania and what qualifies for substance-induced diagnosis. I would say as an inpatient psychiatrist and in the emergency department, I think many of my colleagues agree, cannabis is a pretty notable absence from this list. I expect that at some point in my lifetime that will be added to this list because there is a lot of emerging evidence to show that cannabis use appears to be associated with an increased risk of mania. That appears to be separate than just the risk of psychosis. I know there's been a lot of buzz and a lot of talk about cannabis-induced psychosis, but people are also developing non-psychotic mania with use of cannabis. And that seems like something, again, anecdotal at this point, but we do see a lot of cases of that or what appears to be cannabis-induced mania in hospital and in emerge. And of course, cannabis is still going to be very high risk if someone has a known bipolar disorder. So typically I am telling my patients with bipolar disorder that they should be staying away from stimulants, recreational stimulants, and that they should be staying away from THC because it does seem to be a fairly significant risk. So the bipolar guidelines, if you ever pull them up, they have a bunch of these lovely tables, and I'll just kind of talk a bit about how these recommendations are used rather than going through each one. But basically, this is a ranked list of treatment recommendations. So when they're talking about first-line treatments, they are ranking lithium as your #1 option for the treatment of acute mania. It's not that all of these first-line options are equally effective or equally ranked. They also helpfully show you if those medications are still helpful as maintenance treatment to prevent depression or prevent mania moving forward. So that's why lithium ends up being so highly ranked across phases of illness, because it is helpful both in acute episodes and in preventing depression and mania moving forward. Something that I will mention, just because it's not common, but it does happen, is that ECT is also an option for the treatment of mania. We do sometimes have patients who end up needing ECT because they're not responding well or they're not responding fast enough to pharmacotherapy. A note on antipsychotic monitoring, because mania is the phase of illness where likely a lot of these antipsychotics are getting introduced, is remembering that our patients with bipolar are still at very elevated risk for metabolic syndrome and elevated risk for cardiovascular mortality. So monitoring is important. Typically, we're looking at A1C, lipids, prolactin as needed. So if your patient is complaining of specific symptoms like galactorrhea or gynecomastia, getting a prolactin. And then also looking at BMI, weight, waist circumference. We often, I know as inpatient psychiatrists, recommend that people also get monitored for emergence of EPS. So if you're looking for tools to incorporate that, many of you have probably heard of the AIMS. A tool that I wanted to plug a little bit is called the DIMES. So this was developed by psychiatrists with Early Psychosis Intervention Canada. So if you are interested, if you want to pull this up on your phones to look at later, the website is epicanada.org. And they have a PDF that shows you how to do the EPS exam and how to monitor and score that over time so you can track for changes. The reason I really like this tool is because it's pretty concise. It only takes a few minutes to do the whole exam. So I feel like that's probably a better fit for the primary care setting. And it's the tool that I like to use as well, just because it's very easy to commit to memory and do very quickly in a visit. Depression. So just to kind of drive home what I said earlier, bipolar 2 is not mild bipolar. So these pie charts are looking at symptom burden over someone's life in bipolar 1 versus bipolar 2. So green is the amount of time that people are spending asymptomatic, which admittedly is a greater proportion of the time in bipolar 2. But if we look at the burden of depressive symptoms, it's quite similar between both illnesses, and people are spending about half their lives depressed after they get a bipolar diagnosis, which is a significant chunk of time. So just remembering that bipolar 2 is not a milder form of illness. General approach to depression is pharmacotherapy is essential and psychotherapy is adjunctive. We want to screen really carefully for suicide risk, psychosis, and substance use. I would say, unfortunately, many of the patients that I worry about the most when it comes to suicide risk are patients who have bipolar depression, again, because they can become very unwell in a very short amount of time. And sometimes it can be quite effortful to find the right treatment combination to get someone out of a bipolar depression. It can be quite severe. There's often a high burden of cognitive symptoms in bipolar depression. So people will often complain of feeling slow or foggy, that kind of pseudo dementia type picture. Some of the medications we use in bipolar disorder can also contribute to that. So lithium, for example, of course, very effective treatment for bipolar, but also does come with a side effect of cognitive dulling, especially when we are using higher doses and people are being maintained at a higher serum level. And as like most things, we want to restart any previously effective medications if they'd been discontinued in the interim. Something I find interesting when we look at the rankings is that you saw how long that mania list was of options you have. And this list is a lot shorter. And that's mainly because most of the antipsychotics have disappeared. And this is what I mean is that difference between what works for one doesn't necessarily work for the other. Something to note, I know Latuda or lurasidone is an option we often use for depression or recommend. It is a challenging one unless you have a pretty reliable patient who's very good at following the instructions for their meds, because it has to be taken with food. So if people are not getting at least 350 calories, including some fat, with their dose of lurasidone, they are only going to absorb about 30% of the dose, which is not going to be enough to treat them or keep them stable. I have seen some psychiatrists, some of my colleagues, because of that, will actually compensate for that and prescribe a much higher dose of Latuda because they know that their patient is not going to be eating enough. I think it is often easier to just opt for a different agent and kind of keep Latuda as your last resort if you don't think your patient is reliable enough to consistently eat when they take their medication. We should also be mindful of some of the minimum doses here. So quetiapine, if you're trying to treat an acute depression, we want to be getting to at least 300 milligrams most of the time. Lamotrigine, we are titrating to 200 milligrams. And a little plug for lamotrigine, because I think that's one that's underutilized a little bit. And part of the reason for that is it has a reputation for being very slow. And I think that's because we all think, well, it's going to take weeks and weeks and weeks to get you up to your 200 milligrams, and we don't have time to wait. The research on lamotrigine, when we look at how quickly people respond, is not really that different than how long it takes for people to respond to antidepressants. So the way I see it is if the severity of what's in front of you, if this was a unipolar picture, if it would feel reasonable to start an antidepressant, it's also reasonable to think about lamotrigine. Lamotrigine is a medication where, of course, we have some scary side effects, which we'll talk about, of that SJS, but otherwise it tends to be a really well-tolerated medication once people get through that titration period. So it's a good one to keep in mind. So why not just put people on antidepressants when they're depressed? They should not be the go-to because they have a risk of worsening some things in the course of bipolar. They are an option. They're a second-line option in the guidelines, but they do have a risk of that manic switch, a risk of causing rapid cycling, and also they just don't seem to be as effective as our other treatment options. So the effect size is overall smaller compared to the other treatments we use for bipolar depression. If you are going to reach for an antidepressant, it is likely safer to do so in bipolar 2 rather than bipolar 1. And there are some specific antidepressants that are recommended in bipolar 2 as second-line treatments, which are sertraline and venlafaxine. Okay, and then finally coming to maintenance. So generally to maintain, once we're kind of out of the woods and the mania or depression has been treated, we want to continue whatever they were on that worked. There is a slight caveat there with some of the antipsychotics. We can often lower doses when the acute episode has resolved. So someone might come out of hospital for mania and they needed 20 of olanzapine to keep them well and sleeping. And if they're staying well over the coming weeks, it would probably be reasonable to see if we can come off of that, especially if that was an adjunct to a primary treatment like lithium or divalproex. This is a high-risk time for medication non-adherence. We see this all the time as psychiatrists, and I'm sure you see it in your practices too, of patients who have been medicated for bipolar, and eventually, you know, they've been stable for a few months, a few years, and they start to wonder, like, do I even have bipolar disorder? Do I really need this anymore? And unfortunately, the answer is yes, they still need it, but it's easy to forget that when you're not experiencing symptoms. So it's important to stress to patients that by preventing future episodes, we are protecting their brain. So there is a concept of neuroprogression in bipolar disorder, where we know that each mood episode is essentially another insult to the brain. It makes it more likely that you are going to have future episodes, that those episodes are going to be more severe, longer, and harder to treat. So by preventing the episode now or next year, we're also protecting their brain 20 or 30 or 40 years from now. Some resources to pass on to your patients and their families would be, there is a patient and family guide to the guidelines that goes through a lot of this. And then CAMH also publishes a series of information guides for patients that I find are really well written and accessible. And they do have one on bipolar disorder that's available as a free PDF that can be accessed online. This is also a really good time to think about psychotherapy with your patients. So if someone, like I said, is on an adjunct antipsychotic with a mood stabilizer, we don't really know what the benefit is or if there is a benefit to continuing that past 6 months beyond the acute episode. The other medication I'll point out here is the absence of cariprazine. So when these guidelines were published, cariprazine was kind of the new kid on the block and got a lot of press and was one of the ones that we were drawing attention to as a new treatment option. There still is not enough evidence to know whether or not that's an effective maintenance treatment. Again, I'll leave these kind of for your reference. And finally, I'm just going to talk a bit about mood stabilizers and likely leave the special populations and comorbidities as reference for you. So lithium is still the gold standard for bipolar disorder. It is neuroprotective, so there's some evidence about reducing dementia risk, and it's also anti-suicidal. So again, a great option when you have that really scary bipolar depression in front of you. If someone is in an acute episode, we're looking at a range of 0.8 to 1.2. For maintenance, we're looking at 0.6 to 1. If you can stay on the lower rather than the higher end of that, that is better, because the higher someone's lithium level is throughout their life, the higher the risk is of them developing things like renal problems as time goes on. So there's not necessarily a benefit to being at 0.9 versus 0.7. Sometimes it's tricky though, because sometimes you increase lithium by 150 and the level jumps up a lot more than you think. So it's not always doable. We want to be checking thyroid and calcium as well as renal function. And you want to get a new level 5 to 7 days after a dose change, or every 3 to 6 months if their dose is stable. Obviously also getting a level if they're showing any new symptoms that make you worry about lithium toxicity. Important to talk to patients about what to do if they're sick. So especially if they have gastro, they have vomiting, they have diarrhea, that is a good time for them to hold their lithium until that resolves. Ideally no more than a couple days, because that is a high risk time for lithium toxicity. Making sure they know to avoid NSAIDs. I had many patients who kind of forget about that over time, and they come in taking lots and lots of naproxen for their foot, and they keep feeling worse and they don't know why, and it's because their lithium level is running quite high with that. I usually tell my patients that anytime they're prescribed a new medicine, if they're taking lithium, they should talk to their pharmacist, because there are a number of interactions, which is hard to cover every time we talk to someone. And we should avoid stopping lithium abruptly, because there's some evidence to show that that may actually worsen the course of illness and make it more likely for them to relapse. So whenever we're getting people off lithium, which is not always in our control if our patients choose to stop, but if we can help them, then ideally we want to taper them over several weeks. So some of the medications that influence lithium levels are here for your reference. Side effects, I know we've touched a little bit on. Some other ones to think about would be weight gain, unfortunately, is fairly common with lithium. Thyroid disorders are also important to monitor for as well. And tremor can happen in about a third of patients on lithium. Acute versus chronic toxicity. Acute toxicity, we're often seeing a lot of the GI upset, like the nausea, vomiting, diarrhea. Chronic toxicity is often those patients who maybe were started on lithium many years ago, they're getting older, their kidneys are slowing down, function is going down, which means their lithium level is slowly creeping up as time goes on. And those patients often end up with neurologic symptoms in relation to their lithium level. So things like ataxia, tremor, hyperreflexia. I just had a patient who's been on lithium for about 20 years, and she came in and her lithium level was 1.3, and she certainly did not present with your classical features of lithium toxicity, just because that had been slowly building up for such a long time. When to involve nephrology if you're worried about someone's kidney function on lithium. So the guidance that we get from NICE in the UK is that if their eGFR has declined more than 10 points in 5 years, or more than 5 in 1 year, that's a good time to consult nephro. Or if their eGFR is less than 40, of course, if there are other features that are making you concerned, also fair, and also in the guidelines to consult nephro if you're worried. Risk factors for CKD, like I said, is maintaining a higher serum level. So we want to stay in those targets as best we can, and using multiple daily dosing. So an easy way to reduce someone's risk is just moving to once daily rather than BID dosing of lithium. Yeah, valproate. This is another one where if you ever have patients who tell you that they want to take something natural, lithium is a nice one because it's a salt, it's on the periodic table. Valproate is also derived from natural sources. So it comes from valerian, which is this plant here. So that's another maybe selling point for some of your patients. Divalproix and valproic acid are both equally effective. Divalproix is a little bit gentler on the stomach, which is why it's more commonly prescribed. It is more effective for mania than depression. Once daily dosing is sufficient for mood disorders. So often if you're going to like a standard reference of how to dose valproic acid, it will tell you to do BID dosing because that's how it was established for seizure disorders. The same is true for our lab values, and the lab ranges are established based on seizure disorders as well. But we don't need to do BID dosing if someone does not also have a seizure disorder. And we know it's more likely that they're going to adhere to their treatment when it's once a day. We should be cautious when combining with lamotrigine because it does increase lamotrigine levels. Monitoring requirements are not so heavy for valproate, so looking at liver enzymes in a CBC every 3 to 6 months. And that's because the risk of hepatotoxicity, it can also affect platelets. And then we also watch out for pancreatitis and teratogenicity. So this is one of those medicines that is unfortunately a hard no in pregnancy because it is highly teratogenic. Lamotrigine, just to talk a little bit more about, it does take time to titrate. The reason that we have those standard titration schedules, which I'll show you in the monograph, if you look on UpToDate, it'll tell you exactly what to do. But we have to do that because it minimizes the risk of SJS or Stevens-Johnson syndrome. One of the perks of lamotrigine is that we don't need any specific lab monitoring. So we just basically need to warn them about SJS, rash, things to watch out for. And usually once you get through those initial weeks, it's kind of smooth sailing after that. It also has a pretty low metabolic burden. People don't tend to gain a lot of weight. It's another great advantage compared to many of the options we have. The target is 200 milligrams a day in divided doses. And just note that there is an interaction with oral contraceptives. So they can both make the other less effective. So that's a good time to involve your pharmacist or involve a psychiatrist. That's for your reference, just one of the titration schedules there. Okay, so I'm going to leave things there that we have some more time for questions. There are some slides, just some quick notes on special populations and comorbidities to take a look at as well.
Very much, Dr. Mohamed. I know we had one question in the room. Was the question answered during?
Thank you. My question is, if you have someone coming in with pretty significant depression and trying to rule out bipolar before probably starting like an SSRI, and you're not entirely sure about it, if you're sort of leaning towards probably not, and you've started an SSRI and it doesn't seem to cause any hypomania or any issues, my first question is, does that effectively rule out bipolar as something that they have? And then my second question would be, if you're a little bit more worried about bipolar potentially, would you start like something like lamotrigine first for a little while and then add on an SSRI? Would that be like a safer way to address their depression?
So those are great questions. So certainly being on an antidepressant and not tipping into a mania or hypomania is a good sign when it comes to that risk of this person having underlying bipolar, but it's not a for sure thing because the SSRIs and SNRIs in general don't have a huge risk of precipitating mania or hypomania. If they're on an agent like a TCA at a therapeutic dose for depression, then that might convince me a little bit more that, you know, if I'm seeing someone who's been on a TCA for years and years and they've never had hypomania, they've never had mania, again, it's a lot of points in the direction of this probably isn't bipolar, but we wouldn't ever be able to say 100% this is never going to declare itself as bipolar disorder. In terms of lamotrigine, I think your standard management is probably fair to just try the antidepressant. If you still have that little bit of doubt, what I would likely do is just counsel the patient and family on, you know, if you're starting to notice things like the mood is changing a lot, you're not sleeping and you don't feel tired, just knowing those red flags of when to come back to be reassessed, I think would probably be fair rather than kind of diving into other types of medications.
We have a question from online. All right. Okay. So this is from Danuta, and she's inquiring about evidence on the effectiveness of cariprazine in bipolar 1 disorder.
So cariprazine is one of the treatment recommendations for bipolar disorder. The caveat there is that it does not have an official recommendation for maintenance treatment. So it is one of the options for mania. But unfortunately, we don't have enough evidence right now to know if that's going to be something that will help keep people stable long-term.
Great. And Marita, any further questions from online? Great. Well, thank you again, Dr. Mohamed, for an outstanding talk. Okay, well, thank you all again. That wraps up the day. Just a quick reminder for the family physicians that are here, which is most of the audience. 6 main pro credits, I believe. The team will be sending out certificates of completion, I believe, via email, and I'm hoping for a nod of approval. Yes, perfect. Yes, that is the plan. You'll be receiving a certificate of completion for your main pro credits via email. Also, if folks are interested, please take the centerpieces home. It will save us from bringing them back to the health center. And I do think that they're beautiful. And again, thank you again for your attendance, your participation, and hope to see you all again next year.